Hello, hello. MRCOG Pakistan educational activity. Today's activity is the part of the series of educational activities of MRCOG Pakistan, which are started by Professor Nazli Hamid, Chairperson MRCOG Pakistan. The theme of today's activity is MRCOG and Beyond, and the main aim of today's activity is to educate and guide our young doctors about NHS system and improve their understanding of UK training system. Today's activity is also a part of our pre-conference workshop of our next upcoming conference of 7th International Conference of Shalimar Medical and Dental College, Sharing Solutions. Today, we are honored that Dr. Wasim Lodi, LGC Chair, has joined us from UK. We very warmly welcome our highly supportive Professor Arif Jamal, who is former Chair MRCOG Pakistan. We are thankful to Professor Rehana Rahim, who has joined us from Lady Reading Hospital, Peshawar, to facilitate the session. And we are thankful to Dr. Nikat Ali Shah, who has joined us from Karachi. We are thankful to our Chief Operating Officer, Dr. Aisha Numan, for her administrative support. Now we will formally start our session with the recitation of Holy Quran.
والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون فما يكذبك بعد بالدين أليس الله بأحكم الحاكمين.
Now I will invite Dr. Aisha Numan, Chief Operating Officer, Shalimar Hospital. Dr. Aisha Numan is very dynamic and enthusiastic lady. She is always supportive for all academic activities in Shalimar Hospital and had a very vital role in our recent recognition of urogynecology subspecialty in Shalimar Hospital. Dr. Aisha, please join us.
I'm sorry, I was late. Assalamualaikum, Mr. Arif Jamal, Associate Lodi, and my dear colleagues, and especially Dr. Nazli, Dr. Shahrizad. It's really an honor to host this session, and interestingly, Dr. Nazli has been doing so much, and I'm really proud of her that she has been able to take Shalimar Medical Dental College and Shalimar Hospital to the next level. And I'm really grateful that to her and to her team as well, and especially to the August in MRCOG. So we she would be, inshallah, taking the MRCOG, and with her efforts, she told me that 3 of the MRCOG trainees, they have got induction there in the MTI program in UK. So we hope with her Eurogynae initiative as well that she has been given the chance to move in the second fellowship program. We hope to get the inductees in that program as well. Thank you so much, Dr. Nasli, and good luck to you.
Thank you, Dr. Aisha. Now I will like to invite Professor Nazli Hamid to give update on all academic activities by IRC RCOG Pakistan from July 2022 to date. Dr. Nazli Hamid is urogynecologist, IVF consultant, and medical educationist. She has been awarded National Talent Scholarship twice and 13th gold medal during her academic career. She is current chair IRC RCOG Pakistan. She is a member of Asia Oceania Federation Urogynecology Committee. She is vice president Punjab Pakistan Urogynecologist Association, and she recently got Shalimar Hospital accredited for second fellowship in urogynecology. This is the first hospital in Punjab to be accredited for any subspecialty training in ops and gynae. Dr. Nazli, please.
Very good morning, and thank you very much, Dr. Shehzad, for your kind introduction. So today, I shall just briefly update you on what I've tried to do so far, and how the college is responding to that, and what we aim to do in the next few years, couple of years that I'm here in this position. Okay. So, the main challenge that you face in this position is a very strict confidentiality policy of the Royal College, because they don't want to share with you the names of and the contact details of the people whom you want to approach and address and communicate information to. So you have to reach a wide audience without actually knowing where those audience actually are and who they are. So that was the reason that I decided to create a Facebook page, IRC RCOG Pakistan Facebook page. And this is the advantage that we, as we are progressing in the newer times, so we have got this digitalization and social media, which helps us spread awareness. And I use paid promotions so that the messages that we are publishing should reach a wider audience. Because once I just posted them in different professional groups, I felt that they were not as widely disseminated. Not because people don't want to disseminate them, but because probably the people who are there in those groups are not the primary target audience. They are not the primary people who are going to be affected by these changes. So the main target audience is not present in our professional groups. So I decided to get these posts published and promoted. So the activities which we have done so far was the first activity. This was career pathways for Pakistani doctors in the UK. And this was conducted by one of our local esteemed faculty members. And I also gave the updates, like today I'm giving you the updates. So the first one I gave here, so that people should come to know that what is being done and what is the strategy which is being followed. So a lot of interest was generated here. And then I decided to, I recorded this event, and then I created a YouTube channel and I uploaded the recording on that YouTube channel, so that those people, we know that we are all busy people with our own busy calendars and diaries, and all of us may not be able to join at one particular time, even if we are interested to do so. So that's why it was vital to have the recording available and then disseminated to wider audience. In the second meeting, Dr. Wasim Lodi was very, very kind. He's the LGC chair, and we will give his detailed introduction once he's coming to the talk. But he has been very, very supportive in all these activities, and even today he's with us. So he focused on MTI scheme awareness and interview skills. And most of the our students, they don't know the details of MTI. This is medical training initiative by NHS. So, and it is not only applicable to OBGYN, it's also applicable to other specialties. But we are obviously directly focusing and more conscious about, OBGYN. So interview skills was again a broad topic, and similar topics are included in these 2 days, this 2-day symposium, which are broad topics. How should you prepare your curriculum vitae? How should you prepare your for an interview? What to expect when you are going for a job. So these are generic topics. We are generally focused about reading a subject. हमारे लोग एक सब्जेक्ट की डिटेल्स में बड़े अच्छे होते हैं, OBGYN की किताबें उन्हें रटी हुई होंगी, but they don't know how to, these softer skills कि आपने अपना CV कैसे prepare करना है, आपने इंटरव्यू कैसे देना है. So those are the areas which probably needed more polishing. So a lot of interest was suddenly created in the MTI, and then we decided to hold a dedicated talk on just an MTI, and this is the MTI team of the Royal College, headed by Nitin Samaraj and the MTI officer, Mr. Sanjay. So they came on board with us and they participated in the third activity directly, and a lot of queries were addressed. And again, the recording was uploaded, and this is the poster from this activity where you are sitting right now. So this activity program was shared with the Royal College, and I just wanted to share this. This is the feedback from Hari Thakur, who's the current president of Royal College. And fantastic program. Thank you to all who are involved. So it is a congratulations to all of us, to all of you who are contributing to make this success. And again, this is by the educational facilitator. It's a packed program, and you should get a good audience. So it's really not very easy to get appreciation from international authorities and dignitaries. So the efforts bore reward here because 3 of our MTI candidates got selected in these 3 prestigious positions. And I feel that I've contributed here because these candidates approached me when they were shortlisted. Once you are shortlisted for MTI, you are given a date for interview. And when they were selected for interview, they started reaching me out, sending me WhatsApp messages that we have got our interview. Please help us, please guide us. How should we prepare for the interview skills? So I shared the videos, that we had recorded, including Dr. Wasim's video, and I said, please go through these videos first, and then if you have any questions, please come back to me. So they went through these videos, and once they were selected, they sent me an email, thanking me that these were very helpful and they actually helped them. So it is actually very rewarding when you see that you are giving back to the system. We have reached a stage of maturity where probably we won't be progressing much from here onwards, but we want to give back to the society. So once you're giving back to the society, this is really a very positive reinforcement. I also want to share this statistics for the upcoming MTI round 2023, for which applications have been filed. And please note, Pakistan has filed 20 applications this year, so we have topped this list. Out of 77, 20 applications are this time from Pakistan. We always topped from the bottom. This is the first time that we actually topped here. So again, and what is very important is that most of these applications were complete, with only 2 where IELTS result was pending. Ineligible were only 2, and incomplete application only 1. So majority of them were complete applications. So this has been applauded by the college, and they say that the awareness campaign certainly seems to have a huge impact on the number of applicants, and it's all thanks to the hard work. So it's not a hard work by me. I'm the person probably who is in the limelight for good or bad, but it's the hard work by the entire IRC. The IRC, which has its legacy in people who are as senior as Professor Rashid Rafiq, Professor Shafiq, Dr. Sadka Jafri, Dr. Khalda Bindi, Professor Rubina Hussain, Dr. Arif Zaman. I just had the honor of being a pupil with them, when they were heading this chair. I learned from Professor Rubina Hussain in 4 years of my tenure as a member with her. I learned a lot from Professor Arif Zamunjuri when I was working with him as a fellow, and I certainly wouldn't have been able to give any of this performance, if I was not guided by these very senior people. So about the RCOG examination information, I want to take this opportunity to let you know that MRCOG Part 1 and 2, the next examination is due in January, and for this already you have, those who have wanted, they must have been preparing now. And 169 candidates have filed application for Part 1, 176 candidates have filed section Part 2, and this is the highest ever application this time from Pakistan. So again, this is a contribution, but the aim of having this activity is not just to have the highest number filing, but the highest number passing. So that should be our target, and that is what we want to achieve in the long run. For the MRCOG Part 3, the immediate next term is due in February 23, and 81 candidates have registered from Pakistan. For the May 23 examination, the center is being planned. Assessment of training will close on 23rd of January. So please disseminate this information that all those who are interested in the next round for MRCOG Part 3 should get their assessment of training done by this date. And booking will open in the end of February 23. We have been taking initiative for inviting examiners from Pakistan for MRCOG Part 3. Not just because it's a feather in their cap, it's just because when we are exposed to their system of MRCOG Part 3, we as examiners are more aware of what we are supposed to ask and what the Royal College expects from the candidates, we will be able to guide our trainees better. So this is basically, and the college is very receptive, and there are many things which are being discussed with the college. I've just pointed out things here which are probably going to be materialized soon. And about conducting MRCOG Part 3 examination in Pakistan. So appreciating what we have done so far, the college has been very, very kind in a recent meeting that they gave a 50% reduction in Part 3 courses run by the college for the upcoming batch of 10. So the first 10 applicants, if you route your application through the IRC chair, you will get a 50% reduction on the £990 fee, which is substantial. We are going to plan, we are planning and we are going to run MRCOG 3 courses at a much subsidized rate online very soon. But till the time that we start doing that, I think this is a very, very good opportunity, and it's not easy to get a financial rebate from an international authority. It actually means that you have probably proven that you are genuinely interested. So the current members, statistics, the fellows, as of now, we have 100 fellows from Pakistan, we have 98 members from Pakistan. The retired fellows are 22, associate fellows are 75, and I will be stressing on what are associate fellows. So associate for doing an associate fellowship, you don't have to be MRCOG or FRCOG. Any gynecologist can apply for an associate fellowship, and if you are an associate member, you will get all the educational benefits. You will still be getting the updates, educational updates, the access to CPD portfolio. So it's actually worthwhile. It's important to note that out of the total RCOG members, 47% are outside the UK and 22% are based in the Asia region. So we are, besides India, we are a substantial majority, and our contribution is valued by them. These are the membership transformation projects by the college. Associates, I've already told you that associates, you don't have to be an MRCOG, FRCOG to be an associate member, and you will have an access to RCOG news, best practice OMG guidelines, RCOG library, and access to journals, discounted rate for RCOG learning, CPD e-portfolio, training e-portfolios. It's very important now that we are talking about e-portfolios and our students are going there for MTI. If we are not aware of e-portfolios and if we don't help them prepare those e-portfolios, obviously their chance of selection is going to be compromised. So it's important that our supervisors should have at least associate membership to be aware of these things. And obviously then you become a part of a global community of ops and guidance specialists, and you can participate in RCOG courses and events at a discounted rate. So this is very interesting. They have launched an 3D package which is for allied health professionals. So again, this is very important because our allied health professionals, their role in our medical care cannot be underestimated. And it is as important to update them with the latest knowledge and techniques as it is for the doctors. So it is a golden opportunity, and we will work certainly on this to increase this membership. Elevation to the fellowship from member to become a fellow, it doesn't happen automatically. You've got to fulfill a certain criteria, and you've got to fulfill certain prerequisites to be able to do that. And recently we have elevated one of our members to fellowship. We have discussed the subsidized rates for retired fellows and members so that they are not deprived of the right to vote and being an active member of the community. At the same time, they should get a subsidy on the amount of fee that they're paying. So this is particularly important for the students who are sitting here. Now they have started medical enrolling students in the fellowship program, which is a much discounted rate. So medical students who are interested in ONG, they can also get a membership right today when you are just sitting in the medical college, and you can engage with the British Undergraduate Society of ONG. So that is very important because pre-assisted learning opportunity that you get in this way is probably that cannot be compared with what we deliver here as sermons. Probably that is not as effective as you learn from your peers and your age mates. So for the growth of those senior colleagues who want to be members of the college, but they want something more than that, what they are already getting. We are discussing peer-to-peer engagement and subspecialty training programs, and the college is probably going to start very soon a 4-weekly observership for our doctors. Obviously, for hands-on training, the GMC registration is another thing, and you need to fulfill certain more criteria, and not everybody can get registered there. So an observership is still better than doing nothing and not being exposed at all. In the collaboration framework, a liaison program for standardization of training, especially in the scenario of like we have got subspecialty training started in Pakistan in urogynecology, and the Rani Thakur herself being a urogynecologist. So I requested in the last meeting for contribution so that we can standardize the training which we impart here should be closer to the global standards, and involvement in a multi-center research program. And we have already sent a proposal to them on what research we can start on. So a collaborative presentation was made, and RCG was very generous. They created a donation cell. An email was sent to all fellows and members to spread awareness, and they are collaborating with the Hoover Foundation at the moment for ongoing rehabilitation of flood-affected victims. So all the activities, like I said, that I had an honor of being with Professor Rubina Hussain and being with Professor Arif Jamul, and that helped me, really pick up the right momentum because I wasn't completely unaware of what was going on. So in the same spirit, I want that the leadership continuity should be maintained. I'm regularly keeping a record of all the activities. I aim to pass them on to the next IRC chair after completion of my term, so that the next year can capitalize on what humble achievement I might be able to make, and to visualize what needs to be done next. And then, Dr. Arif, I want to thank you especially because you trusted me, and you actually, probably mentioned those qualities which I don't even think exist in me. But I certainly have a couple of qualities, and they are sincerity of purpose and reciprocating positivity with 100% interest. Thank you so much.
Thank you, Professor Nasri. Now we will have 3 talks by Dr. Wasim Lodi, which will help our doctors to understand structured organization of NHS and training system in UK. Dr. Wasim Lodi moved to the UK after postgraduate training in Pakistan. He then did CCT in Obs and Gynae in UK. His special interests include outpatient operative hysteroscopy and medical education. He is involved in various teaching activities with RCOG and ART internationally. He is an undergraduate and postgraduate examiner. Currently, he is regional champion of MTIs in North, Central, and East London. He is a panel member from UK in specialty training, recruitment, and interviews. He is a mentor, trainer, and holding courses and interview oriented skills, basic practical skills, on technical skills and human factors contribution in making errors. He has co-authored many research papers and a video book, How to Perform Operative Procedures in Ops and Gynae. This book won the Best Book Award in Gynae and Ops category in 2021. He is passionate about creating opportunities for professional development of colleagues in UK and Pakistan. Sir, please join us.
Assalamu alaikum, everybody. First of all, I would like to thank Professor Nazmi for giving me the opportunity to come here. And it is always a pleasure to come back to Pakistan and pass on to my colleagues whatever I have learned over the last few years. This is, I think, my third activity, I would say, as when I've been invited. Prior to that, when Professor Sudhamar was IRC chair, he suggested to go to Peshawar, so Dr. Rehana hosted me over there. We had a very good session for MRCOG preparation over there. And before that, I was sent by Royal College officially for Part 2 MRCOG course, which was run by Professor Rubina Hussain. I'm grateful to all of you, and every opportunity I use it to learn myself whenever I come back here. Now, these next 2 days, they're very different from what you would have experienced before. Now, I would say that there are many academic courses that you can attend where you would learn a lot about obstetrics, gynecology, and there are many people who would be much more qualified than me to deliver those. However, what I feel that nobody tells us anything about how to prepare CV or how to prepare ourselves for our personal and professional development. And that is where it matters. When I look back, sometimes I wonder I would have achieved far more in life if I had received the guidance. Unfortunately, I didn't. And then I learned it the hard way. आप गिरते हैं, मार खाते हैं, फिर उठते हैं, फिर गिर जाते हैं, तो उसी से then you learn. And I started my career in 1997 from Shehzad Hospital with Professor Said. And it was a great learning opportunity for me. I had not done any ops and gynae before, and I spent almost 3.5 years there. Then I went to UK. But I always had the passion that I wanted to go to UK. I was probably one of those people who had done MRCOG Part 1 way back in 1994. I never ever thought of doing FCPS Part 1 and then getting exemption for MRCOG Part 1. I went for Part 1 directly because I wanted to go abroad and get myself trained. It's just that it's unfortunate I couldn't come back. I think this is one of the things that probably our seniors, they can pave a pathway for people who can come back. I even applied to jobs there, nobody gave me the job. So, so then I thought, okay, when I'm getting a job, I will settle there. Anyhow, now, first of all, I had heard all these glorious things about myself, so they look very glorious when I hear about them. But trust me, बहुत मार खा के वहाँ तक पहुँचा, और ये है कि this is a lesson for you, especially it starts as a medical student. And I would say, I decided I want to do ops and gynae when I was a medical student. Now, I graduated from Rawalpindi Medical College in 1994. And when I started my maternity rotation in year 4, I was one of those people who would be just hooked to labor ward. And in Pindi, it's a very different environment. Professor Sadrana was the only male gynecologist over there. And we were not allowed to actually go to the labor ward to do anything. And then they used to tell us to wear a mask, that white coat, then hat, shoe covers. And my first V that I did, I would tell you how it started. So we were, me and one of my other colleagues is also a gynecologist. We were the only two from our batch of 300 who decided to do obs and gynae. We were standing outside the labor ward. She said to us, come, come, come. Now, at that time, they used to put patient in lithotomy. She was delivering actually and put a screen there, and they told us, don't talk, just come in. So I go like that, wearing gloves. And then she says, examine, just examine. And then she said, go out. That's all. Didn't even say a word. Patient didn't know. I came into the room, I examined, and what I examined was just the head. And I had no idea what I was examining. My next one was in Sheikh Zayed Hospital when I started my rotation over there. And I had one of my seniors who then was in the other end of the ward, and somebody was delivering, and she said to me, examine. And we were having this conversation across the ward that, okay, examine, do you feel this? Do you feel this? And that's how I learned obs and gynae. Now, these 2 days, you will see my name almost everywhere. It's not a one-man show. Okay, because there are people who say that, okay, it's your show, it's not my show, it's your show. And then this is for residents, this is for people who are established gynecologists, this is for people who are medical students. Some of you might be deciding to do obs and gynae. Even if you don't decide to do obs and gynae, there are generic things that you can take from these 2 days. And I want to make these sessions interactive. So if you are not going to ask me questions, I will start asking you questions. So if you want to avoid that, I would encourage you to speak up. And this is one of the things that we need to change ourselves as Pakistanis, because we don't talk to each other, isn't it? So when we have Pakistanis in a meeting, very rarely people will go and talk to each other. We are too shy. I was too shy. I lost many opportunities just because of that as well. So please use this opportunity to interact, to learn whatever you want. So I will start my first talk, which is the introduction to NHS, because I thought you need to have some background information how this NHS works, because it's a different health system. When you go to UK or you want to go and work there, then it is a very different sort of setup. And it takes a little while to get used to it. And then if you know beforehand, it will make your life much easier. Where is that? Structure of NHS. It seems people have started leaving already. But ऐसे फिल्म स्टार्ट होती है तो बड़ी बोर फिल्म लग रही होती है तो 5 मिनट के बाद स्ट्रक्चर ऑफ NHS. Okay, so this is my hospital. This is we have a big maternity unit. It's inner city London hospital, so we have a very complex population. The catchment area has a lot of Turkish women. There are days we don't even have a single English-speaking woman in our obstetric unit. They're all Turkish speaking, and we have Turkish interpreters physically present, at least from 9 till 5. And we also have a large African community, Eastern Europeans, and these are all those people who have got very high morbidity rate and complex medical and social issues. So our delivery rate is about 5,000. Right, so in this session, I'm going to talk about the UK health system. Then I will tell you that why there are certain procedures which are expedited in on NHS, and then how the money flows, and then what are the referral pathways, how a patient is seen over there. So NHS, which is the National Health Service, which is government-funded health scheme in UK, was established in 1948. They say NHS was never established or was never meant to provide quality of care. It was supposed to provide quantity of care. So they wanted everybody to have free health system, and this is where NHS comes in. The funding for NHS, it comes from the government, and then the budget every year, this has been going on. So there has been severely increased pressure on NHS. You might have seen in news, especially if you are interested in looking at BBC News from UK, and you would see that nurses were on strike, doctors were planning to strike, and postal workers are on strike. So a lot of people, they are doing that. And one of the main reasons for that is that the government hasn't got the money. And that is because they have got an increasing aging population, which require a lot of social care because it's a welfare state. So what happens in the UK over there, that when you are old or you're retired, if you are too frail, you cannot live on your own, then the government is supposed to provide you with care workers. Now, if you are independent, you can still live in your house. Otherwise, you have to go to a care home, and then in care home, the government will pay for you. So it's like a hostel, you can say. They have common facilities over there, and all the old people are living there, and they are looked after. And if you are living at your home, which a lot of people, they try to do that, and then the government would provide you some care workers who will come maybe 2 times in a day or 3 times in a day to give you food, to clean you, give you medicine, and all that. And the government has been cutting these social care budgets. And what the problem it causes is that previously they were spending a lot on that, and people were abusing the system. Still now, there are women who would come, they would seek asylum. As soon as they seek asylum, and then they would say that, okay, they've got some medical problem. If they're pregnant, they get admitted to the hospital, and they cannot be sent home if they say that, okay, I'm worried about domestic violence, or I don't have any place to live. So they would stay in the hospital until the government or the council in that area would be able to find a spot for them to live. So you can imagine that renting a flat, even a 1-bedroom flat for that woman, how expensive it will be. And this is all coming from taxpayers' money, and that's where it all gets diverted. So this figure will show you how this whole process starts. So if you look here, that there is taxation, there is all the borrowing which comes, then it goes to the UK government, and we would have a budget of about 161 million, and then it goes up. Then government from there will disseminate that budget. So it will go to social care, it would also go to Department of Health. Department of Health will get the major chunk of that budget. Now then Department of Health, which is run by the Health Secretary, would be responsible for disseminating that money. They are then going to pass on that money to different agencies that you can see, and then ultimately it would go to CCG. So let me just take you through this. The Department of Health gives on to NHS England. Now, what is NHS England? In UK, there are 4 provinces. One is England, which is the big bulk or the main thing on the map. Otherwise, it's synonymously, when somebody says England, it doesn't mean United Kingdom. You have got Scotland, you have got Northern Ireland, you have got Wales. So these are all 4 different provinces, but the biggest one is England. So that's why it's called as NHS England. And that's the main body where the main money is going. The other provinces, they get their money, but then it's much smaller, and then it is at their discretion to basically to disseminate that money and use it for their own health system and budgets. Then NHS England will then give that money to CCGs. So what are CCGs? CCGs are clinical commissioning groups. So these basically are GP services which have been brought together to make larger groups. Now, say if it is in one area of London, because London then is further divided into different smaller areas, and let's assume it is a defense, right? Let's put it like that. So all the GP surgeries, which is the primary care, they will come together, they will form a CCG, and then they will decide which services they want to fund for their own people who are living in defense area. We don't have defense area, but they was just like an example for that. So in all of the England, there are about 211 CCGs. Now, what these CCGs then they do is they get the money from GP. Now, they don't want to give money to hospitals because if they are sending a patient, they are first of all, they are giving money to the local GPs. Now, GPs, they want to treat the patients as much as they can. And when they think it is beyond their expertise, then they will refer the patient to a tertiary center or secondary center, which is the hospital. When they do that for specialized care, then they have to give hospital that money. And this is where the conflict starts coming. And over there, one of the big issues is that GPs, they don't want to transfer you. A lot of people, they go and they want to be seen by a specialist, but you can't just go and get an appointment with a specialist in a hospital. And that's how the whole system runs. And this is also more or less the same sort of thing. It is a more newer slide. And within this money, when this money starts flowing, so they also pass on this money to local councils, so which are then providing social care, healthcare, these care services for people, because everything is almost free. You don't have to pay for anything. And then you are sending this money to all these other extra facilities. And the money for training also comes from the Department of Health. So Department of Health, when they give money to say NHS England, that money will also be dedicated for training as well. And the salary which training gets over there, that is coming from there. Now, if you look here, this is the whole of the England. So this is the main England area. This is Northern Ireland here, this is Scotland, and this is Wales. Now, Wales is the least developed of the area. It's more like it's a rural type area, I would say. Scotland also is not as developed as compared to the main England. Now, when they're giving this money, they have to bear in mind that in the main England area, say if it is London, the cost of treating somebody would be much higher because the cost of living is high, rents are high, everything is expensive. If you compare it with a small peripheral area in Wales, it's much cheaper to treat. So when they are dedicating that money, they would give it accordingly, taking into consideration that if you are doing, say, a cesarean section in England, in a London hospital, that will be much more expensive. It's just like you go to a hotel. In London, it will be expensive, and if you go to somewhere in Wales or Scotland or Northern Ireland, it will be cheaper. So they would give them that extra money because they have to look at what is the best tariff which would fit in with them. That it's not the same, that everybody gets the same amount of money for a cesarean section or any procedure. They would just vary that accordingly. Then I said that Department of Health gives this money, about 5 billion, which goes to Health Education England. Health Education England is the main body which is responsible for training, and then it goes to local education and training boards, and then they are passing on this money for the training. Yeah, if you can ask questions, I can take it.
Where in this growth system outside or
this is so far, this is separate from all that. So GMC is a separate body. GMC is not affiliated with the government. It's a separate body. And which one is the other one you were saying? Royal College. Royal College is also completely separate. They have got nothing to do with this budgeting, and they are not involved in anything. They are just the regulatory bodies. GMC and Royal College, they are interlinked in a way that if Royal College wants to implement anything, even Part 2 MRCOG changes, or like even when they introduce Part 3, they have to apply to GMC to get approval from them, and they have to give them quality assurance that the doctors who will pass this exam, they will be of the same caliber as those who did MRCOG Part 2 before. And similarly, if GMC wants to implement anything and they want, they notice that there are changes which are required in curriculum, they are going to ask the Royal College to look into that. So they are both interconnected to each other, but then this system is running separate from that, and then they are not getting any funding from the government, and government is not responsible for their actions.
So this is NHS is like public health system.
NHS is completely public health system. Just like you go to a public hospital here, and then you are just doing things over there. You have got nothing to do with Pakistan Medical Commission or Pakistan Medical Dental Council. So they are completely separate bodies.
And how much is private setup now?
Private setup is increasing, but still it's not much, because in UK, private insurance is very expensive. And the reason for that is insurance premiums are very expensive. If you compare it with the rest of the Europe. People over there, they believe that if they are giving taxes, then they should be entitled to free healthcare, because that's how it has been from 1948 or so. And people don't want to pay anything extra. However, there have been issues that people are unable to get treatment on NHS because of COVID. There was a big backlog, everything slowed down, and hospitals, they are not having appointments for surgeries and all that. So they developed a system that GPs, they can refer some NHS patients to private hospitals to have the surgery as NHS patient, because then the government would pay them just to ease the load. But overall, there is not much interaction with that. So private setup is, you have the money, you want to go, and the private consultation would be about 250 to 300 pounds if you just go and see a gynecologist. People don't do maternity obstetrics private in most of the places because the insurance is very high. Because say if there is cerebral palsy, and then who is going to bear that cost? So as a result of that, people who are working in private setup, practicing obstetrics, they tend to go more for antenatal care, ultrasounds, and then maybe cesarean sections rather than trying to deliver vaginally, because they don't want to take chances with that. But in government, when we are working for NHS hospitals, so we are provided indemnity by the Crown Service, basically. The government is responsible. So if there is a brain damaged child and the patient sues the hospital, then the hospital will end up paying money for to compensate that. So doctors, they will not have to pay anything from their pocket. However, if you are doing the same thing in a private setup, then it will come from your insurance. That's why everybody has to have insurance, and private maternity insurance is very, very expensive. That's why a lot of people, they don't do that. It's more of a headache. Right. So in NHS, basically there is primary care, secondary care, and tertiary care. So primary care is GPs primarily, which are the family doctors. So for any problem, first you have to go and see them. They will do some tests for you. They can even organize ultrasound scans, CTs, MRI scans, and then they will try to do the initial management. If they think that they cannot manage, then they will be referring you to secondary care or tertiary care. So basically, they are the gatekeepers of referrals, and that is because the money, they are holding the money here, and any patient that they are referring, they have to send money for that patient. So that's why they exist. As a result of that, patients, they get poor treatment because the quality of GPs has changed as well. In good old days, people used to have more broader experience. Now with shorter training time, because over there, the average week is 48 hours a week during training. As a result of that, nobody wants to work anything extra. People have limited knowledge. As a result of that, they just want to linger on to the patient. So then when you go to the secondary care involves district hospitals or not like very high level hospitals like tertiary cares, which are providing subspecialized training. Previously, there were subspecialized centers like say in secondary care, there would be oncology as well, there would be urogynecology, there would be fetal medicine and other subspecialties. However, now there is a drive that they want to move on all these subspecialization facilities to tertiary care. They want obs and gynae people to have what we call special interest to see patients in secondary care. Like say if you take urogynecology, you will have some urogynecologists in secondary care, but they are not supposed to provide high-level services over there. Like they want to have sacral nerve stimulation in a tertiary center. Similarly, if it is oncology, so in oncology, if it's a small cyst or early grade cancers, you can treat it in secondary care. But for advanced cancers, they want these patients to be referred to the tertiary care. The rationale behind that is they say that if you are seeing, say, one vulval cancer or two vulval cancer in secondary care in a year, so it's assumed that you are not an expert. And then they want these patients to go to tertiary care where they are getting referrals from all over the region. As a result, you are doing hundreds and all that. Because I remember that like in Pakistan, if you do one vulval, this wide local excision for vulval cancer, even in a year, you will say, I can do that. But in UK, it's not considered as normal. It is considered that this is basically, the practice is not good because you are not expert by doing one in a year. You cannot maintain your skill unless you are doing it every other day. So then you will be considered more experienced in that, and patients should get the benefit of that. There are benefits of that, and there are disadvantages as well of that. And then quaternary care is even higher than that, which then includes these heart, lung transplants, those sort of things. So in NHS, in secondary care, there are university teaching hospitals where we get medical students as well from different universities. And as I said, that includes large district general hospitals. There are smaller district general hospitals, and then there are smaller community hospitals, which are usually, they have GPs over there. Now, even GPs over there, they develop a special interest. So there are GPs with special interest in, say, gynecology. There are GPs with special interest in dermatology. What they would have done is they would probably have done a 6 month rotation in dermatology or psychiatry or pediatrics, and then when they are sitting in that setup, most of their colleagues, because they sit as groups now, so one person is more expert in pediatrics, so they will send all the pediatric patients to that. So because people don't feel comfortable, and that is because of the cutting of the training time that everybody has been having. Then another thing, what happens is that once the GP decides that you need to be seen in secondary care or tertiary care, they will do an electronic referral form. So, and when they do that, then patient will have the option, they can choose hospital within their area. So it could be that there are 3 hospitals, so it is their choice. If they want to go to hospital A, they can choose that, or if they think hospital B is nearer but not good, they can even choose the other hospital. And then it also includes some private hospitals. So these private hospitals, as I mentioned, that as a patient on NHS, you will not have to pay anything. Even the consultant who is treating them over there, these are NHS consultants who see patients privately over there. They don't get paid extra for that as if it's not a private patient. So, but some people, they still prefer that. But there are less facilities in private hospitals, and private hospitals, they don't take complicated cases over there, and they would refer them to the other hospital. So GP's referral letter then goes to hospital. hospital consultant, then they will vet the letter and they will say, okay, let's direct it to the appropriate clinic or to the appropriate clinician. So if it is an HRT and there is an HRT clinic or menopause clinic or fetal medicine clinic, so then they will direct it into that particular clinic. Then what is this payment by result? This is why I said that the GPs, they send the money to the hospital. So what some hospitals they do is they develop a system that the CCGs, they ask them to code the patient. So because if it is a low risk, completely simple patient, then you would get less money for that. However, if it is a 4 previous section patient who has got placenta accreta, she has got diabetes, she has got hypertension along with that, she has got morbid obesity. So all these things, they have got a code for that. As a result of that, if you do that, showing that this is complex, so then when they are going to give them money, they will give them higher amount of money. However, because of this, the CCGs, they were losing a lot of money. So then they thought that, okay, let's do a block contract with the hospital. So block contract is, they will say that last year you saw, say, 1,000 patients. So we will give you money for, say, 1,100 patients for next year. And you did so many hysterectomy, you did so many cesarean section. So we will give you £10,000. It is up to your discretion how you want to use that. But we are not going to pay you anything extra. So that's how then the money goes to the hospital. They receive it and they want to now save the money. And how they want to save the money, they want to cut down follow-ups of the patient, because every time a patient is coming to the hospital, they are losing money by that. So for example, if you look at antenatal clinic appointment, it is about £119. Now, it's not that much if you look at it. However, on average, a woman who is complex sort of, say, antenatally who has got diabetes, they are coming almost every other week. So it's a lot of money which then ends up in antenatal clinic appointments. She would require a lot of surgery. She would require a lot of investigations. She would require ultrasound as well. So as a result of that, when all that money is pooled together, so it will be a lot. So they can't do much for obstetrics, but for gynae side, they want to cut down on referrals. The notorious ones are urogynecology patients who keep on coming. And I know that there are some urogynecology patients who have been coming for years. Some of them, they've got pessaries. All they come is to have a pessary change. Now, in order to tackle that problem, what they thought was it's a waste of consultants' clinic time that these patients are coming just for pessary change. So they started training nurses for that. So nurses, then they would run a pessary clinic. They are not being paid anything extra. They within their job plan, they will set up a clinic and say, okay, you come, you have your pessary changed, and then off you go. You don't need to see the consultant. And still there are a lot of patients with these overactive bladders and stress incontinence who don't want surgery, but they want to keep on coming. And the instructions to us will be that try to reduce the number of follow-ups. And usually on average, in general gynae clinic, it will be about 2 follow-ups maximum. After that, the hospital is not getting any money. So it's not beneficial, because you are wasting a slot by having that patient that you could generate money by getting a new patient booked for that slot. Because our clinics are not as big as you have here. Like here, I remember when I did my outside gynae here, the antenatal clinic used to have 100, 200 patients over there. Our maximum would be 20, 25, but there are only 3 people. There is 1 consultant, there is 1 registrar, and 1 SHO. That's all. And if it is a diabetic clinic, you will have endocrinologist sitting with you as well. Right, then when the patient gets referred to hospital, so they have to start their treatment within 18 weeks from their referral. And that is if it is something non-urgent, non-cancerous. So if it's menorrhagia, and as soon as you book the appointment, then the clock starts. And then there was a lot of pressure from politicians in UK over there. They wanted to have that patient should be seen quickly, and which is not always possible. As a result, because if you're trying to catch up with that you have to do that, you need more facilities. And when you don't have facilities, you are unable to do that. So still, the good practice expectations are that within 18 weeks, you would have been seen by the consultant, and whatever they decide, it will be after that what your management is. However, with this sort of system, a lot of cancers, they were getting missed. And then by the time the patients were being diagnosed with cancer, it was quite advanced. So then they came up with another system which is called 2-week wait referral pathway. So it's basically a fast track system. So if GP suspects that it could be cancer, they can fill in a form and send it to the hospital. It comes and hospital is obliged to see that patient within 2 weeks. As a result of that, it started increasing pressure on the hospital. So say if it is perimenopausal bleeding, so if the GP writes down that I did ultrasound scan and the endometrium was 10 millimeters thick, it could be endometrial cancer. Now, it might not be nothing. It might be just simple hypoplasia, might not be even simple hypoplasia, but hospital becomes obliged to see the patient within 14 days. And within these 14 days, then they have to do the initial investigations as well. So 14 days you see them, and then, next 14 days or so, you have to investigate and to come to a diagnosis that whether this requires any further treatment or doesn't require any further treatment. And then the next 13 days, basically 31 days, you have to treat the patient. So in total, in 62 days, a patient has to have the treatment, and this is what we call 2-week wait pathway. And it added a lot of pressure on hospitals and GPs. They started abusing the system. Menorrhagias, they were coming. Anybody with 3 centimeter ovarian cyst, GP will fast track the patient in a 20-year-old woman, and they were really inappropriate referrals. But as a clinician sitting in the hospital, you cannot refuse that. You have to see them. Then also there were things that they were trying to cut down on money, that we shouldn't be treating people with simple problems. So things like Bartholin cyst, they said on NHS, we are not going to treat that. If you have got vulval skin tag, we are not going to treat that. And then initially it was for the cesarean section for non-clinical reasons. Now, non-clinical reason is a very big sort of term, but it depends what you want. But similarly, if a woman wants to have hysterectomy, like a lot of Pakistani women, when they come over there, they don't want to try Mirena, they don't want to try medical treatment, they have completed their family, they say, I just want hysterectomy. And it's a mindset that a lot of women they have over there. Now, hysterectomy is an expensive procedure. That patient then gets admitted to the hospital. She has to stay in hospital, and the government wants to save money. So they will say, rather than doing hysterectomy, why don't we fit Mirena for this or give medical treatment? And this is where then the problem comes, that if I'm booking somebody for hysterectomy, I have to justify, first of all, that I've given her or I've tried medical treatment for menorrhagia. I have offered her or given her levonorgestrel, IUS, this Mirena, even endometrial ablation. I can't bypass all these things and book her directly for hysterectomy unless she is categorically refused, because I could be asked to justify why I didn't try for these things. Similarly, a lot of patients we used to see who used to come for labioplasty, that we have got long labia, we want it trimmed. On NHS, we cannot do that, because again, even if it is a one-day procedure, the hospital wants to save money, so they refuse. So then they develop this thing called POLS, which is procedures of low clinical efficacy. So what you have to do is, the hospital, the patient will be seen, so a patient comes with long labia and she says she wants to have labia trimmed. We have to ask the GP then, we will see her, examine her, send a letter to GP and say that, okay, it is causing her discomfort. We can't do it for cosmetic reasons. But yes, she says it is causing pain, it is causing bleeding and all that. So GP then has to send a form, specific form, which is called Coles referral form. So essentially, what happens is that they are agreeing that we will pay you money for this, because if we do it without their agreement, they will not give money. They will say this is procedure of low clinical efficacy, there is no benefit, you have wasted money, so we are not going to pay you for that. So they can refuse. Then in order to save money, they develop enhanced recovery pathway. Enhanced recovery pathway is essentially that you fast track everything. Way back when I was registrar in 2009, one of my colleagues at that time, he started vaginal hysterectomy as on enhanced recovery pathway. So essentially, the woman would come in the morning, she will have a vaginal hysterectomy, and by afternoon, she will go home. And the main key element over there was that it was pre-operative assessment. Not everybody was suitable for that. So you would see the patient before, you would talk to her, you would check she has got some support at home when she goes, and if there is a problem, somebody will bring her back at night. We used to hold some classes where they would come in, they would see the nurses, they would see pain specialists as well, they would see the anesthetists, and they would tell them what to expect that day, so they are mentally prepared. And then you would try not to put in any packs, catheters, those sort of things. And it really worked very well. Excuse me. So when it started, some of my colleagues who were old-fashioned, they were very skeptical about that. But then because beds are in high demand and they wanted patients to go out as quickly as possible, so invariably, so some of the patients, they would agree to this enhanced recovery pathway. Thank you. And they started having this. Then they even extended it to a cesarean section. Now, unfortunately, it's not that cesarean section, they go home same day, but our cesarean sections typically go home day one. So if somebody is having a cesarean today, our aim would be that by 6 hours after the cesarean, their catheter will come out. They were forced to get out of the bed in a way, forced, I would say, that the same night they have to start walking around, and by next day, if they are okay, by afternoon, they should be able to go home. And that's all to save money. So to reduce the patient's stay in hospital, because over there, a hospital is looked as a business, that if a patient is occupying a bed, then you are wasting time on that. And the quickly you move them, the better it will be. And the current chaos that we have in hospitals over there in NHS that you see in the news, that is because a lot of patients, they are elderly, they don't have support at home. As a result, the government has to find either social care support for them, or to organize accommodation for them, and until they do that, they cannot just chuck them out of the hospital. So essentially, it has become more like a hotel for some people over there. SPAR tool, we will talk about it later. It is one of the tools that we use for communication, situation, background assessment, recommendation, and we will talk about that later. I put this maternity dashboard because if you go for MRCOG, sometimes they put it in the exam. So essentially, what maternity dashboard is, it is your performance against set standards. So it would have different sort of activities which are documented over here, like what should be your ideal cesarean section rate for emergencies, for electives, what should be your PPH rate, what should be your forceps delivery rate, what should be your third degree tear rate. And if you have any deviation from that, so the data is collected, and then every month, every maternity unit, they will go over that, and then they will see if they are coming in red, then they have to look into that why it has happened. Like traditionally, we saw that our third degree tear rate starts going up in October or April, and these are the times when trainees, they rotate. So as soon as they rotate, they come to the new hospital, people are a bit anxious, and then cesarean section rate goes up, third degree tear rate goes up. But then you should see it coming down as well. And if it remains persistently high, then you start thinking it could, because a lot of normal deliveries are done by midwives over there. So you then have to look at it, that is it they are not supporting the perineum properly, that's why 30-degree tears are happening, or what could be the reason. So this is something very useful in exam. They have put it, and then they would phrase a question that this is the maternity dashboard for your unit. You notice that your cesarean section has increased significantly. Your consultant has asked you to look into that. How are you going to do that? Now, indirectly, they are asking you to do an audit. Okay, so in that, now you have to then talk about audit. They will not ask you what is an audit and tell me how will you do an audit of cesarean section. They will throw in a question like this, and that's how these EMQs, these extended patchy questions, or single best answer questions, they are framed. We'll talk about that later when we go to the MRCOG bit. Then every hospital, they have their these kits. So kits are basically quality, innovation, productivity, and prevention. They want to promote that people come up with new ideas, and then develop, like this enhanced recovery pathway was proposed by somebody, and then every hospital benefited from it, and it is a national setup now. So every hospital, they will set up their kits, and they want their clinicians to look into that. So it would be in every specialty. Then, okay, so let me ask you this question. So patient referred by GP to a specialist on a 2-week await referral pathway should be treated in how many days? 6 weeks. Very good. So you are still awake. Good. Then how about this one? No, that is, it's not like that. It's just to. No, EMQs are different. EMQ, it's not really EMQ. It's different when we talk about it. So what about this one? Approval from CCG is required for reduction of radius. Yes, good. Right. So I made this pathway many years ago when I came to Karachi for that part 2 MRCOG course. So if you have a look here, it would just tell you how this whole system works. It's basically a summary. So patient goes to the GP. GP will either treat that patient or they will refer to the hospital. So when they refer them to the hospital, it could be a routine referral. It could be a phone referral. Is it phone? Phone referral, or it could be an urgent referral, which is 2-week wait pathway. Now, if it is a routine referral, when the referral comes in the hospital, the consultant, somebody will see the letter, they will vet the patient, they will put the patient in gynae clinic or antenatal clinic, and then they will be seen over there. Now, if the consultant thinks this is an inappropriate referral and somebody is history suggestive of more like a surgical cause, they can even refuse the referral or they can redirect it. So you have to then, you're not obliged to accept it. So you have to read the GP letter and assess the situation and why you are taking that patient in. Then if a patient saying early pregnancy goes to the GP and says the GP and says that I've got right iliac fossa pain, GP suspects it could be an ectopic pregnancy, then GP will phone the hospital. They have got direct numbers for say early pregnancy assessment unit, and ask them to see the patient. The patient will go over there, they will scan the patient, and then they will be seen over there. Some units, they have less facilities, so the patient will go to A&E. In A&E, then they will call an obs and gynae doctor to come and see the patient. Then they will then arrange for further ultrasound. Like in our unit, because we have a big one, we call that area called Women Ambulatory Day Unit, WADU. So a GP will refer the patient to WADU, and WADU is essentially gynae A&E, but within the obs and gynae department. So the patient will bypass the main A&E and go directly over there. Or if it is just an early pregnancy problem, they can go directly to early pregnancy assessment unit and can get seen over there. If it's an urgent referral, then they are referred on this 2-week wait pathway, and then they will be seen in gynae clinic, and then if she requires, say, ultrasound or hysteroscopy, so they will be organizing all that.
Most of the cases which are low risk are midwifery-led care. So this midwifery-led care is within the hospital or in community.
It's a majority of that is in community.
So 80% of obstetrics is that. We make it to 20%.
Yes, in a way. It's not 80, I would say about 65 to 70% is low risk. So it
And in community, they have the birthing centers where they will.
No. They don't have a birthing center. I will let me just go over that. So I will finish this, then I will take you through that. So then these patients are seen over there, investigation and whatever the management plan is decided and patient needs. For maternity, it is different. The patient gets pregnant, she will have the option of contacting the hospital directly. She can go on hospital internet and then website and then fill in a form. She goes to book in this hospital, or she can go to the GP and send a referral to the hospital for booking her for anything. Or the third option can be she can just walk into the hospital at night. So then she will get an appointment to be seen by a data, which happens usually around 9 to 10 weeks of pregnancy. Meanwhile, you will see her, she will take all the history, she will identify if she is low risk or high risk. If she is low risk, she will write down she is for midwifery-led care. If she is for midwifery-led care, she will be seen for midwives throughout the pregnancy. Doctor will not get involved. So midwives should be running the antenatal clinic. There are some health centers in the community. So patients will go for antenatal clinic appointment with that midwife. If midwife thinks that she needs an ultrasound scan or she needs a consultant opinion, she will book an appointment for her in the hospital. Some of these midwife clinics, they are run in hospitals. However, majority are in the community. Now, what they're trying to do is they're trying to combine, like one consultant is leading a midwifery team as well. Like my clinic is on a Monday morning, and part of what we call a sunflower team. So we will have a sunflower team midwife sitting in antenatal clinic. So no risk patient will come and see them. However, if there is something that she identifies, she goes to get consultant opinion, she can ask. Similarly, if this patient is think she's low risk, she will refer for something which is a medical problem, which does not exist anymore, and want to put it back. So that's how we see that. So there's midwifery-led care, there is hospital care. Say that somebody with diabetes, high blood pressure, hypertension, these are the ones which are high risk. They will be seen throughout the hospital. Previously, GPs, they used to see some antenatal patients as well, and that was called as shared care. It was in between the midwifery and the hospital care. So, but now most of the GPs, they don't see them anymore, and they would refer them to hospital. So the main challenges that NHS currently has is aging population. Every age over there is like 90s, nobody dies. So as a result of that, it's a big problem. So too much money, and that's why they have increased the retirement age. When I started, the retirement age was 60. Now then they increase it to 65. Currently it is 67. And I envision that by the time I reach the retirement age, they will make it 70. And the reason for that is because they want people to stay in job for longer, so they keep working and government will not have to pay them pension. Because a lot of people, same here as well, okay. Some of the patients, doctors who are working in the old system, they used to retire at 60 and then come back on contract. So in places where they need specialized services. But then they started cutting on that as well. So I sometimes think that average age, say Pakistani is 67, 69. At least in my family, my father, grandfather, everybody died by the age of 68. So I don't even know if I will be able to enjoy my own pension or not. And But then there are a lot of political interferences. These ministers, they come in and then everybody comes in with a new plan and they change things. So these are the main challenges, Pranav.
Digital technology challenge, I think it should be an asset. Support the system.
It is. The problem is that a lot of hospitals are still paper-based. So they are trying to move on to the digital system, but then with digital system, the issue is that cost. There is no uniform digital system across all the NHS hospitals. So if a patient is in Wales, so that hospital has a record on paper. She comes to London, London hospital has a digital system. They want that record, they have to photocopy, contact them, photocopy and send it. Sometimes, you know, you send letters to the consultants over there, nobody responds and it takes ages what happened to her previous pregnancy. And that is one of the main issues, that there are people who have got their files this thick, and then how they want to scan them and get everything digitalized. So this is one of the main things, and it's $1 billion pounds for every hospital. So that is one of the main things. Data protection, they have it, but then, you know, for GPs, it is different. For GPs, it is a uniform system. If I go to a GP in North London and I move house, I go to a GP in South London, he will be able to access my GP records from North London. And it doesn't happen in hospital. And similarly, if I'm sitting in hospital, I want to see what GP record she had. I can't do it, because these are completely different systems. And that is one of the main things. They're spending a lot of money trying to bring in, but then there are issues with that. A few years ago, there was a big issue that somebody hacked into NHS system, and then the whole computer system was paralyzed, basically. So that is one of the things. So as a result of that, they've become much more stricter. Our email is much more secure as it used to be, and you can't just use it for each and everything. And they make it very difficult for people to hack, but it is still happening. If you want to have a look, this is a very useful guide. It's a small video, an alternative guide to the new NHS in England by King's Fund, and it is on YouTube. It will take you through this whole pathway in a very user-friendly sort of format. Then you will be able to understand how this money is flowing and everything. So whatever I've talked about, it will talk about that. Okay, so I've taken a lot of time. So I will stop here. Any questions? Nothing? I can move on to the next one then.
People who are practicing basically their first time and want to just go for exam, look on this routine.
Because it's a UK system exam. When you go over there, you need to know how that system works. Because there were times I was examiner in one of the part 3 exams, and there was a question about in utero transfer. Now, in utero transfer, there are different types of hospital neonatal units. Not every neonatal unit will take 24-weeker, not every will take 28-weeker, not every will take 36-weeker. So they have thrown in a question: a woman goes in preterm labor, and then she needs to be managed. Now, they then wanted the discussion about that in utero transfer thing. And I remember that I had one Pakistani candidate. He had absolutely no idea, because he had never worked, he did not know anything about it. And this is where that familiarity, then if you don't know about that, like say even this 2-week wait system, how this pathway works, or if there is a question where you can say she's low risk, she can have midwifery-led care. So you will not be able to answer those questions. I think yes, you can use some generic terms to do that. But then if you have some background knowledge of this, it will make your answer much more sleek at that time, because you would know the background, how it works. And a lot of people who want to go to UK for attachments, unfortunately, a lot of hospitals, they don't give attachments anymore. And a lot of hospitals, they have started charging people for attachments, like 200 or 400 pounds for a month or something like that. I incidentally met one of Pakistani doctors. She's from Multan. She was doing attachment in my hospital. I don't know if she organized it through somebody, and one of my colleagues introduced to her. She's coming tomorrow. I've asked her if she can prepare a few things of her experience as attachment. Because when I knew that, okay, she's here, she's done lab and all that, I tried to push her into that system, and I could see where she was fumbling. Like I would take her on one round and I would say, okay, you write the notes. Now, although we have seen her before, shown her before how you write the notes, but you could see that she then struggled. Then there were other cases in clinic, and she was sitting with me, and I said to her, okay, you start seeing this patient. Normally, clinical attaches, they are not allowed to do that. But I was sitting there with simple things like cesarean section consent. There was a patient I was booking for C-section. I said to her, you start consenting. And she struggled. And then I said to her, this is what, when you are in exam, it's a very basic, simple thing, cesarean section consent, but you're not used to that. And then I did it in front of her. And it's not that I was born with that sort of thing. When you work in that system, then gradually you know what are the sort of things you have to tell patients. Like I never used to tell patients that there is 1 in 200 risk of causing a scratch or cut on the baby's skin. But there was a case where when I was a registrar, somebody with prolonged labor failure to progress, I did a section and there was a small cut on the baby's cheek, and this woman sued after I think 4 years or 5 years. And then when the solicitors get involved, solicitors, they pick on everything. They would say, okay, the Royal College guideline says that you should have told her. Did you tell her? No, I didn't tell her. It was not written over there. And I can't defend myself. But then fortunately, when they asked one of the experts, that expert went through my notes. I had written times over there, and he said he made knife to skin at this time, knife to uterus at this time, baby delivered at this time. And he has gone very slowly, and in the notes he has written that the lower segment was papery thin. And yes, it is one of those things which can happen. And it seems he has taken appropriate care. So that expert's opinion protected, because otherwise she was an African woman and the baby then developed keloid over there. She was charging that she had to pay a lot of money even for bus travel, taxi travel to that GP to get the cream for that scar. So people, they just want to get money from wherever, and you have to protect yourself. Right, so I will go through the structure of UK training system, and within this I will show you that training portfolio that Dr. Nazmi mentioned as well. So it would be useful then, especially those who are going for the exam, then you know what that means basically. Right, so in UK, once you do the graduation from medical school, you apply for these foundation training positions. So foundation year 1 is essentially first year house job. And they don't have this traditional R system like 6 months of Sanghaini, 6 months medicine, 6 months surgery. They have 4-month rotation. And then they would rotate in 3 specialties also. Then they move on to FY2 after that. So at FY1 level, so your role is essentially you are not prescribing, you are not doing much except for taking history and very, very basic stuff, basically, which I won't even consider that it is like a doctor, but you are qualified GMC registered doctor at this stage. FY2, you start becoming more independent, you are more experienced, still you have 3 rotations, which would be based on your ranking, because here you apply for these posts on a national system. And then it could be in any part of the country, it could be in any specialty. There's no guarantee you will get obs and gynae, even if you want to do obs and gynae. So it depends on your score primarily. Once you are FY2, you then decide how you want to progress in your career. It could be you want to do obs and gynae, it could be you want to do medicine. So then at this stage, you start applying for specialty training positions, what we call ST positions over there. A lot of people, they have started going into obs and gynae. They think this is an easier option because it's a 7-year training program. You get entry here, and then when you come out after 7 years, you are a specialist. Because if you compare it with medicine, you will go into medicine, you will do, say, MRCP part 1, then you will do 2 years, and then you will do MRCP, and then you still don't know. It could be that you decide you want to do medicine, you can decide you want to do radiology, you can choose at that time. But those 2 years in medicine are generic. Similarly, MRCS, which is the surgical one. A lot of people I've seen here in Pakistan, they write MRCS as a degree. It's not a degree. They are not qualified surgeons even. So because then they choose if they want to pursue. So you would do 2 years general surgery, you do MRCS, then you decide I want to do plastic surgery, I want to do colorectal surgery, and then you apply again for that. It is a very competitive process, and then you get into that system, and then you complete that, and you have got an exit exam as well to do that. So that is more difficult. So obs and gynae is much more streamlined. You enter at ST1. ST1 is basically first year resident. You're not doing much except for doing histories, learning basic things, and then you move on to ST2. ST2, you are still a third on call essentially if you have got a consultant, registrar, and SHO. You are at SHO level. You don't have to do before ST1. A lot of people, but when you, most of the people, they will do their MRCP part 1 by ST2, because that will be one of the prerequisites. If you want to move on from ST2 to ST3, you should have your MRCOG part 1. What was happening, we were running this introduced skills course over there for these S3 training positions, because it is a very competitive process and it has become national now. So a lot of people, they would have done MRCOG part 1, even as F2, FY2. There were people who had done a lot of other things that you would expect an ST2 to do, some courses, and they have done it at this stage just to make their CV stronger. So you get appointed to ST1, so you do the basic things, then gradually by ST2, you are becoming more independent. By June of every year, these ST2s, then they start stepping up as ST3, which is the registrar, basically, the junior registrar, you can say. And it is expected that here you would have passed your MRCOG part 1 as well. Once you become ST3, you are at registrar level. Depends where you are working. If you are working in a small hospital, you could be the only registrar on call at night. Your consultant could be at home. If you are in a bigger unit or complex cases unit or tertiary unit, then you could be having a senior registrar along with you. Then you progress to ST3, ST4, and ST5. And by ST5, it is expected that you would do your MRCOG before that, because you cannot move from ST5 to ST6 unless you have done your MRCOG part 2 and part 3 as well. Because at ST6 and ST7 level, you enroll for what we call ATSMs. They stand for Advanced Training Skills Module. So Advanced Training Skill Module is essentially like, I had an interest in outpatient hysteroscopy. So I did ATSM in hysteroscopy and intermediate laparoscopy. Somebody wants to do fetal medicine, they can do fetal medicine ATSM. So that doesn't make you a subspecialist, but you can say, I have a special interest. Like say, if I wanted to do urogynecology at that time because I was working with somebody consultant who was a urogynecologist. And I was doing a lot of things that others, they were not doing, even these mesh repairs and all that. And they didn't allow me, and they said there are not many urogyne positions, so we can't give you ATSM in urogyne, it will be waste of your time. So that's where then people, they start defining their future career, how they are going to do that. MTIs who go to UK, their expectation is that they are going at this level, but because you are going into a new system, most of them, they start at ST2 level, and the aim is that you become used to the system, and then after 3-4 months, you get promoted to say ST3 level, then they see how comfortable you are running the labor ward, and if you are comfortable, you could be treated as ST5. Which is not like a senior registrar, but more like an intermediate type registrar. Then there are people who want to go, these ST positions, they are for clinical obs and gynae, and some positions they get advertised for academic obs and gynae. Academic obs and gynae is that you get affiliated to a university, you do a research project, and then you become professor over there. Because over there, everybody is a gynecologist, nobody is professor unless you are into that academic pathway. So academic pathway is very different. There are very few slots, and then you need to have a special interest in research, because most of those academic pathways, they have research as the main component. And then when you get appointed to these specialty training posts, then you have a local educational and training board, which is previously they used to be known as deaneries. And then you have your training number that you retain that training number for whole 7 years. And once you do your CCT, then that training number finishes and they allocate it to somebody else. And every year you have training assessments, what we call ARCPs, which is annual review of competencies and progress. If you go onto the Royal College website, all this information is over there, that what is the core curriculum, and you should make yourself familiar with this, because if you go for MRCOG part 2 or part 3, it would be useful to know what is happening over there, and what sort of what are the expectations basically. So they have changed this recently in the last few years. The core curriculum now they're divided into, they call it capabilities and practice SIPs basically. And this is the link to that. And if you click on that, it will take you to that page which talks about this. And within that SIP, there are different things. Let's say the purpose of this is that if you do a cesarean section and somebody says you are competent to do a cesarean section, you are competent to do a cesarean section for that particular one. It could be a simple primary gravidas cesarean section. Getting signed off for that doesn't mean that you go and start doing placenta previas as well. So you need to have separate for that as justification that you are able to do that. And the important waypoints are between ST2 to ST3 when you are becoming from SHO to registrar, and then ST5 and 6 when you become a senior registrar and you are supporting your juniors as well, and you move on to the consultant post. Then if you go on to the college website, you will also find a lot of information about that. We will talk about it when we do the talk later about work-based assessments. This is something which all the people who are going for MTI, they need to be aware of, training matrix. Now, training matrix is something which tells you what you should be doing at different at ST1 level, what sort of courses you should have done, what sort of procedures you should have done, what sort of work-based assessments you should have done, and then it would go year by year, and then it would give you information more about that. Everything is on the Royal College site, and it would be useful to look at. So this is one of the examples that ST1 level You are progressing with signing off of basic competencies with like speculum examination, binomial examination. You are first on call at this stage, no examination by itself at this stage. Then by ST2, you have completed your basics, and now you have done your MRCOG part 1, and then you start developing second on-call competencies that you are preparing yourself to become a registrar. And then gradually, this is just like a broad outline that what would be expected of you. Training Matrix has got much more information about that. And then this shows that what sort of work-based assessments you should have done at ST1 level, what would be expected, at ST2 level, what would be expected. A lot of trainees, when they start, they want to do cesarean section immediately. Now, there's no requirement, even if somebody has done obs and gynae before and they start as ST1 and I sign them off, I'm not legally obliged to sign them off. However, there are people who are experienced, they have done foundation year rotation in obs and gynae, and I think they are competent to do a basic private gravida, simple, straightforward section. I can do that, but then it is not required like this. So gradually, then every year there will be something which will start adding up. It will give you information how your clinical skills are progressing. Then when you go for your ARCPs, you have to have a summary of things that these work-based assessments, how many minimum you should have done. So MiniCAT is a mini clinical examination that basically involves speculum examination and all that. CBT is case-based discussions. So it could be that there is you saw patient complex say hyperplasia in clinic. You can discuss it with the consultant or your senior, and then you can fill in a CBT form for that. So it doesn't make you competent to treat that, but it's just that, okay, you have covered that. And then another thing is, which is very important over there, what we call reflective practice, that they want everybody to write up a summary if things have gone wrong, what did they learn from it, and how they can improve that. When people go for trainees, they go for their ARCPs. So this is a very common question that, first of all, the panel, they will look whether this person has done this reflective practice or not. And then the following question would be, what did you learn from it and how did it change practice? Simulation training is becoming much more common now because of the reduced working hours, and also there are things that you don't get opportunity, like shoulder dystocia is not that common now, but you still have to do those drills that if it happens, what you are going to do, if there is cord prolapse, what you are going to do. And then there are regional teaching sessions that you can see at the bottom. And then once you have done your general obs and gynae training by year 6, then you start defining your career, which way you want to go, and then you choose that area, whether it is laparoscopic surgery, whether fetal medicine, urogynecology, oncology. And then those who decide to become academic ONG, there is a separate segment over there. And a lot of our people, when they go over there, they are not really interested, but this is one of the other options. It gets advertised separately. And if you are one of those Padaku people who are interested in research and all that, this is a good opportunity. They do get, their job is split between hospital and university. So in hospital, they will work like any trainee. But when they are in the university, they are bound to have a research project. They could be working in a lab doing something, then they have to do their dissertation paper on there, and that's how they do that.
So in if you were to do that basic line, one service line, then research, each of us have to do a dedicated time when a particular medical 20%, and that then is followed.
No, we have that because we have a system where we have service posts as well. So these staff grade posts where people come and do. But then in order to fulfill the requirement for GMC registration, they still have to get involved in teaching, training, attending conferences, workshops, all those things. They have to do a quality improvement project and all that. So because if you don't do that, GMC will not renew your license. And they are making it difficult for people to have it separately, but still you have to have that sort of system where you are giving everybody an opportunity to train, even though they might be staff grade. Because a lot of staff grade now, they are becoming consultants as well, because of there is a pathway on GMC called Article 14. Article 14 is that if you can justify and give evidence that, say, two people are working, one is a trainee in the department, the other one is a trust doctor, we call them. So they are not in a training post. We are using them for service provision. However, they are keeping a log of everything. They are doing all these work-based assessments, and they are doing their exams, they're progressing, and at the end, they can apply for that. And then they can go on to GMC Specialist Register. And when they go on to GMC Specialist Register, they get that, if GMC approves that, it's called CSER, Certificate of Equivalence of Specialist Registration. So they then become appointable as a substantive consultant once they have that CSER. People still discriminate, especially in the Middle East, when there are staff grades who have done CSER when they went to Middle East. Over there, they ask for more experience. Although these are more experienced people, but CSER is not looked as favorably as CCT, which is Certificate of Completion of Training, that you get into at the end of your training program. So that is one of the things that you need to be aware. However, because of shortage in UK of senior obs and gynae doctors, they are now recruiting at ST3 level as well. And interestingly, you can even apply from here. You don't need British citizenship. Previously, you needed British citizenship. Now they will sponsor work permit for you. However, the success rate would be less because you are not familiar with that system. So there are still a lot of people who are working. We had a lot of trust grade doctors working for us, which was service post, and some from India, some from Pakistan, Sudan, Sri Lanka. And they came on MTI, and then when they start applying, and as soon as they get to know things, then they start applying, and then they get ST3 position. Then you get into the training program. So you come out, you get CSER, and still it's not as bad, because otherwise becoming a staff grade is like medical officer or senior medical officer, which is a dead-end job. And the stage comes that you start feeling fed up and frustrated, unless you don't want any progress in your career. And we'll talk about more when we talk about MTI and further. So in UK, there is, we are gradually moving towards 24/7 consultant presence on labor ward. US already has it. And a lot of hospitals, especially in the north of UK, they are already on 24/7 consultant presence. It's like 12-hour shift. So you do one in the morning, one in the evening. And they are making them resident on-call consultant. And the resident on-call consultant, I think it is more like a glorified senior registrar position, because working week has gone down to 48 hours. So when I was in training, before me, I heard it used to be 120 hours when I think it was your time. Yeah. Then they started reducing. When I did, it was about 100 hours or so. They brought it down, and with 48 hours, it's the trainee mindset has changed over there. You don't get theater because you are off after night. You ask somebody, "Oh, I'm on 0 hour today. I cannot come." Okay. So how did you learn that? I mean, essentially, I used to look at it that this is my own development. So if you are going on 0 hours, it's like going to a course. End of the day, you are going to bring in something, but things have changed over there and it's all going down. And as a result of that, sometimes we wonder that this generation, when they will start looking after us, how will we cope at that time? But I think that the new generation is smarter. They work differently. When we were there, we would be just focused on books. And I will talk about it when we talk about MRCOG part 2 and 3. And I was really shocked. And the way people study over here, even for part 1, I remember reading Robbins' Pathology, Gray's Anatomy, R.J. Last. Over there, they have never even heard the name. I'm sure you would have read Shaw's Gynecology. Have you heard the name? Or Dewhurst? Over there, nobody knows which textbook is that. People, they don't read textbooks. And that's where they, because their basics are very good, they are able to get away with that. And for us, I think, struggle to, we are very good with basics, but we don't use our time efficiently and we waste a lot of time. Then gynae surgery is significantly reduced. Now we don't even have many gynae theaters. Like we would have about 4 or 5 hysterectomies. As I said, that Marina has revolutionized everything. Endometrial ablation has revolutionized everything. When I was in training, I was finishing off my training and I saw that my seniors who were sitting over there, they were not keen to give up their theaters. And it was a national problem. So then I started looking at things that how should I train myself? So at that time, there was quite a lot of interest in outpatient hysteroscopy. So I then started going to Italy. At that time, I would book a 1-week annual leave or study leave, something like that, and go to Italy, identify the guy over there. And then he said to me, the first day I went over there, I didn't speak any Italian. And he said to me, I can bet by the time you go at the end of this week, you will be performing hysteroscopies much better than your consultants. And that was absolutely right. I used to do about 20 to 25 cases and with all these Versa point and everything in outpatient setting. And that was really a transformational thing that then I decided this is the way forward and I should go for them. And now we remove polyps, fibroids, even endometrial ablation, this NovaSure endometrial ablation, I do it in outpatient setting. And I feel more scared when I have to do these things under GA now in a patient, because I've become so used to it that I know when the patient winces that this is the time to stop, I can carry on here. Under GA, I feel scared because one, the instruments are bigger over there because in outpatient clinic, they give you really smaller instruments. And it's just one of those things that people who are more used to main theater surgery, when they come to outpatient, they feel scared. We used to do eSure, which was outpatient hysteroscopic sterilization. Have you heard of the name? So that was a phenomenal thing, especially women with 3 cesareans, 4 previous cesareans, where you can't even see the tubes, and you go and you put them. And but then that unfortunately has become obsolete. It was withdrawn. Anyhow, so then the last thing is that revalidation. GMC brought in changes as well. Now you could have GMC registration, but if you are not going to practice, you are not going to maintain your the evidence that you have been involved in teaching, training, GMC will not revalidate you. So you have to prove to them every 5 years or so that I have been doing these things, and then the hospital, basically, you have your appraisal done by the hospital, and then it gets, they send a recommendation that this doctor is complying with these things, so it can be revalidated. So GMC, once you get GMC registration, if you get licensed to practice in order to work, if you are not working in UK and you don't want to pay that extra fee for that, you can maintain your GMC registration, but you don't need to then have the bits for revalidation, which becomes a problem. A lot of people, when you go to, say, Middle East, because there is no dedicated authorized body over there, which would be able to revalidate for you, then you become stuck in that sort of situation. So you might be able to do it for 1-2 years, PhD, then you just hold GMC registration and your license of practice then goes. Everything is on Royal College website, Health Education England website, DMJ Careers website. Now, you have to look for this information. We cannot spoon feed you. And unfortunately, a lot of our trainees, they want to be spoon fed. And I am completely against that. And as they say in Farsi, daste khud daame khud, that it's your own hand and your mouth, so you put it in your mouth, whatever you want to eat. So please look for all this information. Thank you. Any questions?
5 minutes break or
You want 5-minute break or I'm okay? No, I'm concerned about them. If they are tired, then yeah, that's fine. Okay, you can have 2 minutes break. How many of you are medical students? Are you medical students? Residents? Others? What are others? Households. Carry on, I'm already half an hour late, so. Okay, so let's move on to MRCOG part 2. Now, if a lot of you are house officers, then ideally there should have been part 1, but part 1 is very theoretical. And to tell you the truth, I was not good in part 1 myself. I passed it, I think, on 2nd or 3rd attempt. And when I did MRCOG part 1, it was very different. We didn't have internet at that time. And they used to throw in questions at that time that this cheese should not be, blue cheese should not be eaten in pregnancy. And where do we have blue cheese in Pakistan? And I had no idea how to answer those questions. When I went to, because at that time part 1 was in UK. So I used to go around supermarkets over there. They used to have these leaflets for pregnant women outside. So I would get all those leaflets and read, and then I used to know that, okay, this type of cheese you can have, because they used to still give very practical type of questions at that time. So MRCOG part 1, very theoretical, so you have to be good at it, and most of you, I'm sure, are good at it. So let's talk about MRCOG part 2. How many of you have done part 2 already? Anybody? Nobody. Who is planning to, or who has done MRCOG part 1? You have done part 1. You have done 1 as well. Okay. Right. So if still there are things that you can relate to part 1, which would come handy for you later. So first of all, why do you want to do MRCOG? You have got FCPS. FCPS is a good recognized degree. So I used to think that MRCOG is more prestigious at that time. And it's an international postgraduate qualification. It's recognized all over. And then I used to think I will come back to UK and it will be different. Even my going into Obs and Gynae way back in '94, when I told my father that I want to do Obs and Gynae and I want to submit my application form for part 1, you know, I told him that I'm originally from Lahore, graduated from Pindi. We were having breakfast and I said this to him and he said, what do you want to do? I said, Obs and Gynae. You know, there was pin drop silence on the table. And I still remember his words. He said to me, can't you think of any other specialty? Then I said to him, look at Dr. Rashid Latif, look at Professor Saeed. I mean, these were big names at that time in the 90s. And I said, see, they are the good ones. And if I do it, maybe tomorrow I will replace them. And that's how then he became. Otherwise, it's like a taboo. And a lot of you might have seen that Indian movie, Dr. G. And also there was one Pakistani drama as well, in which they showed that the Rishta comes for a girl from, and they say the guy is a gynecologist, and he's a gynecologist. So it is a very rewarding field, and my interest was that one of my neighbors, Saqib, Najm Saqib, so he used to be my next door neighbor, and we started in Allama Iqbal as first year medical student, and I was, I think, in class 8 at that time, and we used to talk, and then gradually I developed that interest. And then I told you that when I was in med school, I started becoming very interested into that. And I used to think I can have a good private practice as well if I am good at it. And when I did Obs and Gynae at Sheikh Zayed, Professor Saeed at that time said to us, we were 3 boys, one is Ikram, who's Sheikh Zayed, the other one is Asim Talib. So we 3 started together, and Saeed Saab said to us, if you want to practice as a male gynecologist, you have to be very good at it. And he really killed us. He used to put us alternate day on call, and he was brutal about it. But I think that hard work paid off. So first of all, what are the requirements for MRCOG? And everything is on the college website. Okay, so we don't need to go into the details of that, because if I tell you something, it can become outdated by tomorrow, but look at it. So you have to fill in all those requirements, and you need to know what to do. Now, have you ever seen this? Anybody seen this before? There is a story channel that one company decided to launch a new cola in the Middle East. So they hired a sales rep, and then they sent it to Saudi Arabia. And they said to him that we are going to promote this over there. That guy got very excited. He designed a poster. And then he designed this poster to show that you are in a desert, you are completely exhausted, you drink the cola, and then you are ready. After that, they launched this poster, and after that, the sales hit from it. It was a got that fully. And what would be the next? Yes, because what he did not realize was that so they use Arabic language. Arabic language you read it from this side. So if you read from this side, it will give you completely different picture. So he was thinking in his mind of going from here to there. So that's why when you decide to go for MRCOG Part 2 or Part 3, it is a UK exam. You have to think about UK, and that's why I brought in this NHS structure and all that. Unless you don't know, you will not be able to succeed. So now Part 2 has become computer based. So you can sit here and do that. In my times, it was a useful opportunity to go out and do that. So there are two papers. Paper 1, paper 2. Even when it was physical, so still used to have the same. Each paper is 3 hours, which is 180 minutes, and then you have SBAs and EMQs mixed within them. So both the papers they would have similar format. You may not know that whether your biology will come in this one, and human medicine will be this one, or oncology, or this is all gynae, or this is all obstetrics. They just mix them, and the questions will be random. So when you start preparing for it, first of all, look at RCG website. You need to become familiar with what is on RCG website. Read everything about Part 2 MRCOG. In good old days when I did, they used to send us booklets at that time, which would have information about that. Now everything is on the website, and there is a lot of information over there. The most important things that you need to read is reading of guidance. They are all on the Royal College site. They are all free. You don't even need to register for it, because most of the questions that you will get will be post-history. Don't waste time reading textbooks only. Because when you read, it's good to read textbook when you first time to develop a concept of something, but then afterwards be smart. Subscribe to this journal if you can, Obstetrics, Gynae, or Productive Medicine. I'm a great fan of this journal. What they do is they would have a theme, and they would give 4 or 5 topics in there, and every 3 years they keep revising. So you will have the most up-to-date information in this one. So this is very useful. Then top, this is the obstetrician gynecologist. This is the RCOG journal as well. You have to read that. All the talks for last, I would say, 4 or 5 years, you must read them. Strategy is the RCOG e-learning platform. You must go through that. You have to subscribe to it, and then you would be able to go through different reviews. And I will tell you why these things are important. NICE guidelines, if you go on NICE, it's National Institute of Clinical Excellence. So this is the central body which would give these guidelines about different aspects. You can't remember each and everything from those guidelines because they will be 200 pages long. There will always be an executive summary in the beginning. Read that. And then you can make your notes over there. When they develop these guidelines, they look at NICE guidelines. So that's how they incorporate people. Because NICE is the ultimate body which will say, do this, don't do this. And then you have to practice mock SBAs, EMQs, and all. Now, why these things are important? That when you are developing SBAs and EMQs, I used to be part of that committee which used to make EMQs and SBAs. It's the process is like they will say to me that okay, you write down one EMQ and one SBA. Now, what am I going to do? It's not that I will sit down and start thinking of something. I will think whenever I read something. It could be I read a topic, recent article in talk, or it could be I read a recent like that. And then, based on that, I will start developing that question. And when that question is developed, it's not that I will say, I've done this question, they will put it in the exam. No. It goes through massive sort of scrutiny. There is a committee I will say that this is my question, and then there will be 20 people sitting over there. Everybody will start criticizing, and they do complete post-mortem of that question, to the extent that it used to be very disappointing and disheartening. So then ultimately I left it. But that's the process. It's not easy. When they do it, which is justifiable, to make it uniform, because when 20 people are sitting, everybody is thinking differently, and they will say, no, this is unfair. People who are not working in UK, they will not know anything at all about it. And especially local people, these local white people, they're very touchy about that. And I have seen, they have said, this person is coming for this exam. They should be knowing what happens in UK. Because if I'm sitting there, I will give you this benefit that okay, thoda sa tas khaya, koi nahi, usko pata nahi. They don't budge about it. They say it should be like that. So a lot of post-mortem, and then these questions, they go through. The majority, they get discarded. If they are reasonable or they modify them, then they will put it college courses. So they will trial them, and then they see how people perform on that. And if they think this is worth keeping, then they will keep it. And ultimately, the really high quality ones are the ones which go to the exam. Like I read once, there was an article in Talk on suture material. And then I started writing up a question based on that, because that was something which I've read recently. A lot of people, that's what they do, because people are busy. College, when you are involved in their committees, they don't pay you anything. So you are doing it just out of goodwill. And that's why people, they don't want to spend too much time unless you are retired. So you would look for things that are useful. Then you can attend UK courses, you can do international courses. There are a lot of courses which are online. End of the day, the main thing which matters is practice. A lot of people, they read a lot, but they don't practice, because there is a technique to practice EMQs and SPAs. And if you don't get the hang of it, no matter whatever you have read, you will not be able to do that. Then time management is another thing. That within 3 hours, you have to do these 100 questions. Now, nobody is going to tell you anything, when to do, which one to do. Both the papers are given to you, and then it's your choice. So they say that you should attempt the questions that you find difficult first. Everybody is different. When I used to do my exams, I used to prefer doing questions that I know, so I do them quickly and then move forward. Some people, they prefer the opposite. So end of the day, it's your choice. However, they say that for SBAs are relatively easier because there is less to read. So you should spend about 70 minutes on SBA questions and then 110 minutes on EMQs, because there's a lot to read. And then sometimes, our English is not that great, so we go slowly and then we waste too much time on there. So that's what I've told you. So these extended magic questions, they replaced those MCQs and all that, because they think that it assesses your core medical knowledge, and then they give you a scenario and then you have to choose the best answer for that. So that way they are checking if you are able to deal with that complexity in that or not. And then guessing is harder. And there's good evidence that they are the fairest format. And then it's all machine read. So now electronic, it's all easier. And as I said, that they are difficult to set. So they are based around a topic or a theme. As I said, that like the suture material one, the way that I started developing, it is composed of 3 parts, each EMQ. There is a lead-in statement or paragraph describing the basis for matching. There is a list of options and then a number of items. So that's how it looks like. That when you look at it, you see a lot of options. Then you have got the instructions, and then here is the actual question. So now when you start looking at it, you have to look at the lead-in statement. So this is the lead-in statement, because this is going to tell you that what exactly wants to do. Then you have the question at the bottom, and then you have got these options. So when you are going through these options, they could be 5 to 20. There are a lot of them, and they could be alphabetical, or they could be just randomly spread. So now what you have to do is that you have to look at the options or read the question and then look at the options and see which one you think is the best answer. And that's how you will answer a single best or the most appropriate, because that is telling you about your thinking process. Sometimes when you look, you might see that 2 options, 3 options, they're all accurate, but there would be something within this leading statement which would then tell you what exactly are they looking for. So if you look here it says each of the following scenarios relate with women with breast disorder, and then select the single most appropriate initial investigation. Now, here is initial is the word which would give you the clue what they are looking for. And if you don't focus on that, then you will not be able to reach to the right diagnosis, and then you exclude options which are false. So when you start looking at it, so have a look at this question. This is the question, and then you have got this lead-in statement over there. And when you look at the options, so there is these options. If you start looking at it, then what you have to do is we call it cover text. That once you have read the question, then you have read the legal statement, you should be able to have something in your mind that this is the answer. And then from there, you are going to see, is it there? If it is there, that means that's your right answer. If it is not there, then you can discard that. And this is where it takes time to get used to it. If you are not going to practice, you will not be able to get good at it. Now let's have a look at this. So read this question. Brown vaginal loss for 7 days. She's on combined pill, speculum, vagina atrophic, cervix is normal, bimanual examination is unremarkable. So you have already thought about something. You might have some thoughts in your mind. And sorry, it was, I think yeah, so this was the EMQ option before that question. Now, when you look at it, you will go through that cervical cytology. There was nothing related to that in that question. Screen, nothing, CT, nothing. All this, you start going back through that list. When you reach this last one, ultrasound scan, then you would pick that option. The reason for that is for MRCOG part 2, part 3, always choose something which is less invasive. Don't jump to an answer. If it is saying initial investigation, initial should be least invasive. So a speculum would be less invasive than ultrasound scan. Ultrasound scan would be less invasive than a CT scan or MRI scan or hysteroscopy. So go from bottom and then go. Then, as I said, that you read the lead-in statement and then the questions first, and then work out your answer without looking at that list. Because if you read that question and the lead-in statement, it should have come to your mind what would be the initial investigation for somebody who's having this irregular bleeding or spotting. And same thing for SBAs as well. And the ideal question should pass the cover test. That you should not be looking at the options. You should be able to answer that question. And then within SBAs, so you have a STEM, which is used as to test application of your knowledge. And then instead of asking for a list of features of CTG, they would put it like this, that they would put in a CTG and then say that based on the variability of 5 beats per minute, the CTG is normal or something like that. Nobody would say, look at this CTG and tell us, is it normal or abnormal? And all these SPAs, EMQs, they are based around curriculum, and the questions would be relating to all of them. like the CTG1, if you have a look at it. So this is the stem that interpret the above fetal heart monitoring trace using definitions and classification of NICE 2007 guideline. Now, if you have not read NICE guideline, you will not be able to answer that. If you have read NICE guideline, because there is a chart over there that will talk about those bits, and then you would be able to answer them. And then it says, which is the single most accurate description of the tracing? Now, they are not going to give you many options, and they will not ask you which statement is correct. So you have to look at it, that what is the accurate description of the tracing. And then it would be like this based on the NICE guideline. If you look at the bottom, and then you will choose it from there. Sometimes they put some distractors in there, and that is deliberately to distract you. But remember, most of the time, they want you to pass the exam. So they don't really put difficult questions. The questions are there. Sometimes we fail as candidates because we start thinking too much, and we start thinking, maybe the examiner wanted to ask this, but examiner didn't ask you about that. And this is where that people start filling in MCQs and SBAs. Right. So part 2 is still more factual knowledge exam, and you need to have some knowledge which comes from those sources that I mentioned to you earlier. And then for part 3, you require more clinical aspects. And that's it really. So the main thing is read the question, time management, and stop writing when you are asked. And then also attempt every question. A lot of people, they have this habit that they leave some questions in the middle, and then you forget to go back. Obviously, if you have not attempted all, you will not get score for that. Okay. I'm just going to go through very quickly through part 3. I'm sorry that I've taken that much. So when you start preparing for part 3, you have to practice. And the practice would be with somebody who has worked in UK, who knows that system, or who has recently passed the exam, because then they would be more up to date about that. And then there are 14 tasks basically in the exam, and all these 14 tasks, they are essentially going through all these different modules of the curriculum. And each task is about 12 minutes in length, which involves 2 minutes of reading time. When you go there, they put screens there. So the question will be pasted outside. So when you stand there, you are reading that question. Inside the examiner will be marking the previous question, and then you move on. There's a clinical examiner on 14 tasks, and lay examiner on 4. Some people who are interested in education, they've got nothing to do with that. It could be a lawyer, it could be a magistrate, it could be a social worker, or it just invites applications, they apply, and then they are interested. So essentially their job is they are sitting there, they are looking at you, and then they give their opinion that they don't have any clinical knowledge, but their opinion is more on professionalism. And would they be happy to see you as a doctor or not? Then there are 2 types of tasks. Normally, it could be structured discussion, say like management of something or audit or whatever. Increasingly, they are moving towards simulated patient colleague, and there they would have a role player sitting as well. And I think last year or the year before, there was a station, they went over there, no female sitting over there, man sitting over there. And that man wanted to become a woman, and that's how the whole discussion was going around. So obviously, when you are in that sort of setup, you walk into the room and you don't even see a female role player. It would be nerve-wracking at that time. So in every examiner gets a sheet where they have to mark the candidate based on these 3 things, which are patient safety, communicating with patient and families, communicating with colleagues, information gathering, applied clinical knowledge. And then essentially what you want is that you want to make sure that this doctor is safe, and you are happy to work with this trainee or doctor as a colleague, that they are safe, they can tell the patients clearly, and they can discuss things with their colleagues as well, and they are able to gather relevant information and apply their clinical knowledge. So end of the day, as a candidate, your job is to go over and prove that you are able to manage. There are scenarios you might not be able to manage yourself, but you can signpost the patient to go to another center for expert opinion. And then as examiners, we don't have to score you, we just have to give pass, borderline, or fail. If you are really bad, then you will be failed. If you are really good, you will pass. Majority of people, they pass because there is another category, borderline pass and borderline fail. So if you have done well in most of the things, I might say, okay, let's pass this person. If you are struggling and I have to give you too many prompts to keep you on the track, then in that case, I will say that, no, I would rather fail this person. Then examiners are different as well. A lot of time when I went for the exam first time, they actually did a feedback for us and they sent it to me as an examiner. And it was interesting to see. I used to think I'm a very soft person and I give generously marks. When I got the results, so those are the people who are known as doves. So it turned out that I'm actually a hawk, and which was completely eye-opening for me. And I had no idea about myself. So these exams are useful opportunity to learn about yourself as well. Then the top tips for the part 3 exam is practice. I told you empathy. Empathy is that you put yourself in patient's shoes and then experience that. There is something called empathy and sympathy. It's not sympathy, we are talking about empathy. We are poor in empathizing with others. I think it's probably as Pakistanis, we are not accustomed to that if something has happened, that okay, it happened, so what? It's a fact of life. But in exam, you have to, I'm really sorry to hear about it. How are you feeling? Here's the tissue paper. Do you need some water? इस तरह थोड़ा सा कहानी आपने उसके साथ डालनी. That is sympathy rather than सीधा सीधा कि बीबी तुम्हें कैंसर है. ठीक? Then when you go for the exam, always notice what's on the table. Sometimes there would be a forceps sitting over there. There could be a mannequin. And your job is to perform something, or it could be a foam, they have put in a foam over there, or once there was bridging thromboprophylaxis, everything was pasted over there. But then when the candidates, they come in, they become so stressed that they don't even look what is on the table. There was one exam where people were supposed to do instrumental delivery, demonstrate instrumental delivery, because they had put mannequin as well and forceps. A lot of people, they didn't do that. And it is primarily the overseas doctors because they become more apprehensive and they are in that situation. Then when you go into the room, then you don't need to shake hands. A lot of people, they start thinking, do I need to shake hands with the examiner or not? Then dress appropriately as well. You don't have to worry about if you've never worn trousers. Don't try to wear trousers that day. I have seen a lot of people who go from India, Pakistan, that they are wearing these jackets. So jackets are like, they are going like that, and trousers are like this big. So why you have to go through that? So you can go wearing shalwar kameez as well. So it's absolutely, as long as you are looking professional, it's fine. So nobody is going to score you based on what you are wearing. And I've seen that people look uncomfortable. I was very poor with interviews myself. And then when I started doing interviews for others, I look at people, when they are doing the interview, I look under the table, how their feet are. Because when I used to give interviews, I would be like, my legs are moving and all that. And then I realized that that person would be anxious. And sometimes I would give them something like a clue or something to relax them, and then gradually, so they get back on track. Another thing is that avoid, sometimes we don't realize. A lot of time we're doing things and then we're doing that, okay, I know. So you avoid these sort of things. And these things, they come with practice. When you're practicing with some of your friends or colleagues, ask them to give you that feedback. Don't argue with examiner. I have seen people who started arguing with examiner. Now, as examiner, there are times if I go, I remember that I was the examiner, and the session I got was on psychiatric disorders in pregnancy. I had absolutely no idea that what is that DCM, that thing, the diagnostic and statistical. Yeah, DSM-5. That's American. That's American, but there was a question that said that this patient has got this DSM-5 something written over here. I had absolutely no idea. So when they tell us in the morning that this is the task that you are going to do, first you have to quickly go through that yourself. And what they do is people come together in a room because there are 5 circuits running. So 5 of different examiners are doing the same question in 5 different circuits. They will all sit together in the room. They will discuss what they know about that. Some of them, they will have no idea. They will say, oh, I'm an oncologist. I don't know anything about obstetrics. And then we will have exchange of ideas, somebody who knows, or will quickly go through that question, discuss that, and then practice among examiners as a role player. That we will say, okay, I will become the candidate. Let's do it ourselves for practice run. And that really helps, because then at least you know where to judge people. If you don't know much, go safely, MDT discussions, multidisciplinary, involve others. Don't just say, I will try to manage everything myself. Mention that I will give leaflet to the patient. Increasingly, we see patients with same-sex couple who will come in. They are asking for a fertility investigation or fertility treatment. Transgenders, that's another new thing. And then you have to be very careful with that, that she was he, but she's she now, or she was she and she's he, because those people are very touchy about that. And then in exam, they might not put in a transgender, but then if they find, because increasingly in UK, you see these people who are becoming more, I would say, coming into the mainstream, then it would be very difficult for you, because if you ask me, I probably would have felt very uncomfortable in the beginning. Recently had a patient who came to A&E, and he was working in police, big muscles and tattoos and all that, and came with abdominal pain. Previously had appendix removed. Surgeons, they were not interested in seeing. Then when they called gynae, because she still had ovaries and uterus, and then, but because has been on very high doses of testosterone, if you look at him with the beard and all that, now you won't even think that this is she, but because uterus and all that is there, she would just CT scan and everything was atrophic and all that, and they managed to send it, because sometimes obs and gynae is the dumping ground in A&E, and nobody accepts anything. It's like obs and gynae problem. You do that. So these are the ones that practice some sessions about these things, that how you are going to talk to these people, because they are very touchy. If because that guy, my SHO said to me that it just came out that he is he, but I said I need to do a vaginal examination. So, you know, it's a very uncomfortable sort of feeling, even as a doctor talking about it. But that's the normal thing. And I won't be surprised if this comes in exam in next, within 1-2 years time. Then when you have role players sitting over there, role players are actually professional actors. Some of them, they do theaters. Some of them, they are in drama school, and they are doing actually this for extra money. And it could be a male, and the purpose of putting that male could be the like fertility station, that they want to discuss about something, whether it's a transition or whether fertility management for azoospermia or something like that. Then speak loud and clear, especially as the exam is now online. So you have to be very clear, because as examiner, for us, it's very difficult over there. A lot of people, they are not volunteering for part 3 exams, especially when it is for overseas. Like in February, there is exam, and they are desperate for people to come forward as examiners. The reason I've done it last year, I don't want to do it, because they want us to log in at 6 o'clock in the morning. Now imagine, even if I take study leave or professional leave, I'm sitting at home. I can't just get out of bed and then sit in front of the computer. I have to get up, I have to get dressed as if I'm going to an actual exam. That means I have to get up at 5 o'clock because of the time difference. They start the exam early. And for us, it becomes very long day. So examiner won't be interested. People who are sitting over there, if you are not talking clearly, nobody is going to then give you benefit of that. Don't worry about perfect English skills. As long as you are able to convey the message and the examiner understands, it's absolutely fine. And one of the things was that, which I particularly noticed, when we go from here, we are not used to speaking English. And when you first time start talking in English, you feel uncomfortable. And there was a Pakistani Khatun, she said to the patient, well, it was Indian, I think. She said, how do you want to call me? So I think what she meant was, how you want me to call you? She kept on saying, how do you want to call me? So it was a role player. Role player said, what do you mean? How do you want to call me? 3 times she said that. Then ultimately she said, it's okay, you can call me with my last name and all that. As examiner, if I'm sitting over there and it's a role player station, I have got zip on my mouth. I'm not supposed to interact with anything. I'm just listening, and they will carry on. Then the whole consultation has to be patient-centered. Patient can say no to any treatment. It might be completely unreasonable option, and you have to just accept to that whatever she says, that's her choice. End of the day, even if she is choosing the wrong option, you cannot say to her, you have to give her pros and cons, and then ultimately go with whatever she wants to say. Then you should be able to convey bad news, and bad news, as said, that like cancer or something like that, or fetal abnormalities. So you have to practice that. You can't just sit there and start that I have to tell you that you have got this. At the same time, be honest with the patient. Like there was in one of the exams 2 years ago, there was a question about cardiomyopathy. And over there, what they wanted was on the examiner sheet that you are having discussion with the patient, she has become pregnant. You have to tell her that she's going to die if she continues with the pregnancy. And then the candidates are saying, don't worry, everything will be okay. Don't worry, everything will be okay. So it won't be okay like that. And don't give false hopes that somebody who has got advanced cancer, you have to tell them that, okay, that's how unfortunately situation is. Similarly, sometimes this is also one of the big issues in UK, domestic violence that they are trying to pick. So they might have a woman who's sitting over there with bluish bruises and all that, and then she will keep that arm in front of you just like that, so you could see there's a bruise. So when you look at that, notice that sometimes that could be the clue for that. And these things, they do matter. And then increasingly, they are putting these sort of stations there. I mean, this is just like a neighborhood board. And then they would have different patients in names and what conditions they are in and all that. And then they would ask you to prioritize that you are on call, you have got these patients, you have got this staff, which patient you are going to see first and why, and how you are going to proceed further. Okay, that's it. Any questions?
Thank you. My name is Dr. From finally resident in First of all, thank you for this informative session and thank you for reading this. And also thank you because many residents like me see people like you and think they are male gynecologist or now. Thank you for that. And I was coming to that. That's the I had somebody to look to as well. So thank you for that. Because I just wanted to ask about the MRCG part 2 because considering that within residency as well, the duty hours and stuff. So how much time roughly is needed to actually prepare them? Because I know it's relative for every person how they study, but just a timeline on how to manage things and roughly on what months or weeks are you looking at in terms of the study.
Depends on your basic, what you are doing in residency. If you're one of those people who have been involved in teaching and training, you are preparing things, then for you maybe 6 months will be more than enough. However, if you are one of those who have never opened a book and now for the first time you are going to sit and read the book, or somebody who has done FCPS, they have knowledge, practical knowledge. You just need to fine-tune that in a way that you are directing it for the exam. So everybody would be different. So, but 6 months would be more than enough. 3 to 6 months is more than enough. A lot of people over there, I have seen that because in UK you keep reading guidelines, you read talk and all that, so you will have some knowledge. So if you have that sort of thing, even 3 months is more. But the job it can be a bit
When you talk about MRCG part 3, I think it's because I'm doing lab 2 as well. I think it's pretty similar to how they conduct lab 2. Or is it like?
It is similar. It is similar. Obviously, lab 2 is much more generic and simple. It is the same. Like if it was this sort of room, they would put some partitions there. So one person is sitting there, one there, and that's how they do it.
How much cost me it to be because हमारे दिमाग में ये मार्क्स करना
यहाँ से भी तो जा सकते हैं, ये भी तो आराम है, तो अच्छी भी जा सकते हैं। ट्रैवलिंग आपकी खत्म हो गई, आप ट्रैवलिंग personally I think that yes, RCG का जॉब यहाँ पे लगता है कोर्स की प्राइस है। There are people who can deliver the similar sort of information or practice without RCG. RCG people pay for franchise courses which charge 20%. So about 30% is for financially viable. अगर आप 5 साल के कर रहे हैं तो उसमें से 30% आपसे भी ले रहे और आपसे भी कुछ भी है। वो ठीक है, स्लाइड्स दे देंगे या कुछ होगा, इसके अलावा unofficial course, I cannot label it as RCG franchise, but it is still useful. And I think we probably will be organizing something if there is anybody interested in that, you guys know. We will probably have a session for our candidates. If somebody is interested, because previously there were 1 or 2 Pakistani candidates who came in and then I said to them, join the group that our own trainings have, because it is useful. When you sit with them, you talk, you listen to them, how they are doing to contribute. So, and that helps a lot. But then at the end of the day, you have to make an effort, because there are people who go over there and then they say, oh, I found the UK first time, I cannot go, can somebody come with me? Nobody is able to come to you, so you just have to make an effort to do that. But there are people making small groups, WhatsApp groups, and they have these sessions together, and that's a very good opportunity. And with online one especially, I think people from Pakistan can join. And I will share the details once I have some more. Okay, thank you very much. I'm sure you are bored of listening to me so far, and I'm really sorry, Dr. Tajammul, I've taken all of your time.
Thank you so much, Dr. Hussain, for a wonderful session. Now we will have small tea break of 15 minutes in cafeteria, and after tea break, our next session will be interactive session. Thank you so much. Our next session is interactive session. Very esteemed professors have joined us. So please feel free to actively participate in the session to get maximum knowledge. Now, I would like to invite Professor Arif Tajamul. Professor Dr. Arif Tajamul is a highly qualified professional. He is the former chairperson IRC RCOG. He represented our country very well. He is also serving as a principal, head of Gynae department at Allama Iqbal Medical College, Jinnah Hospital, Lahore. He is a core member of National Medical and Dental Academic Board that has been tasked with overseeing the standards and practice of education in undergraduate and postgraduate medical and dental college across the country. He has earned the status of veteran due to his vast contribution to the field, earning immense respect by the local and international authorities.
Thank you very much for that exuberant introduction. Thank you, Professor Nazli. And it is an honor and a privilege to be here, especially with you as the new IRC chair, Mashallah. And I am hopeful that जितने अच्छे तरीके से आप इसको चला रहे हैं in future, this is going to excel to new heights. So thank you very much. मेरे काम को बहुत हल्का करना है और उसको बहुत आगे तक ले जाना है. Now, this consists of a few portions. तुम में से जो student है, उनके लिए इसका पहला portion थोड़ा सा जरूरी है. So it might seem a little bit boring to you, but I am going to still do this. Now, हर आदमी एक चीज का सवाल हमेशा करता है, जो कि वो पूजा नहीं करता, पाकिस्तान में छुट्टी करता है. And that is what is stated about it. Why should I do this? And I'm sure तुम में से ज्यादातर लोग जो हैं वो सीरियस नहीं हैं और कंसिडर कर रहे हैं कि हमें MRCOG करनी है और पता नहीं करनी है कि फिर अब चढ़ रहे हैं और सोच रहे हैं something which we all recognize, you know, that's called personal development and professional development. ये concept unfortunately जो हमारी सोच में बढ़ा हुआ है. People have started to cut corners, shortcuts. People have tried easy answers and कौन सा काम कितनी आसानी से किस तरह किया जा सकता है. ठीक है, मुझे इसमें काम क्या करना है कि अगर मैं टेक्स्ट में जाता हूँ तो I'm smart. So I'm smart. मैं मुझे जगह दे. So people have started to become smarter. हम concept भी enjoy, हम shows भी जाके देखें, हम फिल्मों को भी enjoy करें, हम अपने घर को भी पूरा enjoy करें, हम उसके साथ प्रोफेशन को भी बनाएं. हमें हमारी वजह मुझे नहीं मानने का बात जाती है कि पुत्र सिर्फ स्वाद माने, स्वाद इस पता है छूटे की राह होती है और सिर्फ स्वाद डालने का मतलब है कि नॉट एग्जिस्ट, नॉट नो और दुनिया में कोई मौका नहीं. सिर्फ स्वाद माने इसे नॉर्मल लेके ऐसे फिर आता है. So the geography has shifted substantially from our years to this. But having said that, those two words will always remain, but more than two words, capacity building and personal development. So, जब तुम एक नई चीज सीखते हो, नया काम सीखते हो, तो किसी को कोई एहसान नहीं कर रहे. स्पेशली टीचर्स को बिल्कुल एहसान नहीं कर रहे. उन्होंने अपना कुछ कर लिया होता है करना, तो अपने आप को बिल्ड कर रहे. अगर तुम्हें रिस्पॉन्स को भी आ रहा है ऐसे करना है क्या टेक्नोलॉजी बहुत ही प्रोसीजर था. अगर तुम्हारे पास एक एड क्वालिफिकेशन तुम्हारी अपने स्किल की अच्छी लगती है दुनिया में तुम्हारी वैल्यू तो दुनिया में हर आदमी की वैल्यू नहीं आता. दुनिया में कोई आदमी की वैल्यू ऐसे और जब कल तुम लोगों ने अपनी वैल्यू बढ़ानी है these are the values. अगर आप सिर्फ इसी से अपने जीवन को सीखने वेरी हैप्पी का इट्स अ वेरी गुड क्वालिफिकेशन. बट इफ यू हैव FCPS and MRCOG, now you have a qualification which is recognized in Pakistan as well as a qualification which is recognized across the globe. So by doing MRCOG, you are not doing anyone everywhere. The only person you know is yourself. तुम्हें अभी तक ये चीज नहीं हुई है, you were short-sighted. तो तुमने अपना एम खत्म कर दिया है उसे क्वालिफिकेशन ऐसी कुछ करना चाहिए वो मिल जाएगा जो अचीव नहीं करना चाहिए वो मिलेगा कहाँ से जब आपने टारगेटेड टूल सेशन किया तो 4-5 चाबी आराम से बैठ जाओ तो ये चीजें जो कि नहीं आ सकती थोड़ा सा बनाने की जरूरत है so I'm going to take you through communication scenarios where we get this topic a little bit and what we expect about the exam why because of the series coming very important. And then we talk about type of the scenarios, and then actual scenarios. And I'm going to keep it a little bit on a fast pace. ताकि मैं टाइम बहुत आगे तक निकल जाऊँ लेकिन कभी भी अगर आपको लगे कि मेरी स्पीड बहुत ज़्यादा तेज है तो प्लीज स्टॉप because I do want you to get pitches. टोटल कायनात को बने हुए 13.8 बिलियन साल हो गए 1 बिलियन में 9 से बढ़े. So this is the time that all this cosmos universe, the Milky Way has been around. Inside of that has been around for a million 300,000. In other words, it was something like 0.0001%, something like that. So it's not been around long. And just like my last idea is probably because we are the video. Out of that time, humans have been talking for 150,000 years. They have said who are in some of it took about 40 to 50,000 years to develop language. People have a body language which is still connected. All communication is not a language. But जब आप किसी बड़ी से कहीं जाते हो जैसे non-verbal communication, both sides, and that also for example somebody that can get the things ensure that now they can pass over here. Keep an eye on the non-verbal what sort of vibes they are getting from the exam, what sort of cues they are. So that you enter into the exam situation, keep an eye on these things. So communication language is a recap of your exam, 5 basic domains. It has gone away from simple question answer to marking songs into assessing each scenario on these different domains. Every question will not encompass all the 5 domains. किसी सवाल में 4 होंगे, किसी में 3 होंगे, किसी में शायद 5 होंगे, a total of 14 scenarios और 3 पर assessment होगा. अब जो तराजू है वो 1.5 domains. And if you see patient safety, maybe not communicating, not communication, the next is communication. Communication with the colleagues, communication. Information gathering, communication. Applied clinical knowledge, बात करना, communication. 5 में से 4 in one form or the other there is communication. And one of the very close friends who is a psychiatrist says success is 90% public dealing, 10% of. तो अगर आप पब्लिक डीलिंग बहुत अच्छी करते हैं, if you're well versed with communicating, you are already successful. At times of झूठ बोल के बड़ी गलती कर देते हैं. Look at all the politicians. सुबह जब खड़े होकर झूठ बोल रहे होते हैं, लोग कितनी करने वाले हैं. So you don't have to be pious, right, or correct to be successful. It doesn't work that way. Side दुनिया में ही तो पाकिस्तान के लोग के लिए ये वही चीज है. तुम्हारा हिल गया ये बेटे आगे नहीं चल रहा. So core concept of a scenario: exploring patient symptoms, information gathering, explaining the diagnosis, investigation of treatment, whether the information is given. Involvement of patient into this is performed consent gathering. But this is a little more than that. It is not just based on consent or something. It is to come to a joint decision making. क्या patient को involve करते हैं, relatives को involve करते हैं. This is what your own safety is about. And I talk about that here in a minute. Use unfortunately doctor obstetrician को कहने की जरूरत नहीं है. बाकी सारे जो है किसी रसौली की, किसी ट्यूमर की, किसी फजूल चीज की खबर देते हैं. So most of the information passed on by doctors is bad news. So breaking that bad news at times is very tactful. They do आसानी से नहीं है. And then we have to communicate with the doctors as well. और कई बार उनकी perception about a disease or about the patient बिल्कुल फर्क होती है. और आप कुछ और बताने की कोशिश कर रहे होते हैं और उसमें डिसाइड करते हैं. Then you have to be part of the team. या बिल्कुल सिर्फ एक डॉक्टर मरीज का इलाज नहीं, एक पूरा हेल्थ केयर वर्कर से ग्रुप होता है. उसमें इवन जो वार्ड में सफाई करता है वो भी इम्पोर्टेंट है, क्योंकि वो सफाई करके बंद कर दे उस वार्ड में खड़े नहीं हो सकते. So every part of the health care is important. तो ये सोचना कि सिर्फ डॉक्टर मरीज का इलाज करते हैं इस पर कभी नहीं होना. So जब हम कम्युनिकेट करते हैं इन दो मोटी चीजों को हम देखते हैं, प्रोसेस कम्युनिकेट करना कैसे और एक कंटेंट क्या कम्युनिकेट किया जाता है. When we talk about communication, what is the challenge? One, how surrounding कैसे बोलना क्या, भाषा का इस्तेमाल क्या करना है, सराउंडिंग कैसे होनी चाहिए वगैरह, and then actually explain क्या करना है. So in order to do that, you must be aware of the differential diagnosis that may arise from various presentations. बीमारी की different शक्लों में क्या वजूहात हो सकते हैं. Somebody walks in with irregular vaginal bleeding, they can always be more than one, presenting with this symptom, and that is when you start to think, okay, in my diagnosis of the concept. How to explore them independently and then collectively. इनमें से जब तक आप फिगर आउट कर लो कौन सी एग्जैक्ट डायग्नोसिस है, वो सारी साथ साथ चलती. मोर एविडेंस फॉर वन एंड लेस फॉर द अदर. फिर उसके बाद you need to be familiar with most recent guidelines. जिस तरह डॉक्टर सिंह ने कहा था, ग्रेड ऑफ गाइडलाइंस, जर्नल्स, नया लिटरेचर, इसमें एफसीपीएस पे बहुत है. Because FCPS you could still go to your own dose. वैसे आप बाजार से हायर से तो उसके बाद पूरी कोशिश करेंगे पूरा रहता ना मार्केट में तो but then MRCOG works quite differently. You're more interested in less volume of literature, but more pertinent to clinical scenarios. And remember, last time we thought there's a lot of research. No information अपने दिमाग में, it's a hard disk. And if you load it with nonsense, then there will be very small space left for more text. So अगर आप clinically pertinent चीजें लर्न करते हो, नया literature, नया data, उसको correlate और correlate करते हो, then you will be smart about it. लेकिन अगर आपको high risk के 150 सब्जेक्ट याद या आप 90 सब्जेक्ट बड़े से याद कर ले, तो granted that you present the presentation, you mरीज को उसका पता नहीं. तो अगेन कैपेसिटी को need to ask yourself कि जो information मैं obtain कर रहा हूँ ये कर रही हूँ, can I transform this into clinical practice? And if you can't, then probably it's not a wise idea because उसमें बहुत ज़्यादा time spent किया है. ठीक है. And then ये जो सारी चीजें ये आपके उन मरीजों को जिनका हेल्थ केयर से कोई ताल्लुक नहीं है, एडुकेटेड नहीं है, समझानी पड़ेगी कि इस मरीज में इन अद्वियात की क्यों जरूरत है और इस चीज में इस प्रोसीजर की. दिस इज अ डिफिकल्ट, क्योंकि डॉक्टर को तो शायद ये समझाना आसान है, but somebody who has no medical background, at times this becomes quite difficult. And then एक और बड़ी इंपॉर्टेंट चीज उसका मैं आगे भी जिक्र करूंगा, कभी गौर करना, जब तुम मरीजों को बुरी खबर सुना रहे होते हो तो वो सुन रहे कि उसके रिश्तेदार सुन रहे और आधे घंटे के बाद उनमें से कोई ऐसी बात करता है कि आपको ख्याल आया कि जो मैंने पिछले आधे घंटे के बाद इनको तो कुछ भी समझ नहीं है जो मैंने कहा, और आप अपनी तरफ से उनको बड़े वजारत से चीजें बता रहे हैं. इंसानों की आदत है, इंसानों को जिस तरह से स्ट्रेस आए वो अपने दिमाग को वैसे यूज करते हैं. So basically what they're doing is they're camouflaging their brain behind that, and they're listening but they're not actually listening. और ये बड़ी खतरनाक बात होती है, क्योंकि कई बार आप ये सारा एक्सप्लेन करते हो, उसके बाद अगर ट्रीटमेंट कॉम्प्लिकेशन हो जाए तो ये रिश्तेदार जाके कहते हैं मुझे बताया कुछ नहीं और आपको कुछ समझ नहीं आ रही कि मैंने तो सारा बैठ के इनको बताया. How come he is highly caring patients so many, but this is not an uncommon phenomenon. Now, the person history taking the double that is the Calgary Cambridge model. This was designated in 1996. One team in Cambridge, UK, the second team in Calgary, Canada. Now, just say medicine starts running. People have learned the art of talking to patients, obtaining information, or choose over की जाती है हमारा improve करता है. So what they actually did was they formalized कि जो एक patient doctor communication होती है, इसके subset क्या होना चाहिए, ताकि कोई चीज mismatch हो. And this is a very important model, and I would strongly suggest कि इसको थोड़ा सा जरूर पढ़ना. It's not a complicated model, and this is exactly what you do. But the only thing is इसको follow करने का फायदा ये है कि इसमें से रह कुछ नहीं है. सबसे पहले you initiate the section. इसके साथ सलाम अलैकुम, आपका क्या होता है, मेरा नाम ये है, I'll be treating doctor today, so on and so forth. Then you gather information. अच्छा आपका क्या मसला कब शुरू हुआ, so on and so forth. जब आप सारी information दे चुके हो, then you carry out the physical examination, then you explain and plan, and then you close the session. Session close भी करना होता है. और exercise दो फर्क चीजें हो रही है. एक तो आपके सारे सिस्टम को स्ट्रक्चर प्रोवाइड कर रहे हो, दूसरा आप मरीज के साथ एक रिलेशनशिप बिल्ड कर, which is very very important, क्योंकि आपको मरीज की कोऑपरेशन भी याद देना है. इसमें टोटल 21 है पॉइंट्स. अगर इसकी ब्रेकडाउन लो, मैं आज इसमें बात ही ज्यादा करूंगा, लेकिन if you look at the actual model, इसके 21 subsegments, ये सारे 21 में नहीं लिखे. But this is a little breakdown of the previous slide, initiated with preparation, discrimination, identifying, so on and so forth. Again, इसकी बात में ले लेना मुझसे, इसको नोट करने की बहुत जरूरत नहीं है. But all I'm saying is कि उसको standardize करें, ताकि कोई aspect information gathering and giving information is there. But this is an internationally acclaimed model. और ये चल यही रहा सारे. तो थोड़ी सी इसके बारे में नॉलेज रखना वो भी एक और फायदा है. So सबसे पहले जो इनिशिएट सेशन, ठीक है, ये बड़ी इंपॉर्टेंट और खतरनाक बात है. और ये हर इंटरव्यू के लिए भी उतने ह्यूमन ब्रेन takes 6 seconds to form an opinion about something. This holds true for the examinations as well. MRCOG and Beyond 6 seconds. इन 6 सेकंड में आदमी अगले आदमी के बारे में एक ओपिनियन फॉर्म कर देता है अनफॉर्चुनेटली, और उसके बाद ज्यादा चांस ये है कि उस ओपिनियन को छोड़ता है डिस्पाइट कॉन्ट्री एविडेंस. तो लोगों का क्या होता है कि आगे जाके चीजें बेहतर हो जाती है. सम पार्ट ऑफ द ब्रेन रिटेन्स दैट जो फर्स्ट इंटरप्रिटेशन. So if you want to be successful doctors, good doctors, make sure if you first encounter this patient, examiners, seniors, with your juniors, take up. जो impression उसको बन जाएगा वो थोड़ा बहुत modified होगा, but it is very difficult. Offer is safe. ये बार-बार empathy आ रही है, and it is important. Very first one. Empathy is not us. Empathy is more of care. Empathy is कि तुम अगले के बारे में concern हो. तुम्हें अपने वाले को पास नहीं आता, but you care for them. So patient की आपने care करनी है, because trust खाना is looking down upon something. जैसा किसी बड़ी बात नहीं होता है. So empathy उससे फर्क हो सकता है, उसको उस तरह देना चाहिए. Prepare for the encounter, establish a rapport. क्या आप उसके साथ अपनी एक रिलेशनशिप डेवलप करें, मरीज आइडेंटिफाई करें कि आप उसके और उसके लिए अच्छाई करें. Identify the reasons for the consultation. Once this has been done, तब आप आगे. In other words, based on your impact, when you are in the interview, when you really get more information, you will be able to use that information. General inquiry, such a kind of सवाल जो है ना open ended. Repeatedly patients say, पाकिस्तान में बाहर नहीं, कि डॉक्टर्स हमारी पूरी सुनते नहीं, डॉक्टर्स हमें बोलने नहीं देते. हमारे मुल्क में तो बिल्कुल नहीं बोलते, अभी कोई भी में 200 मरीज है, एक एक मरीज पे 3 से 4 मिनट लगते हैं। अनफॉर्चुनेटली जो हमारे रेजिडेंट्स की ट्रेनिंग होती है उसमें मरीज के बोलने का बहुत मौका रहता है, क्योंकि मरीज बोलना शुरू हो जाए तो उस मरीज के आधा घंटा लगेगा, आधा घंटा लगेगा। And when you do that for 4 years, it becomes a second habit, nobody knows. But then patients will complain to general. But remember, सुनने वाला डॉक्टर का अब ना सुनने वाला डॉक्टर तो अपने रिसर्च को हमेशा से जाता है कि कल को अच्छे डॉक्टर बनना क्योंकि और 15 सक्सेसफुल डॉक्टर है और सिर्फ जाके उनके साथ आपने घंटा स्पेंड किया और सिर्फ ऑब्जर्व किया और अगर वो ये बताता था कि the traits that he was very common to them, that they are very talkative. कोई बता जाके उससे बात कर सकते हैं, ये नहीं होता कि उनको देख के आप झिझक के पीछे। दूसरा, because of profession, you've got all the time in the world. अगर पूरे पॉइंट खड़ा करके एक सवाल करते हो उनमें से एक भी बंदा तुम्हें ये नहीं करेगा कि मेरा सामान को मेरे पास नहीं। चांसेस आर दैट दे विल गिव यू द टाइम। जब तुमसे बात करेंगे तुम्हारे लेवल पे आके बात करेंगे, कभी अगर तुम लाइट छोटे और क्लियर उनके मुकाबले में वो बड़े सक्सेस। These traits are common successful people. और अगर ये तुम अपने अंदर डेवलप करोगे only then you will enter their job. वरना तुम उससे बाहर सड़कों पे नहीं लगा के डॉक्टर you need to decide तुम्हें इसमें से किस तरफ जाना है. So it is very very important. थोड़ी सी डायरेक्शन मिली पड़ता है। अगर मरीज बिल्कुल ही ऑफ द चार्ट जा रहा हो कि बिल्कुल खाली घर पर चढ़ रही है उसके बाद रात के समय पर मुझे उसके नीचे से उतरना उसके बाद घर जाकर मुझे ब्लीडिंग शुरू हुई यहाँ तक तो चलो, लेकिन अगर वो ब्लीडिंग के पीछे चल पड़े तो कहीं खैर से पूरा सॉफ्ट की तरफ होना पड़ता है। बट मैंने जेंटल कहा in other words forcibly खींच के नहीं आता। But then most of these questions have to be open. But then ask specific questions as well. क्योंकि मरीज डॉक्टर नहीं, वो उसकी प्रॉब्लम के लिए कोई पर्टिकुलर सवाल पूछने की आदत है, और दैट्स वंस यू फॉर्म सम ओपिनियन अबाउट द प्रॉब्लम। उसके बाद डिस्कस इट विद पेशेंट। मेरे फॉर्म में ये हो रहा है, वो हो रहा है, मरीज से फिर पूछो। आई ऑलवेज आस्क हिम, क्या कोई ऐसा सवाल तो नहीं है जो मैंने भी पूछा है, क्या कोई ऐसी कंडीशन है जिसके बारे में आपको नहीं बताया, लेकिन ये माय इनफिनिट विजडम, मैं ये सोचता हूं कि मैंने हर चीज पूछी। लेकिन आपसे करंट मिस हो जाता है, कहीं कहीं प्रेस का ऑडियो मिस हो जाता है, आपने नहीं पूछा होगा, मरीज ने बताया नहीं होगा। तो एट द इंटरव्यू आई ऑलरेडी आस्क्ड कोई चीज है तो नहीं जो आपने मुझे नहीं बताया। तो ये मेरी अमेरिका के टाइम से आदत है, और जनरेटेड प्रॉब्लम्स जब मैं पूरी हिस्ट्री हर चीज कंप्लीट कर लेता हूं तो मैं लिखता हूं प्रॉब्लम्स, एक्टिव प्रॉब्लम्स कौन सी, इनएक्टिव कौन सी, क्यों? क्योंकि उनको कोरिलेट करके जो मैंने मैनेजमेंट प्लान बनाने में लगी है साहब, मुझे सिखाया गया था कि हर मरीज को हिस्ट्री एग्जामिनेशन में ट्रीट करके अपने प्रॉब्लम बेस्ड है। प्रॉब्लम नंबर 1 है तो फिर मुझे उनको एड्रेस करना है, जनरली देख लो वही तो चीजें उसमें से मिस हो गई। Shared understanding, जो मैं पहले बात कर रहा था, at times I would write that yes, it's stage 3 ovarian cancer, and the prognosis has been explained to the son and the daughter of the patient, right? Because कई बार आपने अपने आप को डिक्लेयर करना होता है कि हाँ मैंने इनको समझा दिया, and at times I would ask them 2 or 3 times मुझे तो लगता है कि जिस तरह हम जा रहे हैं अगर इन्वेस्टिगेशन बढ़ती गई तो वो पैसा आएगा कि सारी पेशेंट डॉक्टर इंटरेक्शन को क्लियर करके आएगा। डॉक्टर्स इनको बताएंगे कि क्या शुरू हो जाएगी, क्योंकि जब हम मरीज को प्रॉब्लम एक्सप्लेन करते हैं तो वी नीड टू डॉक्यूमेंट इट। ऐसे हम लगाओ जैसा पुलिस वालों का हो गया, एग्जैक्टली बताओ पुलिस को बताया गया जा रहा है और उसका क्या है, मे बी विल गेट 10 15 years and then it has to be a shared decision. You have to ask for the patient's consent as well. I mean, there are patients who don't want to. आप साइजिटी हो, आपने एक फैसला कर देना है कि वो भी फर्स्ट फैसला। So it's always the patient's right. अगर मैंने साहब उसको मेंटली डिक्लेयर करो, इसलिए आप नहीं कर सकते। आप उसको हेल्प कर सकते हो इन द डिसीजन, but ultimately the patient has to say yes, The patient has to sign a consent. And then you close the session. It's motivational. थोड़ा मरीजों को टच को जो आपको के डॉक्टर तक आ जाता है, वो दुखी हुआ होता है। Especially सबसे जो बेचारे परेशान मरीज होते हैं, वो होते हैं कामयाब, सक्सेसफुल, पावरफुल लोग। तो सारी जिंदगी है हमारे और बीमारी जो है वो सबसे पहले आपको हेल्प है, उसके बाद कुछ होता है। फर्स्ट विक्टिम इज रिक्वायर्ड टू सेल्फ एस्टीम और सेल्फ रिस्पेक्ट। बीमारी में बाकी चीजें बाद में आती हैं, ये चीजें पहले आती हैं। तो इन मरीजों को जरूरत होता है आप उनको इनकरेज करें, उनको फैसिलिटेट करें। मतलब उस बीमारी में भी हिम्मत करें। The patient should not lose their faith. So, answer to the question to follow initial. समझ आ रही है तो मैं लोगों को ये अपने जूनियर्स का पता है, मेरे कई शरीर बच्चे भी ऐसे होते हैं, उन्होंने कैंप में जब मैं असिस्टेंट प्रोफेसर तब मैं पढ़ाया है, जब मैं एसोसिएट प्रोफेसर था तब मैं लोगों को ट्रेन किया जाता था, पहले लेकिन वो इतना बुरा वैसे होकर मैं सिर्फ बात कर सकता हूँ। जो किताबें पढ़ानी है या उनको काम सिखाना है, उन दोनों से अब टाइम गुजरता जा रहा है। सर मैं ये बता सकता हूँ कि बेहतर इंसान किस तरह बनना है, पुलिस के साथ बिहेव किस तरह करना है, क्योंकि माशाअल्लाह जो अब मेरे जो शागिर्द है वो पढ़ाने लिखाने कुछ सारी चीजें कि जो हम बहुत अच्छी तरह कर सकते हैं। और हमारी कई नस्ल तो कहती है कि भाई बात की जरूरत नहीं, वो एक हिंदू है गया मतलब तुर्की में, तो वो कहता है हम इंडिया में कहते हैं गूगल माता सब आता। गूगल में भाई तो सोचिए वो तो आपको मुझे पता है, ये लोग ये समझते हैं कि मैं नहीं सोच रही थी कि मैं सब कुछ अभी रिजर्वेशन को हर चीज बता के सरकार से बात करना उसको ब्लॉकिंग है, ज्यादा ब्लॉकिंग इन्फॉर्मेशन रोक है। एक दूसरी बहुत खतरनाक साइकोलॉजिकल इसको जैसे नहीं करती वो इससे वापस या अपनी प्रॉब्लम स्ट्रेस उतारने के लिए किसी दूसरे को प्रोजेक्ट करें। आप कहते हैं हम भी पहले होते हैं कि रात को जो डॉक्टर सुबह रहती है जाकर देखती सुबह कहती है कि सुबह दवा लेते हैं, देता है कि मैंने सारी बातें सुनी। तो नॉट डू दैट टू सम एक्सटेंट, इट्स वेरी डेंजरस है क्योंकि डॉक्टर में सारे जो मुद्दे पड़ते हैं काफी प्रोजेक्शन की लोग अपना गुस्सा इसीलिए डॉक्यूमेंटेशन स्टार्टेड और अक्सर पेशेंट की रिकॉर्डिंग फोन में नहीं लगती है। अब तो जो आप कर रहे हैं सोचा करके उसका रिकॉर्डिंग तो ये देखिए वाले फोन नहीं है वहां पर हम बहुत बेशक करते हैं, मुझे अपना जवाब दो ये मुझे इसको बना करना तो वो जो आपको ब्रीफ समझाता है उन्होंने कहा जो बढ़ गई है मैं ज्यादा उन बारे कॉल की कोई जरूरत नहीं, मुझे अपना जवाब दो। So nothing works. Nothing works. The only thing that works is कि सिर्फ डिप्लोमेटिक बात है। कभी वन में बात ना करो कि मैं इनको हम सोच रहे हैं इसके लिए किया जाए, फिर उस जुम्मे को लंबा जाए। हमारा ख्याल है कि इसको अगर इस तरफ से देख लिया जाए तो ये भी एक अच्छी ऑप्शन है। When you say कि नहीं एलाकास वाले ऑपरेशन होना चाहिए, that's dangerous. चीजों को पूरा घुमाना वही ना अभी तो ऑलरेडी किया था क्या, मतलब this is a different world now. Is that already? Right, we go through the scenario very very quickly. You are in ST3 training in a gynecology outpatient. Right? याद रखो सिनेरियोस में हर एस्पेक्ट ऑफ इंफॉर्मेशन इज इम्पोर्टेंट। तो बचाओ क्लियर वाकई एक सही इंसिडेंट है। We are about to see Miss SS, a 40-year-old patient, 40 साल, para 3+2, underwent a hysteroscopy in Kerala 2 weeks ago and is headed to obtain results. She has had a history of heavy irregular for the past 3 months and was treated by her GP with a course of oral progestins with moving it on step. GP was going to she was subsequently referred to the hospital for further investigation. Both was the hysteroscopy and biopsy recovery that has moderately differentiated the demographic. This mरीज को diagnosis करने के बाद आपको आपके पास So, what are we going to do? एक तो बेसिक हर चीज के लिए देखो याद रखना तुम ये ना सोचना कि तुम लोग इमीडिएटली पार्ट 3 MRCOG ले रहे तो दिस इज एनी लेस इंपॉर्टेंट दिस होल्ड्स ट्रू फॉर एनी क्वालिफिकेशन अंडर दिस मेडिसिन तो मरीज से बात करने का तरीका एक ही और टाका निकालने के चले जाओ तो वो वही है इंसानों में नहीं बदलना इंसानों का डीएनए चेंज नहीं होता उसमें कोई सबसे पहले जो इंट्रोड्यूस है इन्होंने करते हैं to identify कि कौन सी किसी को पुश करना था उसको वो आए मुझे ऐसा कुछ को मोबाइल पर वो लाइक दैट मेरा अपने फाइल की तरीके से नहीं पढ़ी एंड यू कैन रिप्लाई दिस थिंग्स हैपन सो ये चेक करते हैं पूरी बात अगर गलत नंबर तो हमेशा अच्छे लोग हैं मरीज से पूछो किसी रिश्तेदार को अगर बताना है या नहीं तो मुझे उससे किसी ने तस्वीर भेजी है डॉक्टर ने क्या नहीं बताया रिश्तेदारों का दाखिला होने एक्चुअली सो आजकल के दौर में चीजें चलती नहीं आजकल के दौर में एक ही दो रिश्तेदार आते हैं वो भी गूगल करके आए होते हैं वैसे कहीं देखना वकील भी होता है सो आजकल जो रिश्तेदार आते हैं उनका और केस है केवल जो दो तीन डॉक्टरों को देख के दिया जाते हैं उनसे डाल के दिया तो लॉट ऑफ थिंग्स हैपन और जितना कॉम्प्लिकेटेड मरीज है उतना डॉक्टर के लिए पता होता है So, पुलिस की आपको सस्पेक्ट आ जाती है कि पुलिस के साथ बात किस तरह करनी है अगर आपके थोड़ा सा किस लेवल में जाके बात करें I mean, it's probably good to ask your question, ask him. But having said that, don't you don't understand कि किस लेवल पर communicate करना पड़ेगा क्योंकि लेवल उसी पे जाना पड़ेगा आपके साथ MRCOG एक्सपीरियंस हो जाता है वो लैंग्वेज जो कि आसानी से समझ आए कोशिश करो कि जाकर पास से बात ठीक है और एक तो छोटे नहीं मेरे कई बार मेरे पास मरीज आए ना तो सारी डॉक्टर की बात सबसे बड़ी बात ये रही होती है कि मैं चला के तो उन्होंने कहा तेरा तो कभी बचा नहीं अब इस तरह की स्टेटमेंट्स काफी बुरी है सबको आती है या क्या करने के लिए नहीं बचा So kindly make sure कि अगर आपने बैड न्यूज की ट्रीट करनी है फिर आप प्लीज इंसानों के साथ थोड़ा सा इंसानियत के साथ चलते हैं she is sick she has something which is threatening her life and her health but then she is a human being as well और clear all the rest कई होता है कि हम डॉक्टर अपनी चेयर ऑफ थॉट पे खो जाते हैं अगर खुद we lose track of what we are saying कभी गौर करना बोलते चुप करके देखना जब तक जो मैंने एक्सप्लेन किया डज इट मेक सेंस अनफॉर्चुनेटली कई बार हमारे अंदर से जवाब आने और नहीं तो keep a track of what you're telling the patient and make it logical sense to take the between the words that they will like logical में देखिए तुम्हें पता है अगर ठीक है तो क्या क्या it's a very easy situation you know that तुम्हें क्या है all now you have to do is communicate with the patient in a decent way. Show empathy. Offer information slowly so that the patient can process it. Give it time. Never rush this, especially in study technique. Patients will time that information process. Give them their own. The team in the GP क्यों मुझे सिंपली रिक्वेस्ट कर सकते हैं सिंपली सिचुएशन आप जरा फिर से बात करो तो वो होता जीपी प्रोफाइल में उस जीपी से तो आपको फिर बटन में तो होता नहीं होता यदि दोनों को बटन है जी ऑन योर बैक क्योंकि वो ग्राफ का भी काम हो सकता है जब जीपी सुपर भी एड्रेस है पहले में कर सकते हैं वो डॉक्टर का कुछ फॉल्ट हो गया है वहां पे सीजर पूरा शिकायत कर रहे हैं सारे लोग जीपी को लेके करके दोनों ले जाएगा क्योंकि कंसल्टेशन की फीचर जीपी है इसलिए मैं बटन में गिरा कर कर दिया ये सब सुपर है तो जिसके पास पैसे होते हैं वो कहते हैं उस जगह पे कॉल और जिसके सो तो फिर मैनेजमेंट प्लान अब जाएगा इसके सिर्फ अगर उसके जेल में ये है कि नेशनल का कोई बच्चा करना चाहिए या कुछ ये लोग इमेज बनाते हैं तुम्हारे मुंह से निकल जाए हाँ आपको बच्चा So be very careful. There is my words, make it somebody else, it is really significant. And then, for better, you need to know, okay, what happens in how. And then you also know, this is still slavery from and the patient doesn't know that. So, guide करना उसके जीपी को खुद करना ये भी हमारे ही जिम्मेदारी ये नहीं होगा कि हम उसकी सर्जरी करेंगे तो जो लोग ट्रीटमेंट ऑफर करेंगे वो शुरू करेंगे क्योंकि ऑन दिस डोमेन्स इस सारे के ऊपर जो आप जवाब देंगे नंबर 1 प्रोसेस और नंबर 2 कॉन्टेक्ट आई विल डू द पास borderline depending upon that I'm not taking the back for the procedure बड़ा अच्छा एक्सप्लेन और then इस सारे प्रोसेस में से आपके एग्जामिनर जो है वो चीजें चेक कर रहे होंगे Any questions, any comments? It's really every day. Going to number 2. This is Zadi, a private company is working as an exceptionist school, presented at the day of war with 39 pregnancy and diminished reading numbers for 2 minutes. During examination, it was normal. However, pretty hard to not take us. Especially before anything to be market, then we see you can the eyes of the say, don't know okay, everyone wants to do something. This I will talk about. She has regular activity checks by community level, condition, and then was classified as bonus. This is she had presented 2 days back at the trial. I were exceedingly that was reported as wrong. उसके 2 दिन के बाद she conducted following the diagnosis, liver was reduced and she delivered a macerated 2.2 kilogram baby. The cord type 1, type 3 around the neck. So we said that she was quite upset during the whole process and was crying at times. She was discharged in stable condition of blood pressure. The postmortem examination showed normal BPM. All treatment was done in marks will be awarded for your ability to deal with a difficult situation with the concept and handling the person as well as answering the person. Also, we can basically what they are also given a brief test, but we have seen the entire thing. They give it. तो ये उसको पेशेंट की हिस्ट्री दीजिए और साथ ये भी किया जाएगा कि प्लीज बस actually was. No place could be about the उससे जो सवाल कर रहे हैं why did this happen? Who's responsible? This cannot say what are you going to do about this? And then at the same time, the young come by the or the student. The patient यहाँ से ज़्यादा कह रहे हैं फिर भी बाद में जाके ट्रीटमेंट करते कुछ लेकिन इधर से and then जो भी तुम्हारा हेल्थ है वो ये भी से बात करेगा the जवाब चाहिए है not satisfied please introduce yourself check sufficient sleep check sufficient satisfaction ये वो एक मोटी बात है पहले वाले सिनेरियो में भी so उसके साथ जब डील कर रहे हैं तो चंद चीजें से मैं बात करेंगे if you have more empathy ये कि पहले तुम्हारे में काम है but you have to be extra cautious कि तुम्हारे मुंह से जो बस निकल गया पेशेंट में कैसे तो मीन्स की बड़ी बहुत तरीके से हमारे मुंह से कई लफ्ज निकल जाते हैं और पेशेंट्स की इंटरप्रिटेशन में पास की बिल्कुल so choose very neutral words जो किसी और तरीके से इंटरप्रेट ना हो सके be sympathetic but don't be like her relative or on her side कि तुमको दिखाया आज जिस डॉक्टर ने देखा तो उसने भी सिलेक्ट किया that's a no this is what you never do तुम अपने कॉलीग पे दिल में तुम्हारे जो मर्जी हो तो बड़ी ज्यादती उसने की है उसको नहीं ऐसा करना चाहिए पता नहीं उस पर क्या होगा so this is what you never do क्योंकि ये और उसको मोटिवेट करना और मुकदमा भी करना अगर हम की बात करें explain that the doctors are trained they are competent in this only the they are selected for process so on and so forth without commenting on the particular doctor about the patient who don't basically so the bilkul let them vent it out let them talk you use थोड़ा cool down करना शुरू करो और ज्यादा ये वो जगह है जब पेशेंट की बात सुने लेकिन वो सारी अपनी जगह उसको जवाब चाहिए जब वो स्टडी करे लेकिन वो इंसान जो भी प्रयास कर रहा है उसको बिल्कुल सिचुएशन दिखाते हैं तो we also be as a human being like even though she's upset but she's not the enemy he's the one who can tell some of that अमूल्य होता है कि अगर कोई हमें थ्रेटन करता है अगर हमारे सामने ऊंचा होता है हम डिफेंसिव हो जाते हैं ऑटोमेटिकली हमारा जवाब उसको दुश्मन दे देता है और एक्ट करना शुरू हो जाता है ऐसा हमारे दुश्मन ये चीजें हम So we probably will have to talk a little about IUG as specific UKG order of the day. Wouldn't it because of that, but cannot say for sure, cannot take it and in चीजों में थोड़ी सी एडवर्टी कहना तो नहीं चाहिए इस एक्चुअली है because अगर वो इनके दरमियान रहती है तो चांसेस are कि वो बहुत एग्रेसिव पोस्चर में and then the postmortem is clear इसमें कोई ऐसी फाइंडिंग मौजूद नहीं जो एक इंडिविजुअल दे कि दिस इज व्हाट इज एक्सपीरियंस है कि बच्चे के टेस्ट मांग के टेस्ट व्हाट विल कोई एक कॉज नहीं है बेबी कॉज यहाँ है बट वी वांट 100% क्योंकि अभी तो बहुत सी ऐसी चीजें हैं which we are not sure and it doesn't hurt to admit that doctors are not know-alls जिस जगह पे हमारी इंफॉर्मेशन नॉलेज या एबिलिटी नहीं है उस जगह पे मानने में कोई नहीं है then advice the other future things तो थोड़ी सी advice उसको देना whatever the way you speak to her she's scared as well so not just not intermediate colleagues there is always an inquiry but inform her about this ये नहीं है कि उसका नुकसान हो गया कि nobody wants to do it उसका राइट है और उसकी इंक्वायरी की फाइंडिंग्स भी उसका राइट तो इंक्वायरी जो है वो क्या डेटा है टेंशन मत लो अगर वो बार-बार सेटिंग कर ली कि काम करूं and we don't do this either but at the same time don't get intimidated you're a professional out there to do a difficult job not an easy job you're going to do your job these के जो actions है अगर उसमें जाना है तो आप रोक नहीं सकते आपकी बातों से नहीं सेकेंडरी मिस्टेक है। कोशिश करो कि आप उसको सीए में उनकी तरफ कंट्रीब्यूट करें। वो लगे इधर तो बढ़ ही जाता है, समझ नहीं आता। सो ये भी आपका बिहेवियर उसको खराब होता है। विशेष स्टार्ट टू गेट वेरी ये मैं थ्रेटन कर रही हूँ, ये आगे समझेंगे कि उनका बिहेवियर और अच्छा जो मस्ती कर अच्छा भी हम बता रहे हैं हमने उस चीज से हम पकड़े हो गए। सो अभी तो न्यूट्रल पोस्चर है इस एक्नॉलेज उसको, अगर उसको पता नहीं है कि कंप्लेंट प्रोसेस क्या है, न्यूट्रल में तो बताना आपके लिए क्या है आपकी प्रॉब्लम को चेक करना है ये क्या है वो हाई you offer future pregnancy के लिए वो शेयर उसके पास होना चाहिए। लेकिन if she is receptive, so that's good है। तो फिर discussion practical चल पड़ती है, professional rather than social। social को आप avoid नहीं कर सकते, लेकिन अगर वो professional side पे निकल उसका काफी फायदा है। But again, वही domains, information, colleagues के साथ और बाकी सब के साथ। Right. You have any questions? Comments? Yes. अगर हम अपने चीजों को अप्रोच करते हैं ऐसा नो छोटे कई डॉक्टर करते हैं हमारे लिए बहुत है जो स्ट्रेस भी है मैं तो बता दिया कि आप सब that's a very stupid shit. So डिपेंड करता है कि आप अपना प्रोफेशनल अगर वो आपको इंसान बना है अगर जो 10 के डॉक्टर हैं ये वेरी बैड और फैक्ट होंगे they're not bad at saying I know. They say all we do not know that हमारे यहाँ उसको ईगो का मसला समझा जाता है कोई भी कंसल्टेंट है और ये भी अपने स्टूडेंट्स को कहता हूँ कि दीवार पे लेते हैं describe what you see, not describe what you don't see. जितनी इंफॉर्मेशन तुम्हारे पास है discuss हमारे पास है ही उस पर कमेंट देना तो क्या बात है तो क्या मेरे को से मुस्लिम बात लेकिन वही आपकी बात को सच मानते तो किसी जगह जाके देखे मैंने को डॉक्टर ने क्या सीखे कौन है वो कैसे तो किसको क्यों और को बताना है लेकिन होती कौन सा तो आपके आप अपना समय क्या करना है आपके कैसे only describe this. Is safety inside that? Already in this it also आपको पता है क्या होता है mechanically इसके मुताबिक हम इन्फ्लुएंस कर सकते हैं लेकिन हमारे लिए 100% इस बच्चे का एडवाइस ये सच इसके लिए even the first without data. And then it's not a good idea. It's on how do you know what happened? Nobody else has done. I'm really sorry. All the rest. अगर आप अपने आप को प्रैक्टिस करवा देते हो उसके बाद आपको हायर करना चाहिए तो आपका भी तो डॉक्टर्स की सिक्योरिटी बहुत ज्यादा है। इधर जो लोग तुम्हारे शीशे बोल रहे हैं, ट्राई टीचिंग देम द ग्रेट ऑफ माय लाइफ। इसी हमने इस सीरीज को डील किया और ये शीशे बोलने आ रहा है। फिर मैं और becoming as long as you are working by the book of the recommendations फॉलो किए, अब उससे धीरे धीरे आपको गैप नहीं हो सकता। आउटकम आपकी जिम्मेदारी नहीं, पाकिस्तान में आउटकम आपकी जिम्मेदारी। यहाँ लोग कहते हैं कि बड़े डॉक्टर को जानना होता है, आपके नहीं बड़े लोग हैं, चार कॉम्प्लिकेशन होगी तो रास्ता देखो जैसे जीआईडीपी का सर वहाँ आपकी बहुत ज्यादा से सारा पूरा ऑनड्रॉइड ब्यूरोक्रेसी वहाँ पे पीछे आने खड़ा होता है। वहाँ अगर आपने काम किया है तो आपको वो छोड़ के सही करेगा। पढ़ा जाएगा ऐसी मरीज में आपने जाता है इनको लहर में साढ़े को यूज किया उसी साइड में उसे ठीक लेकिन पाकिस्तान वाले वायरस की भी है लीडरशिप सेक्शन ऑफ द प्रोसेस ट्रेनिंग के चैरिटी को सेक्शन करें एज वेल एज द गाइडलाइंस अराउंड दिस उससे बात करने में फिर कोई नहीं चाहिए तो कोई मैसेज तो कैसे सबसे पहले तो वो कंप्लेंट हो पाकिस्तान में तो फिर डॉक्टर में से मिल जाते हैं तो ये जो रास्ता बोलेंगे तो सबसे पहले कंप्लेंट हो ये नहीं
out of the topic, but recently जैसे हम जैसे लोग ने अभी recently आवाज़ किया है, पाँच छह दिन पहले ये लगता था कि नहीं होती ना डिग्री के लिए सारे लोगों को फिर मॉर्निंग पे जा सकते हो, हमारा प्राइवेट फ्यूचर टाइप करियर है। अब जब से मैंने वहाँ स्किल्स बढ़े, सर आता था कहना दुनिया में किससे बोल रहे हैं ब्राइट फ्यूचर में गाल कर देना सब बकवास है। अब तो सारी दुनिया की अपनी प्रॉब्लम है। ये जो एक्सप्लेन कर रहा था मैं सोच रहा था कि साढ़े तक भी नहीं कुछ होगा मैं कैसे तो चली नौकरी मिलती है मैं कैसे पैसे पूरे मिल दे ठीक है ना रिटायर करते हैं रिटायर नौकरी देते वो ये तो किसी पर एक जनाजा जा रहा था तो उसके आगे एक ना उसका बेटा चला तो निकल जा रहा कहता है अब्बा तुम कितने ले चले पानी गिर रहा है उसे कीड़े हैं किधर की पड़े तो एक बड़ा से उसका बेटा भी साथ जा रहा है बेटा अपने बेटा कैसे करना अम्मा इस आगे का अल्लाह चले और कहते चुप कर कहते नहीं कि अल्लाह इस रात के आगे का अल्लाह हर जगह बेटे डॉक्टरी के सिर्फ मेहनत करती है 15-20 साल हार हो उसके बाद थोड़ा सुकून आना चाहिए। एक और भी एक बंदा होता है वह जो जुड़ी की बात उसका हाथ देख के कहता है कि 35 साल की उम्र तक इसका परेशानी आ रही बड़ा खुश हो गया 35 साल ठीक हो जाएगा मुझे जो भी कहता है कि आदत पड़ जाएगी इस चक्कर से कदे ना रहे कि मुझे बड़ा रोजी है तो ये तो वो हर जगह की अपनी प्रॉब्लम मैं मतलब जब बैठा था वहाँ अपनी प्रॉब्लम की जाएगी और इस तरह निकल जाता मैं कई बार कहते हैं शुक्र है मैं तो नहीं तो पाकिस्तान में तुम कई छुट्टी कर लो पिछली कोई नहीं प्रोफेसर में तो मतलब है इसका बिल करता है वापस इसका बिल नहीं करता वो नहीं कई कई महीना भी लगे लिया टाइम बिल डालने बेटर और गिवर्स ठीक है तुम ले जाओ उसे स्वागत करना नहीं अपना जो करना दूसरी इंसान है वो तो बिल्कुल बच्चों के स्कूल की बात आपकी आखिरी बेहतर होगी लेकिन आपको पता होता है कि लोग नोट कर रहे हैं ये तो बहुत है जब मेहनत करने में भी कोई वो नहीं है लेकिन ओवरऑल फॉलो होता है ना जैसे फॉर एग्जांपल जब ये इकोनॉमिक क्राइसिस आया था उसके बाद यूके का ओवरऑल जनरल जो हो रहा है ये इकोनॉमिक क्राइसिस बहुत जब वहाँ पे कोई जरूरत नहीं है जाने की एंड जस्ट
सारी दुनिया के नहीं हुआ तो मैं उस हिसाब से सारी दुनिया में पाकिस्तान में हम फर्स्ट पॉसिबल उनका ब्रिटेन में थोड़ी अपॉर्चुनिटीज इसके लिए क्योंकि काफी डॉक्टर बाहर है तो पैसे थोड़े थे तो ऑस्ट्रेलिया रहते हैं मतलब वो जो ग्रीनर वास्टर है तो थोड़े पैसे ज्यादा मिलते हैं तो वो थोड़ा वैक्यूम भरेंगे लेकिन वो भी कुछ तरह नहीं दे रहे कि उन्होंने दरवाजा खोला है जरा बची आ रही है उसके बाद अभी भी उन्होंने रूल चेंज किए हैं कि आपको जो परमानेंट रेजिडेंट देते हैं वो एक तो कहते हुए रखा है 3 साल बाद 5 साल के बाद परमानेंट रेजिडेंस देते हैं और वो भी 5 साल में अगर आप इसका लो कि परमानेंट रेजिडेंस उसके बाद उनका सिटीजनशिप में फिर और 5 साल
नहीं उसके बाद 1 साल के बाद लेकिन आपको वर्क परमिट करेगा वर्क परमिट 5 साल वर्क परमिट
और वर्क परमिट कैंसिल हो सकता है मतलब आपकी कोई स्टैंडिंग नहीं है अगर आप करिए
ये कुछ चीजें थी जो बाद में हम डिस्कस करेंगे ऑफ द रिकॉर्ड कॉलेज ना जाए ना ये बात कि आप क्यों जाना चाहते हैं फाइनेंशियल सिक्योरिटी के लिए आपके पास पासपोर्ट दूसरा आ जाता है लर्निंग भी छोड़ेंगे वो सब गया आप कहते हैं बच्चों का ब्राइट फ्यूचर होगा यहाँ पे बैठे हुए
बच्चों की बहुत अक्सर में कुछ बात कर रहे हैं मेडिकल कॉलेज की 2000 मतलब ब्रिटेन में अगर आप ब्रिटिश सिटीजन भी हो साल के हमें 14,000 के 15,000 पाउंड तो
9,500 पाउंड जो यूके में वो होते हैं बाहर वालों के लिए नॉन मेडिकल डिग्री के 3,000
मैं 2.5 देता था इंपीरियल कॉलेज वो 2,500 में किस तरह पहुंच लेता था नहीं ना
और बकिंगम शायद यूनिवर्सिटी है प्राइवेट मेडिकल उसकी 35,000
ये ट्यूशन है और अभी जो बच्चे के रहने ट्रैवल करना है खाना पीना पौना
हमारी एक ट्रेनी है वो अपने बेटे को वहाँ पढ़ा रही है साउदिया से आई तो वो कह रहे थे कि उसका प्रॉब्लम ये था कि अगर हम उसको यूरोप भेज सकते तो वो 18 को हो जाता और फिर उसको यहाँ की सिटीजनशिप वो बेचारी रोज लोकल करने आई होती है वो अपने आप को मार ये 35,000
वही बात है कि हर जगह पे अपनी तरह की चीजें लेकिन मौसम ग्रीन है आपके वापस अभी मेरे बारे में सिटीजनशिप मेरी इंटरेस्ट नहीं देता है मेरी मांग के लिए कैसे कैसे जगह पर सभी उसी और सवाल ही करना होगा कि बात लेकिन दैट नाउ गोइंग है यहाँ से सब पूछते हैं मुझे अगर आपका रह गए होते तो मतलब भारत सूट है उसको तो पहले ही ना ये डिसीजन की क्या कह सकते
आपके वो कहते हैं मेरे बच्चे यूके में मेरा बड़ा बेटा पैदा हुआ था सोचा और वो दोनों मुझे कहते हैं नाम क्यों हाँ उन्हें पाकिस्तान बड़ा पसंद
है
So sir, you are a lecturer teacher of
जिसको बहुत सक्सेसफुल भी देखते हैं उसकी अपनी स्टोरी है जो कहाँ ठोकरे खा 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 कर
मैं आपको एक ही स्टोरी सुनाता हूँ लेकिन मैंने फर्स्ट टाइम देखा 97 या 8 की बात है सही भी यहाँ पे शॉप लाइफ में कोर्स कराया करते थे उसमें MRCOG FCPS मेरा डॉक्टर तैयब आए उनके ऑफिस में बैठे थे मैं पूजा में गया हुआ था वो कोर्स ऑर्गेनाइज कर रहे थे ये दोनों वहाँ बैठे हुए और कहते हैं सर प्रैक्टिस नहीं चल रही मुझे एग्जैक्ट इतने वर्ड याद है वो उनके सामने बैठ के दोनों कहते हैं सर प्रैक्टिस नहीं चल रही पैसा मैंने कहा था वहाँ चिट्टे करेगा तो फिर चलते
very successful. अच्छा डॉक्टर ही कोई आगे से आता ही मेरे मेडिकल कॉलेज गवर्नमेंट बांकी करिए 150 वो 25 दिन अवसर पता चलता है सोचा भी नहीं है कि पाकिस्तान वो जरा वो मेडिकल कॉलेज जस्ट लोकेटेड इन पाकिस्तान पाकिस्तान से लेना देना कुछ नहीं देना वर्क ऑन किसी ट्रैवल लोग शुगर करते हैं तो राइट थैंक यू वेरी मच
Thank you so much, Dr. Arif, for such an enlightening talk. Now, I would like to invite Professor Rehana Rahim from the Department of Obstetrics and Gynecology, Native Building Hospital, Peshawar. She is fellow IRC RCOG.
I'll just request Dr. Rahim to begin this token of appreciation.
Thank you very much, ma'am. Thank you very much, ma'am. I'm honored. All the best. And guys,
She is fellow IRC RCOG, member of Academic Board SOGD, co-chair Guideline Development Group of Hypertensive Disorder in Pregnancy SOGD, champion RCOG Global Health Program, principal investigator World Health Organization COVID and Pregnancy Outcome, international co-author.
Assalamualaikum. I would like to thank Professor Nazmi for inviting us and for the support which has been always shown by Professor Arif and Dr. Vasiliou. Most of the topic which I'm going to present has been shared in bits and pieces by my previous two speakers, but being an important topic, constant, and its fundamentals, I would briefly like to go through that. And why this is important is because most of the claims made in NHS for the last several years has been based on lack of proper informed consent. So consent is basically the key. It's the key to proper decision making and to avoid harm. And it is based on the principles of patient's autonomy, doing no harm, doing good, and accountability. So can we go ahead, please? Now, second. Thank you. But I have made this document by going through the references. So basically, most of the content has been derived from latest guidelines of General Medical Council, which has been revised in November 2020. And in addition, I have taken a few law cases so that we can emphasize on the importance of consent and the related litigation issues and claim issues which can arise. We are going to discuss what is consent, what is a valid consent, and what is an informed consent. So basically, we have to differentiate. From consent, we have evoluted to informed consent now. There are basic 7 principles of consent taking, which has been devised by General Medical Council guidelines. And if properly taken and following these principles, most of the doctors would be able to get an informed consent.
As an MRCOG Part 3 candidate, we need to be familiar with Mental Capacity Act. And in few case scenarios, how are we going to take informed consent for elective procedures, in emergency procedures, and in a patient who has been found to be unconscious? So what is basically consent? It involves a clear, structured, concise instructions given in advance which patient can understand and can ask questions. I'm sure you all are familiar with consent advices which are being published on our MRCOG website. Like you probably would have seen consent advices for total abdominal hysterectomy, for VBAC, for elective cesarean sections. But having said that, it doesn't mean that that sort of consent would be applied for each and every patient. How the concept has evolved. So in 1957, most of the case laws in UK or civil laws in UK would follow the Boland principle. And Boland principle was simply an opinion which was given by another medical practitioner, another responsible medical practitioner. And in most of these cases, the defendant would be easily protected by the law. In other words, the Boland principle, which went on for quite a while in the UK civil law, it has led to an atmosphere of paternalism and self-regulation. So patients probably had to suffer because of application of Boland principle. Then it subsequently a ruling of a lady Sedeway. That ruling changed a little bit of Boland principle because one of the judges, Lord Scarman, in his dissenting note, he clearly said that patient needs to know about all the substantial or major risks involved in this regime. I'm not going into the details of these rulings. If you're interested, you can easily access them on the internet. Then it was followed by Bolith protest. Bolith was a young boy who died of cerebral hypoxia and had a long story of coming to NHS hospitals for admissions. And then subsequently, it was proven that because he was not intubated, he sustained permanent brain damage. This ruling again gave quite a lot of popularity and giving more weightage to informed consent. Then in 1985, followed by the little case of Pierce versus United Bristol NHS. Again, in this case, Mrs. Pierce had a stillbirth. She was not advised by her obstetrician to have induction of labor. And she sued saying that if she would have been informed properly by the obstetrician, she might not have opted to wait and she might have decided to go for induction of labor. So again, this ruling emphasized that patients need to be informed of all considerable substantial risks, although rare, but they need to know about that. And then Chester versus Afshar, this was the case which brought again changes into the consent and the process of informed consent. The major breakthrough was Montgomery's ruling. And this has changed the whole practice of medicine and informed consent in the UK and perhaps throughout the world. Mrs. Montgomery was a short-statured lady. She was diabetic. She was supposed, and she was informed that she had a macroscopic baby. But her obstetrician did not discuss with her the chances of shoulder dystocia, which in this particular patient was about 9 to 10%, cerebral hypoxia or cerebral palsy, and brachial plexus palsy. The baby delivered when he had shoulder dystocia, sustained cerebral hypoxia, and Mrs. Nadine Montgomery, she had to fight for 16 years in courts, for 16 years in courts to win this case. And that's when the ruling of material risk came into being. A material risk could be a risk to any one particular patient, which may not be pronounced in any other patients. So based on that, GNC has devised its guidelines, and the 7 principles which has been highlighted by General Medical Council for decision making and consent. You need to go through them. The few major changes which they have brought about is meaningful dialogue, involvement of the patient in every decision, and unless that decision has been made to the patient in a clear, concise, simple, open, evidence-based form, the consent would not be considered to be valid. So for a patient, I would go back to Montgomery's case. For Nadine Montgomery, that material risk which did materialize perhaps would not materialize because we all know shoulder dystocia is unpredictable in about 75% of patients. So all the patients' decision making, another thing which General Medical Council now emphasizes, that consent making is an ongoing process. So a patient might consent to a procedure or intervention today, but if she comes back to the clinic in a week's time or 2 weeks' time, and she has decided to change her mind, the doctor has to support her in her decision. So consent is not a one-time decision. Patient can change it. It's an ongoing process. Patients in whom we are expecting long medical courses, particularly malignancies. In that cases, the consent process can change. The doctors now have a duty to make sure that whatever information they have given to their patients, the patient has understood that information. So understanding of the patient, checking the understanding of the patient, doctors are duty bound. The last line, this is really the major change. Doctors must try to find out what matters to the patient so they can share relevant information about the benefits and risks of proposed options and reasonably clarifies, including the option to not to take an action. So there might be patients in which you might have to consider giving them the option, let's not do anything and let's see how things are going to go over the next few weeks or months. And all this information, all this dialogue making, all this talk needs to be documented. And if the patient agrees to have someone with her during this meeting, the presence of those relatives or friends or partners, they need to go into the notes at that time. Now, again, patients with mental capacity, patients who are unable to understand, who are unable to give the consent for any given proposed procedure because of several reasons, because they are not willing to participate, because they cannot understand. The law states that in that case we perhaps have to resort to other measures like involvement of a relative, involvement of a court, involvement of a senior colleague, or involvement of a hospital ethical committee to go around that issue. So a doctor alone would not be able to sign or decide in the presence of a patient who has got any impairment of mental capacity. So in short words, a valid consent will involve, we have to make sure patient has got sound mental capacity. So, and we have to agree this capacity can vary, it can change over time, it can change with condition, and her capacity has to be for that particular decision, for that particular time. This is something new in the GNC guidelines. Whatever information you are imparting to your patient, we have to make sure it is of good quality. As I said, it should be evidence-based. As Dr. Arif rightly said, if you do not know statistics, if you do not know percentage risks, it's better to say, I don't know, rather than giving wrong figures, because that can lead to a successful legal claim. So we have to make sure we are passing a good quality information to our patients. Our patient needs to give the consent by free will. This is really important. So let's say a patient in labor who has been given Patarine, and we are trying to consent her for instrumental vaginal delivery. We have to make sure this counseling is done in between the contractions. It is done when she's not under the influence of narcotics. But again, this emphasizes that all antenatal care plans should be made up in antenatal clinics in the last trimester of pregnancy, so that patients are aware that they might need epidural, they might need an instrumental delivery, they might need perineal repair, which might extend to a third perineal tear. So all this needs to go and properly documented, because during labor, under the influence of narcotics, sedatives, pain, she may not consent. According to Mental Capacity Act 2005, we have to consider all patients to be mentally competent unless proven otherwise. And that unless proven otherwise has to be documented by a team of doctors who will say, yes, this person is incapacitated for this particular time, for this particular decision. But before rendering someone incompetent, we have to make sure we are doing effective and appropriate communication. A person does not lack capacity because of their age, disability, appearance, their medical condition, beliefs. This would be particularly relevant in ethnic minorities. Their apparent inability to communicate, or they do not make the decision which the clinician likes. So you might be asking for a cesarean section for a patient, and the patient does not agree. That doesn't make her mentally incapacitated. What matters is the ability. So getting a sign on a consent form is not enough. Getting a sign on a consent form after a meaningful dialogue is what is meant by the General Medical Council for the doctors to act in United Kingdom. If the patient has proven to have lack of capacity, then all the decisions, whatever decisions we are taking, we have to make sure that they are in the patient's best interest, they are least restrictive, and understanding this, that the patient has every right or freedom of right to express her views if she doesn't agree to this proposed management plan. So these are the 4 components. How are we going to see someone, ensuring someone that the patient has got mental capacity? We would ensure that by whatever information we have given to the patient, she has understood it. And on the basis of that, she has made a decision. She is able to retain the information. So sometimes we might have to ask the patient that kindly rephrase or let us know your decision so that you can check that whatever information you have reported, the patient has understood it properly. So she should be able to understand, she should be able to retain, and then she should use that information in her decision making. As I said, this decision could be quite irrational. Several cases in the talk articles where patients decline cesarean section although medically indicated. But if she is not agreeing to that decision, we have to make sure her wishes are respected. Whatever decision she has taken, she is able to communicate that decision back to the clinician. So following these 4 parameters for patients, we would ensure that patient has got mental capacity and she has given us a valid consent. So in unconscious patients, we have to, sorry, in emergency patients and unconscious patients, we have to ensure that we have to follow the same principles of taking informed consent. But it may not be that lengthy, number one, because we are in emergency. As obstetricians, we expect emergencies to arise almost every day in the labor ward. So the codes would be still the same, but we may not be able to take a written consent. So the patient may not have signed a consent form, but although she has not, the notes should clearly state why the doctor decided to go for that emergency procedure, whether a cesarean or whether shifting to an ICU. All this needs to be documented properly. Now, advanced refusals again a way in which patients, particularly in their terminal illnesses, they would give advance directives. It's usually in the form of a will, like they would not like to be entertained in case, in terms of prolonging their life, in terms of parenteral nutrition, in terms of resuscitation. So if the patient has given an advanced refusal and now she has become unconscious, we have to respect that. Sometimes patient may have attorneys, which might be their relatives, their family members. Sometimes court appoints an attorney. So in those patients who cannot consent to any decision, any proposed action or plan, the court would appoint an attorney, and the attorney would be able to take the decision on the behalf of that unconscious patient. And I emphasize, whatever is happening, we need to have proper written notes, a proper documentation with date and time and witnesses and stamped. Because this is going to go a long way in case of any civil or criminal lawsuits. So this is a scenario we probably see every day in our neighborhoods. Suddenly cord prolapse, shoulder dystocia, so who would take the consent in these circumstances? As I told you earlier, probably all the labor plans should be discussed beforehand. And as I said, for a particular patient, now let's say a patient who's short stature and is supposed to have a macrosomic baby, we need to add in our informed consent in the antenatal notes that we might have to consider an elective emergency cesarean section. So all this documentation, if done before emergency arises by anticipation, by risk scoring, would make things easier for us. So as I said, consent could be either expressed, which could be written or verbal, or implied. Let's say a patient comes to the clinic, that means an implied consent. She gives you her hand to check her blood pressure. That is an implied consent. So the general thought or the general myth that a written consent form is better than verbal, it doesn't stand. I said the process of consent taking, the whole process, that is important. Not a signature right at the bottom of a consent form. Written consent may not be possible in emergency situations, and whatever, if it does arise, then we have to, and it sometimes may not be possible if the patient is under Mental Health Act has got mental illnesses, psychiatric illnesses. So under these circumstances, and in some fertility treatments, so under these circumstances, we have to get help of attorneys, we have to get help of our senior colleagues, so that whatever decision is taken should be witnessed or supported by a team of members. In an emergency situation, who should take consent? Ideally, it should be the surgeon who's going to operate. Ideally, it should be the person who's going to intervene in that emergency situation. But sometimes in busy labor wards, it may not be possible. But the documentation should clearly state that the consultant or the senior most available person was consulted and decision was made. This is very important as well. A patient may withdraw consent. So right in the middle of a procedure, the patient may say, I don't want to go ahead and proceed with this procedure. Unless it's life-threatening, we have to respect that wishes. And there were a few cases quoted in the articles where patients right in the middle of a colonoscopy said that she didn't want to continue the procedure. So if it's not life-threatening, we have to stop. The right to withdraw consent is not absolute. It would be either life-threatening to do so or would pose immediate and serious problems to the health of the patient. So we have to keep that in mind. In cases of children under 16, I'm going to discuss getting competency in a while. In children under 16, if they agree to consent, their parents can withhold the consent. So remember that if you come across such a question for your MRCOG part 2 or 3. So if you have decided to do an elective procedure, we have to make sure that we retake the consent. Because of the long waiting lists in UK, the waiting list could be 16 months. Patients, they often tend to forget what happened in the clinic 18 months ago. So under those circumstances, you have to make sure that the patient is re-consented before she goes to the theatre. This could be relevant if she was seen by a colleague, not by you. Time has passed. There might have been changes in patient's conditions. Maybe her menorrhagia did respond to transamid or to Mirena. So in that case, the situation has changed. So you will not proceed with endometrial ablation then. So you have to make sure that if there is a long time spent in between the original consent and the operating procedure, you redo the consent process again. Or there might have been a new information available now in this 18 months time, which might alter the management plan and patient might want to choose that plan. So what information we need to give? We need to give what we are planning to do, why we are planning to do, what are the risks and benefits of this procedure, what are the risks and benefits of all other alternative options, what are the risks and benefits of not doing anything. So the consent form, if signed, has to be signed keeping in view all this level of information. And as I discussed with Montgomery's case, the material risk came into action. So material risk is any risk which can arise during the circumstances of a particular patient. And if you ask any other reasonable person regarding that, that reasonable person would put significance to that. It's been difficult to understand, but basically what it says, you have to individualize your patients. So a patient with certain risk factors, you perhaps may not have to tell them all those risks, which another patient with absent risk factors needs to be told. So you have to judge you have to go for your professional judgment, your decisions as a doctor working in NHS, they need to be proportionate. GMC is emphasizing a lot on professional guidance and proportionate decisions. What we mean by proportionate decision would be a decision taken for one particular patient might not be the same for another patient. So signing a consent form for total abdominal hysterectomy for all patients, the same form, you could do that. But a patient with large lateral fibroids extending into the broad ligament as compared to a single solitary fibroid in anterior uterine wall would mean different informed concepts. This is what our material risk would emphasize. So patients with left lateral fibroid extending into the left broad ligament, make sure the patient is aware of uretile injury in particular, right? So that is material risk. We need to make sure that the patients, they need to be aware of all serious risks. Death, venous thrombosis, return to theatre, trauma to bladder. The consent guideline of Royal College is listing risks in terms of common, very common, uncommon, rare, very rare. I was reading one of the studies, and it was astonishing that patients were unable to understand the risks which were offered by the practitioner. And they thought 1 in 5 meant 5%. And they thought 1 in 20 meant 20%. So it's not percentages. You have to clearly tell them what risks, and if you think the patient is unable to understand, perhaps get the information, try to get the information leaflets, and try to tell them, as in the Royal College consent guideline, they have sorted it out by saying a very common would be 1 in home. Every 1 person in 1 home or in a family, that's how common it is. Okay, now Gaelic competency, I'm sure if you read for MRCOG Part 3 preparation exams, you would come across cases of Gaelic competency. This mainly revolves around the reproductive rights of young girls under the age of 16, particularly regarding requests for oral contraceptive usage and termination of pregnancy. So, children under 16 could consent if and when child achieves sufficient understanding and is intelligent enough to understand what is proposed. A Gaelic competent child is able to prevent their parents viewing the material whenever the need arises. Again, Gaelic competence was again a long case which took place after a circulation by a letter from the Department of Health that all young children under the age of 16 have the right to use contraceptives. But before prescribing contraceptives, I'm sure you will come across scenarios where you would come across a young girl sitting as a patient along with mother saying, and the GP letter saying that the mother doesn't want to know, or the mother is upset that why her daughter was prescribed oral contraceptive pills without her information. So you have to ensure the person is Gaelic competent, is able to understand whatever information the GP or you as a doctor have provided to her, and she can take her decisions. So this is particularly revolving around demand of contraceptives and termination of pregnancy. And the parents, if the girl wants, the parents may not know what's happening. So in gynecological procedures, all these procedures would expect consent taking. Unexpected pathology, while we are doing surgeries for endometriosis or suspected cancer, and we have come across some unexpected pathology, we do not need to go ahead. We do not need to go ahead. We need to go back, take informed consent, and replan the procedure. Oophorectomy, hysterectomy, again, this could be overcome if we properly counsel and take informed consents at the time of counseling for a hysterectomy. By whatever, if we suspect a pathology, then it needs to be re-emphasized that, look, we might consider taking your ovaries out and listen to her views and whether she agrees to it or not. Unexpected pregnancy, we are performing a procedure and you suddenly notice that the woman is pregnant. You're not going to go with, even if that hysterectomy is planned for endometrial sealing. You have to stop. You have to go back and take the consent. Infertility treatments, they've got their own acts and rules, so we have to follow that. it would be really relevant, particularly for an exam in MRCOG. A mental incapacity patient requesting for, and a mother brings her, requesting for termination of pregnancy, that should not be entertained unless allowed by court or by authorities or proven otherwise. We can go ahead with termination of pregnancy under 16, as I previously told you, provided the child is Fraser competent or Gillick competent. I think we probably did discuss it. We have to be particularly very careful during labor when we are consulting patients for emergency procedures. And let's say if we are giving that information, the information should not be given during contractions. Let's wait for contractions to settle and then give the information. And if we still are in doubt, as soon as the emergency procedure is carried out, debriefing of the patient is very crucial so that she exactly knows why she got an extensive third-degree perineal tear during a rotational forceps delivery. So summary. Taking adequate consent and supporting patients in decision-making is central to good practice. Dr. Wasim is going to talk a lot about patient safety tomorrow, and I'm so unhappy I won't be here because this is one of the favorite subjects which is now coming up, and clinical governance, patient safety, all these talk stations are coming up in MRCOG3 with increasing frequency. So first step towards patient safety is taking a good consent and decision making. Montgomery gave consent a large and detailed definition, and the GMC guidelines, it is bringing clarity to some of the more subjective. What we mean by subjective, there are no objective rules and regulations to consent taking. I might consider that explaining a risk of 1 to 2% shouldn't be told to the patient because the patient would run away from surgery. But that 1 to 2% risk might materialize for that patient, as it happened in Chester's case. She had 1 to 2% risk of cardiac equina syndrome. So all this needs to be guided by general medical counsel. Now, doctors have rigorous duties to have meaningful dialogue, but meaningful dialogue is stressed upon a lot with patients to investigate individual needs and to record interactions carefully. Decision making starts and ends with a specific patient. Thank you very much. Any questions? I can take it because I'm traveling back to the shop.
Thank you so much, Professor Rohana, for the wonderful session.
Thank you.
Now, our next interactive session is with Dr. Wasim Lodi. He is passionate about creating opportunities for professional development of colleagues in UK and Pakistan.
while we are here on this consent topic, I thought I will show you consent forms that we use over there. So there are 5 different types of consent forms that we are. Yeah. So the first one is consent form 1. Consent form 1 we are using for major procedures for any patient who's undergoing general anesthesia, spinal, epidural anesthesia. So it's a standard sort of consent form. Different hospitals, they would just put their logos differently. But then if you go on the Royal College website and you look on the consent advice or the consent guidance over there, it follows exactly the same headings which are on these consent forms. It's a nationally used sort of form. So if you look here on the first page, here it says for competent adult and child, competent child. Now, I never used to understand GILIC competence and user competence. Do you guys understand that? It's essentially the same thing. So Victoria Gillick was the patient, the mother actually, who brought this case against the local authority that they were not giving contraceptive, or they shouldn't have given contraceptives to her daughter. And Fraser was the judge who gave this ruling. So when you say she was trying to protect the anonymity of her daughter, but then it is well known as GILIC competence now. So this is one form that you can see, and here we would just start with all those demographics and the name of the proposed procedure, and then here you would go with what is the benefit, why we are doing that, and then the risk and extra procedures which may become necessary. And then if you have given a leaflet, you have to document that here, and then what type of anesthesia will be used, and you sign there. If you have used interpreters, like we have a lot of patients who are non-English speaking, in that case, if we have used telephone interpreting service, then we would just put the ID for the person that we have used. But for this type of consent, you want to arrange for a physical interpreter to be present because they have to sign there. And as a clinician, you would have signed here, and then the patient would go through this, and then she will sign there. So when she comes back for the procedure, if the form is still in the notes, you will go through that and then tell her that, okay, this was the procedure that we were planning to do, these are the risks, repeat everything, and then you will confirm the consent there. Now, if the patient is unable to consent, then whoever is the legal guardian would be signing it there. Another thing is that the patient can tell you what she wants, what she doesn't want. Like there are patients who are Jehovah's Witness. Jehovah's Witness are a type of Christians who do not accept blood transfusion, and even if they die, and then they can write down here that I will not accept blood transfusion even if I die, or you tell them that we have a low threshold for hysterectomy in those sort of cases, so that they are aware that we will not wait for too long for the IC to set. Now, this is the consent form 2. Consent form 2, we as such, we don't use it in obstetrics or gynecology, but very rarely you will come across a young child. So this is for parental agreement. So as a parent, the form is still the same. The difference is, if you look here, then the parent would be basically consenting that relationship to the child, and then if the child is able to understand, you can still ask them, because over there you have the option of the
the child has the authority actually to say that, okay, I want to sign, or parents' consent will take over in this sort of situation. Then we have consent form 3. Consent form 3 we use for outpatient procedures where we are not putting the patient under general anesthetic. So like for outpatient hysteroscopy, manual vacuum aspiration, putting in marina, or even taking verbal skin biopsy. So that's the sort of form. So it follows more or less the same pattern, but there is smaller and there are less things. Then there is consent form 4. Consent form 4 is for adults who are unable to consent. It's like, say, if a mother brings an 18-year-old or 19-year-old doctor who has got Down syndrome and she's having menorrhagia, and then she wants her to have hysterectomy because she cannot look after her and all that. Apart from like that, you know, to satisfy that the mother understands the risk, you need to go to the legal department or you are not satisfied that she has the authority. In that case, we are going to use this type of form. Then this is consent form 5. So this is a relatively new form because what happens is that most of the forms like consent form 1, if you have consented the patient in clinic and then the patient is after 16-18 months, as hospitals are trying to digitalize the records, so it would go on, they would scan it and then they would put it on the computer system. Now, when the patient comes back, you might not have that original form, but if the scan copy is available, so then you can open up the software, then the scan copy is there, and then you can just go through that briefly and confirm this concept. I thought I just had this so it would be useful for you. And also that the consent in person, the interpreters should be there. Big word is the telephone interpreting service. Another interesting one is BSL, which is British Sign Language, because there have been instances we had patient was mute as well, वो जो गूंगी बहरे होते हैं तो उनके लिए फिर British Sign Language वाला ला के वो करते हैं because otherwise it's difficult to consent. And another thing was which is useful, that over there now the sign has changed. Do you notice that? So make yourself familiar with this. That's because of this transgender and those issues. Previously it used to be male was like this one, and female was just this one. Now they've added this. So all the gynecology departments, they are changing into this sort of thing. Sorry, I've just gone off the record. I thought this was an additional thing. I would just add that. So next we are going to do work-based assessments. Right, so work-based assessments, they, as I mentioned in the morning, that when the trainees are going through their training, or even if you are in non-training course, but you want to maintain your training portfolio by having some evidence that you have been involved in teaching and training, then you would be going through these various forms that you would keep with you in your portfolio. So they are used to evaluate your training progression because then there's a certain number that you have to fill in by the time you go for your annual review of your competency. And then they also identify your strengths and weaknesses, and then on the basis of that, then you are going to decide whether this person has met the criteria required for progression in the next year or not. So they are case specific. That's why I told you that if you do work-based assessment form for a trainee for a simple cesarean section, doesn't mean that he or she is competent to perform a previous cesarean section or three previous cesarean section. So that competency is limited to primary evidence cesarean section, but that's what we're signing them for. And then they have to gradually, during their training, they have to collect more evidence of work-based assessment of phase 2, phase 3, phase 4, and all that. So these work-based assessments, they could be formative or summative. So what are formative or summative assessments? Formative is formation, that when you are learning to do a procedure or these junior trainee ST1 or ST2 is going through initial stages of learning civilian, they would be collecting formative forms. So at the end, when they want to have an evidence that now they are competent, then they will fill in the form which is called as summative form. So that's the sum of everything. So I will show you how, what type of, let's see, the forms are. So RCOG trainee portfolio, there will be one access for the trainers, one access for the trainees. And then within that, then we will have these different forms. How do I bring that up? It's not coming up. Okay, good. Thank you. So that's how, like, as a trainer, I would have a list of my trainees who are, I'm their like education supervisor. Then if I go on them, their individual so that's how that core curricula that we were talking about in the morning looks like, okay? And within that, then we will have those SIPs that we were talking about, CIPs. And then within that, then you will have those basic things like history taking, examination diagnosis, and all that. Right, so I talked about something called CBD in the morning. Do you remember that? Case-based discussion. So case-based discussions could be something like this, that this person has done one, which is 6 weeks right tubal ectopic from October 2021. And the reason I'm showing you these is that sometimes they can put in a question in the exam that you are evaluating one of your trainees who has done laparoscopic ectopic or cesarean procedure, and they've asked you to do work-based assessment. So what type of form are you going to use, and how will you give them that feedback?
So if you look at it, it would just start with the basics, then it would go that describe the event, then the trainee would have put that history, what they want to be assessed basically. Ideally, for any sort of assessment, they should tell the trainer beforehand, like say if you're going to tell that there is a cesarean section I'm going to do, I want you to assess me on the basis of that. And then at the end, once you have given that background of that, then the trainee will put on their analysis that what they think, whether they are competent to deal with those sort of cases or something else that needs to be done. And what is their learning plan, how they want to achieve that. And then the assessor would add their own comments. Ideally, I mean, this is not something which I have done. This is one of the MTIs whose form has just come up over there. So he's working in a different hospital. So ideally, assessors' additional comments should be much more elaborate. So they should be able to go over that and then do that. But a lot of trainers, sometimes they don't add anything extra, and they would just write down excellent management, which is not the right way to do that. Okay, so we'll go back to this. Right, so then there are different types of these assessments. So one of them is OSAT, which is Objective Structured Assessment of Technical Skills. So this we will be using for procedures that you are going to do, whether it is a cesarean section, whether it is laparoscopy or hysteroscopy. And I will see if this opens up. Then another one is MRCOG. So I will just leave that, but it is on the college website. If you just go on the RCOG website and put it over there, it would open up that form. MRCOG is for basic procedures like clinical skills that you use, like speculum examination, environmental examination, smear taking, those sort of things you will be doing that. And case-based discussion is for cases, and sometimes you want to include in your portfolio, like you have never seen choriocarcinoma, then in that case you can fill in the form, a CBD. Think of a hypothetical case that a woman had molar pregnancy, histology, underwent DNC, then histology came back as choriocarcinoma, and then how she was referred and what happened. So you would discuss with your trainer, and then you would fill in this form, and in your portfolio you will put in other methodology ON that you use for that. And yes, it's the same thing. I think it would be much quicker if you then go to the RCOG website and do that. Do you want me to go into that or just carry on then? I just wanted you to see that one OSAT form. Gee, that's fine. And then all the trainees at the end of their placement, they have, or every year, they have the meeting with their education supervisor, and we do a form, what we call Education Supervisor Form Report, ESR. And then education supervisor will go through their portfolio, they will see what sort of work-based assessments they have added on to that, how is the progress in their other those SIPs that I talked about early on, and then whether they are meeting the matrix requirements or not. Matrix is that the book I showed you early on. Like here you can see that this person has got this OSAT forms. So they have just observed that. And another thing that you also need is reflective practice. They need to have at least 2 reflective practices. So it would be on a case where outcome was not good, and then they are able to reflect and then say, okay, I was involved in the serious incident, and this is what I've learned from it. Every year you also need to have team observation. Team observation is essentially you send a feedback form to your colleagues, and then they will give feedback and email it to you. I mean, it doesn't come directly to the trainee. Trainee would just send it, and then it will come, it will be in their portfolio, but trainee cannot see it until the education supervisor has seen it and released the what you call a TO2 form. That's like summative form for all TO1s, and then we carry on with that. It's a yearly sort of thing that you have to do. Any questions about this work-based assessments? So these 3 things that you need to remember: MiniCAC, CBD, OSATs, TO1 or TO2 forms, so that when you get a case or you get a scenario in the exam, so it doesn't come as a surprise to you that what is this work-based assessment. Okay, so next we will move on to applying for jobs in the UK. Is that good? Now at least it will become less boring. I think it will be more interesting now, these things. And I need to come out of it. Not this one, it's a different one. You can close the screen. Yeah, we can close all of them. Find a new one. ओके, अब सबसे पहले बात आती है कि ठीक है, एमआरसीओजी एक जगह एक चीज है, आप करना चाहते हैं, लेकिन वही बात है कि बहुत से लोग यहाँ के हालात से तंग आके भी निकलना चाहते हैं, लुक फॉर अनदर ऑप्शन। तो उसमें आपके पास क्या ऑप्शंस है? आप प्लैप करें, आप फुल एमआरसीओजी करें, या आप एमटीआई स्कीम के थ्रू जाएं। यही 3 मेन ऑप्शंस आपके पास आती हैं। तो उसमें जो सबसे बड़ी चीज आती है वो है आपको जीएमसी रजिस्ट्रेशन चाहिए यूके में कहीं भी काम करने के लिए। और अब एमटीआई स्कीम जब उन्होंने डिवाइस की तो उसमें वो उनका मकसद ये था कि लोग आएंगे, काम करेंगे और उसके बाद वापस चले जाएंगे, क्योंकि उन्हें भी लोगों की जरूरत है, काम करने वालों की। उन्हें ये जरूरत नहीं है कि लोग हमारे पास रुके। लेकिन जब हम यहाँ से जाते हैं तो हम एक डिफरेंट नियत के साथ जाते हैं। तो उस पर यही होता है कि जब आप जा रहे हैं तो आप सोचते हैं कि अच्छा, मैं पाकिस्तान के हालात इतने अच्छे नहीं है, मैं यहाँ से निकल जाऊँ। कोई मिडिल ईस्ट जा रहा है, कोई कहीं जा रहा है, मिडिल ईस्ट के भी बुरे हालात हैं। वहाँ पे अगर आप यहाँ से जाते हैं तो जिस तरह वो ट्रीट करते हैं, इट्स नॉट रियली गुड। और दूसरा ये होता है कि अगर आप एक दफा एमआरसीओजी कर लेते हैं, यूके में काम कर लेते हैं, तो देन व्हेन यू गो टू मिडिल ईस्ट आपकी सैलरी इज डबल, एटलीस्ट डबल जो आपको यहाँ से मिलती है। मैं आपको इसलिए बता रहा हूँ कि मुझे 1 साल मैंने कतर में काम किया कोविड के उसमें ईरा में। तो उस वक्त मेरा एक कोलीग है जो कि एसोसिएट प्रोफेसर है पिंडी में सर्जरी का, और हम दोनों ने इकट्ठे मेडिकल स्कूल से पढ़ा। तो उस समय बात हो रही, वो ताइफ में काम कर रहा था और उसको लेस देन हाफ सैलरी दे रहे थे जो वो मुझे वहाँ दे रहे थे। इट मेक्स अ बिग डिफरेंस। दूसरी उससे भी बड़ी चीज आती है कि आप जब डिसाइड करते हैं तो उसमें बहुत सारे फैक्टर्स आते हैं कि हो सकता है कि आप मुल्क के हालात से इतने तंग आ गए हो कि आप यहाँ से निकलना चाहते हैं। ये भी होता है कि आप अपने आप को मिसफिट फील करते हैं उस सिस्टम में। मैं जब निकला था मुझे था कि सिफारिशें मेरे पास कोई नहीं थी, तो और ना मुझे अच्छा लगता था कि मैं लोगों के पीछे भागूं। और यहाँ पे जिस किस्म का है, उस वक्त तो ये प्राइवेट हॉस्पिटल्स वगैरह नहीं होते थे, गवर्नमेंट सेक्टर में ही काम करते थे। और जब तक आपके पास नहीं हो कोई सिफारिश मोटी ताज़ी, आपका काम नहीं चलता था। और दूसरा, मुझे घूमने फिरने का बहुत शौक था, तो पाकिस्तानी पासपोर्ट में तो आपको वीज़ा कोई नहीं देता, तो उस पे फिर आदमी को डिस्करेजमेंट बड़ी मिलती है। तो मुझे ये भी होता था कि अच्छा मैं निकलूं, कम से कम मेरे पास पासपोर्ट तो अच्छा है। उस वक्त आप बच्चों के मुताबिक कोई नहीं सोचते, अभी आप सिंगल होते हैं, आपको उससे नहीं होता कि आपका वहाँ पे क्या स्कोप होगा बाद में या नहीं होगा। तो ये आपकी मेन चीजें होती हैं जिस पे आप डिसाइड करते हैं कि आपने क्या करना है। और जब आप यूके में जॉब्स अप्लाई करते हैं तो सबसे पहली तो ये है कि आपको बेसिक रिक्वायरमेंट जीएमसी रजिस्ट्रेशन चाहिए, जो आप एग्जाम के थ्रू करेंगे या प्लाट के थ्रू करेंगे या एमटीएस के थ्रू करेंगे। तो जो जॉब्स की जगह है जहाँ पे आप ढूंढते हैं वो बीएमजे करियर्स है। अगर आप गूगल करें बीएमजे करियर्स, बीएमजे वो ब्रिटिश मेडिकल जर्नल जो है उसका ये करियर सेक्शन ये फ्री होता है। इस पे बहुत यूजफुल आपको इंफॉर्मेशन मिल जाती है और इसके ऊपर कुछ जॉब्स एडवर्टाइज होती हैं। अब कम हो गई है क्योंकि ये लोग चार्ज करते हैं एनएचएस जॉब्स के लिए। तो एनएचएस जॉब्स जो है वो अब इस पे नहीं जाती। अभी भी है कुछ हॉस्पिटल जो बहुत डेस्परेट होते हैं, वो पैसे देके अपनी जॉब्स इनमें पब्लिश करा लेते हैं। लेकिन यूजुअली बीएमजे करियर्स में अगर हो भी तो वो कंसल्टेंट लेवल की जॉब्स आती हैं, छोटी रजिस्ट्रार एसएचओ लेवल की नहीं आती। दूसरी जो सोर्स है वो अगर आप गूगल करें एनएचएस जॉब्स, जब आप एनएचएस जॉब्स करेंगे, ये इसको ट्रांजिशन कर रहे हैं एक उसमें डिफरेंट नई वेबसाइट पे, लेकिन अभी ये खुलती है। तो एनएचएस जॉब्स पे बेसिकली आप अपना अलर्ट सेट कर सकते हैं। उसमें आपको किस लेवल की जॉब चाहिए, आपको एसएचओ लेवल की जॉब चाहिए, रजिस्ट्रार लेवल की जॉब चाहिए, इवन आप उसके अंदर लोकेशन सेट कर सकते हैं। जैसे आप नॉर्थ ऑफ इंग्लैंड में, नॉर्थ ऑफ यूके में काम करना चाहते हैं, आप साउथ में करना चाहते हैं, आप लंदन में करना चाहते हैं, आप स्पेसिफाई कर सकते हैं। तो जब उस एरिया की जॉब एडवर्टाइज होगी तो आपको एक ईमेल अलर्ट आ जाएगा, तो आप वो जाके कर लें। अदरवाइज शुरू में तो ये है कि वो एक बात है, बेगर्स कांट बी चूजर्स। पहली जॉब सबसे मुश्किल होती है, एक दफा पैर रखने की जगह कोई आपको दे दे, फिर आप रास्ता खुद ढूंढते हैं आगे। तो वो तो जहाँ कहीं मिले उसमें आप ओपन जाते हैं। अनलेस के कई लोगों का होता है कि फैमिली रीजंस होती हैं, आपकी फैमिली है वहाँ पे और आप बाउंड है कि आपको उसी स्पेसिफिक एरिया में रहना। तो ये जो है ये यूजफुल वो है। दूसरा ये भी है हेल्प जॉब्स यूके, एक ये भी वेबसाइट इज वेरी सिमिलर टू दिस वन, आई थिंक वो इसका पार्ट ही है बेसिकली। तो इस पे भी आपको जॉब्स जो है उसी तरह जैसे ये एनएचएस जॉब्स पे आती हैं उसी तरह आप अलर्ट सब पे लगा लें, आपको वो ईमेल आ जाएंगे उसके। उसके अलावा फिर ये होता है अगर आप और स्पेसिफिक है कि आपसे बर्मिंघम में रहना है, आपने मैनचेस्टर रहना है, तो उस सूरत में ये है कि आप वहाँ पे जो लोकल आपका हॉस्पिटल होगा उसकी ट्रस्ट की वेबसाइट पे जाएं और वहाँ पे वो एडवर्टाइज करते होते हैं कि उनके पास कौन सी वैकेंसीज होती है। और लास्ट चीज होती है कि कुछ लोग जब वो जाते हैं वो जाके लोकल एजेंसीज के पास रजिस्टर करते हैं। लोकल एजेंसीज का फायदा आपको तब होता है कि जब आप थोड़ा आपके पास एक्सपीरियंस हो। मेजॉरिटी लोग जो यूके जाते हैं उनको सारे मशवरा ये देते हैं लोकल एजेंसी के पास रजिस्टर कर दो। तो लोकल एजेंसीज क्या होती है, ये आउटसाइड प्राइवेट एजेंसीज है। हॉस्पिटल्स प्राइमरीली वो अब रिलाय करते हैं, अपना एक बैंक स्टाफ उनका होता है जो पुराने ट्रेनिंग्स गुजर गए हुए हैं वहां से, उनका उन्होंने कॉन्टेक्ट नंबर्स रखे होते हैं अपने पास, उनको रजिस्टर किया होता है। जब कोई जरूरत होती है, जो कि आजकल बहुत ही होती है, अब रोज ही कोई ना कोई, और दूसरा सिकनेस बहुत ज्यादा है वहाँ पे, वो तो अच्छे भले हमसे 1/3 उम्र में यंग बच्चे, किसी को वो छींक भी आ जाए तो वो 4 दिन नहीं आता कि मैं बीमार हो गया। तो उसकी वजह से ये होता है कि ये फिर आपको रिलाय करना पड़ता है लोकल एजेंसीज पे। लोकल एजेंसीज फिर आपको सीरीज भेजती हैं, अगर आपने इनके साथ रजिस्टर किया हुआ है तो आपका सीवी उस हॉस्पिटल में वो भेज देंगे कि अगर उनको ज़रूरत है तो फिर वहाँ पे कोई जो भी कंसल्टेंट वगैरह है वो उसको रिव्यू करेगा, एंड इफ दे थिंक कि यू आर सुटेबल कैंडिडेट तो आपको वो लोकम ऑफर कर देंगे। लोकम शॉर्ट टर्म जॉब होती है, हो सकता है 1 दिन के लिए हो सकता है 4 दिन के लिए हो, 1 हफ्ते के लिए हो, कुछ है वो इवन आपको 2 महीना 3 महीने के लिए भी दे देती है। लेकिन मेरा अपना एक्सपीरियंस ये है कि चूंकि इस वक्त यूके में मेन प्रॉब्लम है कि सीनियर एक्सपीरियंस रजिस्ट्रार्स नहीं है। तो जब आप अप्लाई करते हैं अगर से एसएचओ लेवल के लिए, तो अगर मैं देख रहा हूँ और आपका यूके का एक्सपीरियंस ही नहीं है, तो अब मैं आपको उस जॉब के लिए जैसे हमारे नाइट आउट जो एसएचओ है वो ऑफसेट होगी। अब अगर आपने काम नहीं किया, वो लोकल एजेंसी ने मुझे भेज तो दिया, अगर आपके उसमें है ही नहीं कि आपने कभी किया, अनलेस कि हम रियली रियली डेस्परेट के पास एक बॉडी होनी चाहिए रात को वो कर सके या कोई काम या ना कर सके, बंदा हो वहाँ पे, तो then it would make sense. Otherwise, most of the people they don't go for those local agencies, so it's not very useful. अभी कल I asked one of the doctors वो जो मुल्तान से थी, वो मैंने हमारे पास क्लिनिकल अटैचमेंट की थी, तो वो आएगी तो आप उससे भी पूछ लीजिएगा उसका भी मोस्ट रिसेंट पिछले हफ्ते का एक्सपीरियंस क्या है। शी हैव बीन ट्राइंग, लेकिन वही बात है कि ये जीरो सोर्स है। बेस्ट सोर्स आपका ट्रस्ट वेबसाइट्स और हेल्थ जॉब्स यूके, ये जो है मेन है जिस पे आप रजिस्टर करें। और सबसे बड़ी बात होती है कि इस पे जब आप एक अप्लाई, जरूरी नहीं होता कि आपने अप्लाई कर दिया तो आपकी एप्लीकेशन उनके पास चली जाएगी। से आप एक क्लिक करते हैं, एक जगह वैकेंसी आई है, आपका एप्लीकेशन फॉर्म खुल जाता है, आप अपना एप्लीकेशन फॉर्म फिल करना स्टार्ट कर दें, फिल करके उसको सेव कर लें, बिकॉज एवरी टाइम यू गो एंड अप्लाई फॉर अ जॉब वो आपका फॉर्म वही होगा, यू कैन ऑलवेज मॉडिफाई दैट। और उसमें जो चीज आती है कि ये फॉर्म्स जितने होते हैं इनकी एक इलेक्ट्रॉनिक स्कोरिंग होती है। जब हम शॉर्ट लिस्टिंग कर रहे होते हैं तो से जीएमसी रजिस्ट्रेशन है तो उसके 2 मार्क्स हैं, पार्ट 1 किया हुआ है उसके 2 मार्क्स हैं, बेसिक एमबीबीएस के 2 मार्क्स हैं, तो ये 6 मार्क्स तो वो बेसिक के हो गए। उसके बाद कुछ चीजें आती हैं जिसमें वो आपसे जैसे आप पूछते हैं ऑडिट्स का, क्वालिटी इंप्रूवमेंट प्रोजेक्ट का, रिसर्च का, पब्लिकेशंस का, उसमें कुछ ना कुछ लिखे। अभी मैंने कुछ लोगों ने मुझे वहाँ अप्रोच किया कि वो एक खातून थी, वो इधर कराची की, इधर काम कर रही थी आयरलैंड में, वो सीपीएसपी के उस पे गई, वहाँ पे ये जो उनका एक्सचेंज प्रोग्राम है और यूके जॉब्स के लिए वो अप्लाई कर रही, तो उसने हमारे वहाँ पे अप्लाई किया। तो जब उसका मैंने एप्लीकेशन फॉर्म देखा तो उसमें वो ब्लैंक है बिल्कुल, रिसर्च में कुछ नहीं है, पब्लिकेशन में कुछ नहीं है, ऑडिट्स में कुछ नहीं है। अब वो एक्सपेक्ट उसकी ये कर रही है मुझसे कि मैं समहाउ उसको जॉब दे दूंगा। तो मैंने उससे बोला कि मैं कैसे ये कर सकता हूँ कि जब आपका उसमें आपने लिखा ही कुछ नहीं, तो उसमें मैं आपको एक बड़ा सा जीरो दे सकता हूँ सेगमेंट में, बिकॉज इट इज कंप्लीटली ब्लैंक। तो यू हैव टू राइट समथिंग। तो अगर आपको कुछ चीजें नहीं समझ आती तो आप डिस्कस करें। अभी रिसेंटली ये जो एफटीआई एप्लीकेशंस क्लोज हुई है उसमें भी एक इशू था कि मुझे किसी ने पूछा कि उसमें एक क्वेश्चन है, दे आर नॉट एबल टू अंडरस्टैंड कि उसमें लिखना क्या है। और उसमें एसेंशियली क्वेश्चन में वो जो पूछना चाह रहे थे वो ये पूछना चाह रहे थे कि आपको पता है अगर आप एमटीआई स्कीम पे आते हैं तो आपकी प्रोग्रेशन क्या होगी, और उसमें आपका वो जो ट्रेनिंग मैट्रिक्स है, दैट ट्रेनिंग मैट्रिक्स इज स्लाइटली डिफरेंट फॉर एमटीआईज, कि वो क्या होगा। जो आदमी यहाँ बैठा है उसको नहीं पता होगा। मुझे इसलिए पता था कि लास्ट ईयर में एमटीआईज का जो एनुअल रिव्यू था कॉम्पिटेंसी का उसमें मैं था, तो देन दे वर टॉकिंग अबाउट कि वी आर डेवलपिंग दैट, सो दैट वाज ब्रांड न्यू, और उन्होंने वो चीज उठा के इस साल के एप्लीकेशन फॉर्म में डाल दी। सो दैट्स लाइक एन इनसाइड सॉर्ट ऑफ स्टोरी जो फिर आपको वो पता चल जाती है कि उसको वो कैसे कर रहे हैं। तो बिफोर सबमिटिंग एनी एप्लीकेशन फॉर्म, please get a second opinion from somebody else to have a look at it, and then you can keep improving your these application forms. I think that's it. Yeah, लेकिन आपने तो MTI स्कीम अच्छा, राइट। तो उसके बाद हम आगे चलते हैं इस पे लिविंग एंड वर्किंग इन द यूके। ये भी शॉर्ट सा है उसमें। ये बेसिकली इफ यू वांट टू आस्क एनीथिंग प्लीज फील फ्री टू आस्क मी एनीथिंग अबाउट दिस थिंग, इज मोर लाइक वन टू वन सॉर्ट ऑफ। देखिए ये बहुत से लोगों को मैंने कहा है कि जब आप इवन MRCOG पार्ट 3 के लिए जाते हैं तो उस वक्त भी आपने अगर ऑडिट कभी नहीं किया और आपका ऑडिट का स्टेशन वो टास्क आ जाता है वहाँ पे, आप कैसे उसको डील करेंगे? मुझे याद है कि जब मैं अपना पार्ट 2 उस वक्त तो इकट्ठा होता था उसके लिए गया, ये अप्रेजल ऑडिट गाइडलाइन ये मुझे भी नहीं आती थी। मैं पाकिस्तान से नया नया गया हुआ था, 1.5-2 साल हुए थे। और मजे की बात है कि वो मेरा जब सर्किट स्टार्ट हुआ तो पहला ही जो था वो उसका आ गया ऑडिट का। और वो एक होता है ना आदमी के पसीने वही निकल जाते हैं, लो जी अब क्या होगा। इट वॉज़न्ट दैट बैड। मैं अंदर गया हूँ, एग्जामिनर ने मुझसे वो स्टार्ट किया कि तुम्हारे यूनिट में इन्फेक्शन रेट बहुत हाई हुआ है आफ्टर सिजेरियन सेक्शन and we want to see what are the reasons and how we can tackle that. So what are you going to do? So essentially audit का स्टेशन आ गया था, तो I just had to go through all the steps और वहां से वो मुझे ऑडिट से वो उस पे ले गया, वो जो दूसरा आता है उसके साथ, सॉरी नहीं, ऑडिट एंड प्रपोज नहीं, तो ऑडिट के साथ वो फिर आप गाइडलाइंस वगैरह डेवलप करते हैं ना, तो वो उसमें से उसकी रिकमेंडेशंस आएंगी कि हमने ऐसे करना है, तो दैट्स हाउ इट गोस। तो मैं लोगों को कहता था कि देखिए सिंपलेस्ट है कि आप एक 20 पेशेंट्स का खुद ऑडिट कर लें। ऑडिट आपने कैसे करना है? अब मसला ये कि हम लोगों को एक ही ऑडिट का पता है कि जी बैंक 31 नवंबर के दिसंबर को बंद होते हैं, आज इनका ऑडिट है, ठीक है। अब हमारा ऑडिट डिफरेंट है उनके साथ, तो उसमें ये है कि आप एक अपना फॉर्म डिवाइस करें, जैसे ये मैंने आपको बताया कि RCOG की वेबसाइट पे सिजेरियन सेक्शन कंसेंट फॉर्म, आप एक टॉपिक डिसाइड कर लेते हैं कि आई एम गोइंग टू डू एन ऑडिट ऑन कंप्लीशन ऑफ सिजेरियन सेक्शन कंसेंट फॉर्म्स। इसको आप प्रोस्पेक्टिव भी कर सकती हैं, रेट्रोस्पेक्टिव भी कर सकती हैं। आप प्रोस्पेक्टिव करना इसलिए इजी हो जाएगा कि अब आपको वो पुराने नोट्स निकालने पड़ेंगे। प्रोस्पेक्टिव में यह है कि आप एक फॉर्म बना लेती हैं, उस पर आप लिख देती हैं कि पेशेंट एज इतनी पेशेंट थी, उसका इलेक्टिव सिजेरियन था, इमरजेंसी सिजेरियन था, उसके बाद उसमें पेशेंट का ऊपर नाम, डेट ऑफ बर्थ, हॉस्पिटल नंबर लिखा हुआ था, नहीं लिखा हुआ था, किसी ने एब्रिविएशन यूज की थी क्योंकि हो सकता है वहाँ LSCS किसी ने लिख दिया हो। उसके बाद इवन ये भी है कि किसी ने नीचे साइन किया हुआ है उस फॉर्म को कि नहीं, क्योंकि मैंने देखा है कि मेरे कंसल्टेंट कलीग्स ने इंग्लैंड के अंदर सारा फॉर्म फिल किया हुआ है, पेशेंट वाला खाना ऊपर खाली पड़ा हुआ है, बीच में कुछ भरा हुआ है और नीचे अपने साइन भी नहीं किए। और वो आगे जो साथ रजिस्ट्रार था या SHO था वो भी चीखा निकला, उसने भी देखा कोई नहीं, उसी तरह उठा के पेशेंट के उसमें कर दिया। और वो जब पेशेंट सेक्शन के लिए आई है तो आप उसको अगर देख लें तो वो तो कंसेंट फॉर्म ही ब्लैंक है, सिवाय इसके कि उसमें जो बीच में 4 चीजें लिखी हुई हैं। तो आप उसको डिसाइड करके आप, इट्स वेरी सिंपल, उसमें कितना है कि आपने देखना है कि लोगों ने नाम पूरा लिखा, लेजिबल था, नहीं लेजिबल था, एब्रिविएशंस यूज की, नहीं की, उन्होंने लिखा व्हाट इज द बेनिफिट ऑफ सिजेरियन सेक्शन, what are the risks associated with cesarean section, what extra procedures can become necessary, ये चीजें लिखी या नहीं लिखी, that's all। अब आप करके 20 फॉर्म्स के उसके देखें, 20 में से आप देखती हैं कि अच्छा इनमें से 2 के ऊपर किसी ने वो पेशेंट डेमोग्राफिक्स कुछ नहीं लिखा हुआ था, स्टिकर नहीं लगा हुआ था, एक पे लोगों ने सारी एब्रिविएशंस यूज की थी, एक पे उन्होंने साइन किया हुआ, फिर उस पे ये आ जाता है कि उसमें किसी ने 10 पेशेंट्स को बताया कि बावल ब्लैडर इंजरी का चांस है, एक पेशेंट को बताया 1 in 200 रिस्क है इसका डिहेसेंस का, और थ्रोम्बोएम्बोलिज्म का 10 को नहीं बताया, इस तरह। तो वो जब आप उसको एनालाइज करना शुरू करेंगे कि एक्सेल शीट बना ले और उस पर वो डालती जाए 1 by 1, उसमें 20 पेशेंट्स के एंड में आपको पता चल जाएगा कि कितना किसने क्या किया, और उसको आप अपना एज अ यूज करें रिजल्ट्स उसके कि we found out we did audit on 20 patients from this date to this date. It was a prospective audit and we found out that 5 patients, they did not had their demographic details written over there, 2 patients they had abbreviations used, और इस तरह वो जो भी आपका ब्रेक डाउन आ जाएगा। एंड देन यू विल राइट डाउन उसके साथ जो आएगा आपका ऑडिट के रिजल्ट्स के बाद recommendations में आएगा कि that we should be doing completing the consent form legibly, writing out all the details, whatever आपके जो significant features हैं वो सारे उसके अंदर होने चाहिए। And then final recommendation आएगी re-audit after 1 year। तब ऑडिट साइकिल आपका क्लोज होता है, बिकॉज ऑडिट साइकिल ये नहीं है कि इस साल आपने कर लिया उसके बाद बाकी किसी को पता ही नहीं है। तो वो नॉर्मली तो यही होता है कि आपको अपने एप्लीकेशन फॉर्म के लिए जरूरत है तो आप थोड़ी सी तपस्या करके आप कहेंगे कि मैं कर लेता हूँ, बाद में आप कहेंगे कि मेरा तो काम हो गया अब मुझे क्या जरूरत है ऑडिट करने की। लेकिन इट्स अ वेरी सिंपल प्रोसेस, और एटलीस्ट एक दफा आप कर लें तो आपके उसमें एप्लीकेशन फॉर्म में फ्यूचर के लिए पड़ा रहेगा। बाकी ऑडिट जो प्रेजेंटेशंस एंड पब्लिकेशंस आती हैं उसमें आप ये देखिए कि आपका जो है ना, आपने कोई ऐसा अपना डिपार्टमेंट को क्वालिटी इंप्रूवमेंट प्रोजेक्ट किया, आपका एफसीपीएस का डिसर्टेशन इवन वो इसमें आ सकती है। तो समथिंग राइट समथिंग, उसको ब्लैंक ना छोड़े, ब्लैंक छोड़ के आई एम बाउंड लीगली बाउंड कि मैं आपको 0 दूंगा उसके लिए। जब मैं 0 दूंगा अब उसके बाद जब आपकी वो स्कोरिंग होगी वो कंप्यूटर ऑटोमेटिकली कैलकुलेट करके आपको अगर वो ऊपर से लेके बिल्कुल नीचे बॉटम पे ले जाए, अब मैं कितनी सिफारिश लगा लूँ, अगर मैं आपको ले भी लूँ कल को कोई और आ जाता है या आप आते कोई ऐसा इंसिडेंट हो जाता है तो लोग मुझे पूछेंगे कि तुमने इसको क्यों रखा। सो आई हैव टू जस्टिफाई, सो दैट्स व्हाई वो लोग दे डोंट बॉदर विद दैट। But this is something very useful for future. Be aware of that. Any questions related to that before I move on to the next one? जी, तो वो एग्जैक्टली और यही चीजें आई डोंट नो व्हाई दे हेजिटेट। उस पे ये है कि जैसे आप इन्हें कहें कि लेट्स डू completion of cesarean section consent forms.
I can tell you why the trainings are they are having difficulty there because there are no set standards. You know, for any audit, you need a set standard.
जी,
तो यहाँ के trainings को problem है, every hospital they got their own standards, जो कि valid नहीं है।
बिल्कुल।
कॉलेज
बिल्कुल। अब ये ना कि आप उसमें हो सकता है आपके अपने हॉस्पिटल में स्टैंडर्ड नहीं है, लेकिन आप यू आर थिंकिंग अहेड कि मैं कल अप्लाई करूंगी, इनवेरिएबली ये क्वेश्चन एप्लीकेशन फॉर्म में होगा। नहीं भी हो, जब आप इंटरव्यू के लिए जाते हैं, इंटरव्यू में 4 क्वेश्चन टिपिकली लोग पूछते हैं। अगर से मैं बैठा हूँ, मेरे साथ एक और कोई कलीग बैठ के वो इंटरव्यू कर रहा है, तो वो आइस ब्रेकिंग जो होता है वो क्वेश्चन होता है, ओके टेल अस अबाउट योरसेल्फ और टेक मी थ्रू योर सीवी, व्हाई आर यू अप्लाइंग टू दिस जॉब। तो उसमें एसेंशियली ये कि हम आपको थोड़ा सा रिलैक्स कर रहे हैं, आप बताते हैं कि मैं फलाना फलाना हूँ, मैंने ये किया हुआ है और इसलिए अप्लाई किया। दूसरा क्वेश्चन टिपिकली आता है डीलिंग विद एन इमरजेंसी, उसमें एक्लेम्पसिया भी हो सकता है, सीवियर प्रीक्लेम्पसिया भी हो सकता है, कार्ड प्रोलैप्स भी हो सकता है, पीपीएच भी हो सकता है, एनीथिंग लाइक दैट। एक तीसरा क्वेश्चन आता है क्वालिटी इंप्रूवमेंट इन ऑडिट्स पे, उस पे वो आपसे पूछेंगे हैव यू डन एनीथिंग दैट चेंज्ड द वर्किंग ऑफ योर डिपार्टमेंट, हाउ डिड इट हेल्प, और उसमें पेशेंट सेटिस्फेक्शन सर्वे आ सकता है, उसमें आपका ये ऑडिट आ सकता है। अब ऑडिट्स और इन चीजों के लिए चूंकि आपको एक स्टैंडर्ड चाहिए, बिकॉज ऑडिट में एसेंशियली what you are trying to do is compare your performance against that standard. Now, standard is much easy to set in a way that you can use RCOG, Royal College Guideline. So there is a Royal College guideline on cesarean section, different with 5-6 different guidelines है laparoscopy के लिए। तो आप उसे कहें कि this is my standard, इसमें रॉयल कॉलेज गाइडलाइन में वो कहते हैं कि आप ये चीजें बताएं। अब उसमें तो अगर आप रॉयल कॉलेज की गाइडलाइन पढ़े, उसमें लिखा हुआ डेथ भी, अब लेकिन डेथ कितने लोग बताते हैं, वही बात आ जाती है कि अगर वो लेस देन 1% रिस्क है तो आप बताएं या नहीं बताएं। लेकिन वो जिस तरह वो कहते हैं कि दूध का जला छाछ फूंक कर पीता है, जब मेरे साथ इंसिडेंट हुआ था वो जो नाइफ इंजरी लेसरेशन वाला था, तो उसके बाद मैंने स्टार्ट कर दिया था। अब मैं वो जरूर लिखता हूँ उसमें, इसलिए कि वो हो जाता है। तो डिस्पाइट एवरीथिंग, यस ब्रीच में ज्यादा कॉमन होता है, पहले मैं ब्रीच में लिखा करता था लेकिन मैं कफेलिक में नहीं लिखा करता था। अब especially when I'm going for a second stage cesarean section, तो उसमें I make it a point कि मैं या मेरा junior जिसने भी लिखा है ये चीजें लिखी है, because end of the day as a consultant then you have to take the responsibility for everything, so you have to double check. So it is easy, just use the Royal College guideline as a standard and then take it from there. अच्छा, तो चलें जी, आपने जॉब अप्लाई की, अब आपको जॉब मिल गई यूके में, ठीक है। तो अब आपने टिकट अपना कटाया और आप यूके पहुंच गए, ठीक है। यूके पहुंच गए, जाते ही बड़ा अच्छा लगता है जब आप ये देखते हैं, बाय द वे मेरी फोटोग्राफी है, तो बड़ा अच्छा आपको लंदन लगता है, हर चीज बड़ी ब्राइट। पहली बात तो ये है कि धूल नहीं नजर आती है आप 6-6 महीने भी जूते बगैर पॉलिश किए वहां पहन सकते हैं, कुछ नहीं होता। तो उसमें फिर ये होता है कि आपकी ये चॉइस होती है, जब आप यहाँ से तो है ना कि आपको होता है कोई जॉब मिल जाए, किसी कोने खतरे में मिल जाए। पहली जॉब मिल गई, आप महीना 2 महीने गुजारे, फिर आप कहते हैं कि मैं कहाँ किस गांव में किसी कोने में हूँ, तो किसी बेहतर जगह पे जाओ। अब कुछ लोगों में शौक होता है कि वो सेंट्रल लंदन में आके रहना चाहते हैं या मैनचेस्टर बड़े शहर में रहना चाहते हैं। अब आपकी अपनी, हर आदमी की अपनी फैमिली रीजंस हैं, सब कुछ है। कुछ लोगों को होता है कि मैं समुंदर के पास जाके रहूं। अब उसमें हमें फायदा ये आ जाता है कि ओवरऑल यूके ठंडा है, समर बहुत खूबसूरत होती है यूके, इट्स लाइक रियली वर्थ सीइंग। तो आप कहते हैं कि नहीं मैं तो सारी जिंदगी से मैंने किसी लाहौर में गुजारी, मैं तो समुंदर नहीं देखा, मुझे समुंदर के पास रहने का बड़ा शौक है। तो आप जाके कहीं ऐसे शहर में अप्लाई करते हैं जहाँ पे आपका जो सी साइड कोर्स है या कुछ है। फिर कुछ लोग होते हैं उन्हें हाइकिंग का और पहाड़ों पे चढ़ने का बड़ा शौक होता है, तो वो भी यहाँ पे जो है बहुत सारी ऐसी जगह हैं जहाँ पे आप वहाँ पे जॉब ले सकते हैं, वहाँ पे आपको ये आउटडोर एक्टिविटीज मिल जाती है। और कुछ होते हैं जो कहते हैं कि नहीं मुझे तो बर्फ बहुत अच्छी लगती है, तो वो जाके बर्फ वाले उसमें चले जाते हैं। ये अभी हमारे रिसेंटली 3 हफ्ते पहले बर्फ पड़ी थी। अभी स्कॉटलैंड वगैरह में जब आप जाते हैं तो स्कॉटलैंड में बर्फ बहुत पड़ती है, कॉस्ट ऑफ लिविंग कम होती है, स्कॉटलैंड में रहना सस्ता है, सब कुछ है, लेकिन आप क्या गुजारा कर सकते हैं जहाँ पे 4 महीने 5 महीने इस किस्म का मौसम हो, उसमें ड्राइविंग भी एक हैबिट बन जाती है। जिन लोगों को आदत नहीं होती तो फील वेरी अनकंफर्टेबल एंड हो सकता है कि आप कहें कि नहीं मुझे इस किस्म का मौसम पसंद नहीं है, तो आई डोंट वांट टू। तो ये एंड ऑफ द डे आपका डिसीजन आता है कि आपने किस जगह पे जाना है उसमें यूके में। और जब आप शुरू में जाते हैं तो पहले दिन तो आपने कुछ घूम फिर के गुजार लिया, गर्मियों में गए तो मौसम अच्छा लगा, और उसके बाद फिर होता ही है कि आप काम पे जाते हैं। जब आप काम पे जाते हैं तो यूके में जो सबसे आपको डिफरेंट चीज दिखती है वो आपको दिखती है डाइवर्सिटी। यहाँ पे तो है ना कि सारे एक जैसे ही होते हैं, तो इवन आपको पेशेंट कोई दूसरा नहीं नजर आता। मैं उसमें ये है कि फिर आपको डिफरेंट लोगों के साथ काम करना पड़ता है, डिफरेंट मुल्कों से लोग आए होते हैं तो उनके एटीट्यूड्स डिफरेंट होते हैं, और वहां पे फिर आपका मेन टेस्ट स्टार्ट होता है कि आपने कैसे उसको मैनेज करना है। स्लाइड फंस गई है। तो डाइवर्सिटी मेन चीज है। अब ये हमारा डिपार्टमेंट है, इसमें आप देखें कि कितने रंग के लोग हैं इसमें, और खासतौर पर ये डाइवर्सिटी जो है ना लंदन एरिया में बहुत ज्यादा है, और उसके फायदे भी हैं नुकसान भी हैं। फायदे सबसे ज्यादा ये होता है कि आप टॉलरेबल हो जाते हो उस सेटअप के अंदर। डिसएडवांटेज ये आ जाता है कि आपके लिए उस तरह अपॉर्चुनिटीज नहीं रहती कई दफा जब आपके सारे ब्राउन ब्राउन लोग आप जैसे हो उसमें। एक और फायदा ये भी आता है कि यूजुअली मैंने देखा है कि जो एनवायरनमेंट है दैट इज मच बेटर देन वर्किंग इन अ प्लेस वेयर एवरीवन इज वाइट। तो खासतौर पर जो टर्शरी सेंटर्स होते हैं वहाँ पे जब ये जितने गोरे होते हैं ना, तो वो आपको इंफीरियर समझते हैं, दे लुक थ्रू यू। दैट वाज वन ऑफ द रीजंस जब मैंने बहुत पहले टर्शरी सेंटर में काम किया लास्ट टाइम इस पे वुमेन्स हॉस्पिटल में, तो यू जस्ट फील ह्यूमिलिएटेड कि आपके वो जो गोरे बड़े बड़े नाम के कंसल्टेंट्स हैं, आपका नाम नहीं उनके ले रहा, दे जस्ट लुक थ्रू यू। वो एक वाइट मेडिकल स्टूडेंट से बात कर लेंगे और इवन यू आर देयर एज अ रजिस्ट्रार, दे वुड जस्ट इग्नोर यू। So that is one of the things which then matters. और उस पे ये होता है कि then आपका create progression उसके साथ आता है। हाँ, अगर कोई ऐसा उनमें अच्छा है, बड़े दिल वाला है जो आपके सर पे हाथ रख देता है, you can go places। लेकिन अगर वो नहीं है और वहाँ पे गोरे ज्यादा है, यूजुअली टर्शरी सेंटर्स में गोरे ज्यादा इकट्ठे हो जाते हैं, या लोकल ग्रेजुएट्स होंगे, तो they are like that, so you become a real second class citizen, and then I noticed that the progression is not that easy। और उसमें ये भी होता है कि कई दफा जब मैं गया था तो मुझे याद है कि मैंने सीवी दिखाया अपने कंसल्टेंट्स को, हाँ हाँ ठीक है सब सही है। जब मैं अपना ये एनुअल रिव्यू कॉम्पिटेंसी के लिए गया तो उसने मुझे कहा तुमने MRCOG किया हुआ है? मैंने कहा हाँ किया हुआ है। तुमने लिखा नहीं अपने सीवी में? मैंने कहा ये मेरे सीवी में ये लिखा हुआ है। तो ये तुम्हारा सीवी ये तुमने बनाया? मैंने कहा हाँ मैंने बनाया। तो तुमने कभी किसी को दिखाया नहीं है? मैंने कहा नहीं, मैंने अपने एजुकेशन सुपरवाइजर को दिखाया। तो उसने कहा सब ठीक है। तो वो कहते हैं इफ यू अप्लाई फॉर अ जॉब विद दिस सीवी आई विल नॉट इवन लुक एट इट, आई विल थ्रो इट इन द बिन। हाउ विल यू फील? आई मीन ये वो चीजें आती हैं व्हिच आर रियली हार्ट ब्रेकिंग। और देन यू थिंक यार मैंने दिखाया भी है किसी को, वो उस वक्त किसी ने बोला भी नहीं कि इसमें ये गलती है। तो दैट इज वन ऑफ द थिंग्स दैट सब नहीं इतना वो करते। आई थिंक जब आप एक डाइवर्स कल्चर में होते हो, पीपल आर मोर टॉलरेंट एंड प्रोबेबली दे लुक आफ्टर यू वेरी वेल। सो दैट्स व्हाट आई थिंक। अब हमारे इसी तरह के इंडियंस भी हैं, नाइजेरियंस भी हैं, श्रीलंकन भी हैं, गोरे भी हैं, स्पेनिश भी हैं, तो अरब्स भी हैं। तो वी फाइंड इट क्वाइट नाइस एक्चुअली। और ये बल्कि ये अभी हमारा ये वाली जो फोटो है रिसेंट क्रिसमस पे हम लोग एक छोटा सा वो लास्ट फ्राइडे इवनिंग करते होते हैं ट्रेनिंग्स को गिफ्ट्स वगैरह देने के लिए। तो वो कलेक्टिवली सब कंसल्टेंट्स की तरफ से होता है, डिपार्टमेंट की तरफ से, जस्ट टू थैंक देम फॉर देयर हार्ड वर्क। So we all get together for that, and that's how it looks like. अच्छा, तो सबसे पहले फिर आपको एक कल्चरल शॉक लगता है, और वो कल्चरल शॉक होता है काम का शॉक। एक होता है बिकॉज आपके वर्किंग आवर्स चेंज हो जाते हैं। अब आप सुबह 7:30 बजे 8 बजे वहाँ पहुंचे हुए हो और आप रात तक 5 बजे तक बैठे हो। वो जो इनिशियल आपको वो होती है कि आप 2 बजे घर आके 1:30 बजे घर आके जब वो 5 बजे तक काम पे बैठे हो, और खासतौर पर सर्दियों में 3:30 बजे अंधेरा होता है। तो रमजान बहुत अच्छा गुजरता है सर्दियों में, क्योंकि सुबह 6 बजे तक तो आपका वो होती है सहरी, और उसके बाद 3 बजे आप रोजा खोलो, विच इज नाइस। लेकिन वो नहीं, जब गर्मियाँ आती है तो गर्मियों में उलट हो जाता है कि सुबह 3 बजे 2:30 बजे आप रोजा स्टार्ट कर रहे हो और रात 10 बजे तक आप बैठे हुए हो। दैट बिकम्स रियली डिफिकल्ट एज वेल। तो दूसरा ये होता है कि एक आपका इंग्लिश लैंग्वेज का टेस्ट आना शुरू हो जाता है। अगर आप यूज्ड टू नहीं हो तो आपको वो इंग्लिश बोलनी पड़ती है। फिर आपको होम सिकनेस स्टार्ट हो जाती है। अगर आप अकेले गए हो तो फैमिली है तो चलो दैट्स स्टिल इजी टू मैनेज। तो आफ्टर कपल ऑफ डेज फिर वो जब आपको खाने पीने को कुछ नहीं मिलता। मेरे साथ एक मेरा फ्रेंड था कराची का, इज वेरी वेल नोन। तो वो हम मेरे ख्याल 1 महीना 2 महीना पहले वहाँ आया। तो फिर मुझे कहता है कि आओ मैं तुम्हें लंच कराता हूँ। मैंने कहा अच्छा, तो कहाँ पे? कहता है ये बाहर मेरे साथ जो हॉस्पिटल की अकोमोडेशन थी तो मैं वहीं रहता हूँ। तो मैंने कहा अच्छा चलो, ले गया। तो जाके उसने फ्रिज खोला, फ्रिज में से एक उसने वो जो टेस्को बोलते हैं ना सुपरमार्केट है, उसका वैल्यू पिज्जा वो निकाला, उसको ओवन में रख दिया। वो मार्गरीटा पिज्जा था, खाली उस पर वही था चीज थी, वो किया। उसके बाद उसने वो निकाला, उसके ऊपर एक अचार का पीस रखा। मुझे कहता है ये खाओ, ये लंच हो गया हमारा। तो वो इसलिए भी होता है कि कॉस्ट ऑफ लिविंग बहुत वहाँ पे हाई है। और उसमें अगर आप एक छोटे शहर में जैसे आप वेल्स में चले जाते हैं तो वेल्स में घर सस्ते हैं, अगर आप रेंट भी कर रहे हैं तो आपको 600-700 में पूरा घर जो कि 3-4 बेडरूम का, यहाँ की तरह तो नहीं है, सब छोटे होते हैं, लेकिन पूरा एक आपको घर मिल जाएगा जिसमें आपका अपना गार्डन है। अगर आप वही 600 में आप लंदन आते हैं तो लंदन में आपको एक स्टूडियो अपार्टमेंट भी उस पर नहीं मिलता। लंदन में जो मिनिमम भी स्टार्ट होते हैं दे आर लाइक 1200-1300, और दैट देन मेक्स अ डिफरेंस। कई लोग, अभी हमारे एक और खातून को मैंने जॉब ऑफर की, वो कनाडा से आ रही थी, तो उसने पहले मुझे कहा कि अच्छा ठीक है मैं आ जाती हूँ, उसने अप्लाई किया, देन शी चेंज हर माइंड, शी सेड कि आई लुक्ड एट इट, लंदन में घर बहुत एक्सपेंसिव है, मेरी 3 बेटियां हैं तो आई कांट मूव टू लंदन, तो वी विल गो टू स्कॉटलैंड। तो दैट सूटेड हर। एक और को इसी तरह जॉब ऑफर की, वो बर्मिंघम में स्टाफ ग्रेड काम कर रही थी, एंड एवरीथिंग वाज डन। हम 6 महीने उसका वेट किया, लास्ट मिनट पे व्हेन शी स्टार्टेड लुकिंग फॉर हाउसेस तो शी सेड कि यहाँ पे तो मुझे 1800 में 3 बेडरूम का अपार्टमेंट नहीं मुझे मिल रहा, और मेरे वही 2-3 बच्चे, तो आई नीड एटलीस्ट दिस मच स्पेस। सो दिस इज वन ऑफ द फैक्टर्स जो आपको मेन होता है फैक्टर इन करना है। कॉस्ट ऑफ लिविंग, आप जो पेरेंट्स हैं वो आपके साथ जा रहे हैं या आपको एक्स्ट्रा स्पेस चाहिए, बच्चे ज्यादा हैं, तो इट विल बी चीपर टू गो इनटू वेल्स और अप नॉर्थ। प्लस उसके बाद बच्चों की स्कूलिंग का आ जाता है। लंदन के स्कूल्स आर नॉट वेरी गुड हर जगह पे। कैंट जो है, कैंट इज अ वेरी नाइस प्लेस यूके में, कैंट के स्कूल्स आर वेरी नाइस, कैंट बाय इटसेल्फ इज वेरी पिक्चरेस्क एज वेल। लेकिन उस पे ये नहीं है कि लंदन में बिल्कुल स्कूल अच्छे नहीं हैं, लेकिन वो पॉकेट्स हैं, और वहाँ पे होता है जहाँ स्कूल अच्छे होते हैं आसपास के घर महंगे हो जाते हैं वहाँ पे, क्योंकि लोग वहाँ पे जाते हैं। फिर जब आप काम करते हैं तो आपको चाइल्ड केयर चाहिए होती है। अब चाइल्ड केयर जब आप करते हैं तो चाइल्ड केयर इज प्रीटी एक्सपेंसिव ओवर देयर। अगर तो आपके बच्चे बड़े हैं, स्कूल्स में वो मॉर्निंग क्लब्स होते हैं, आफ्टरनून क्लब्स होते हैं, वो आप 2 घंटे 3 घंटे बच्चे वो एक्स्ट्रा रखेंगे। अगर वो नहीं है, इफ यू हैव टू पे समबडी, तो वो लोग भी 14 से 15 पाउंड चार्ज करते हैं पर आवर, अगर कोई वो चाइल्ड माइंडर आके आपके बच्चे के पास बैठे तो। सैलरी वाइज जब आप स्टार्ट करते हैं तो मोस्टली जो लोग होंगे वो स्टार्ट करेंगे एट एसएचओ लेवल। नो मैटर आप कंसल्टेंट रहे हैं, स्पेशलिस्ट थे, इंडिपेंडेंट प्रैक्टिस कर रहे थे, लेकिन जब आप वहाँ पे जाएंगे मेजॉरिटी ऑफ एम्प्लॉयर्स दे वांट यू टू स्टार्ट एज एसएचओ। द मेन रीजन फॉर दैट इज कि ये नहीं है कि पीपल डोंट कंसिडर यू, इवन आपने एमआरसीओजी किया भी होगा, इट्स टू फेमिलियराइज विद दैट सिस्टम। Because if you are working as a registrar and then your SHO comes in और वो SHO आपसे आके पूछता है कि A&E में पेशेंट आया है, what should I do? Because SHOs में different types के SHOs होते हैं, उसमें ऑप्शन गायनी करियर ट्रेनिंग्स भी हो सकते हैं, उसमें GP ट्रेनिंग्स भी आते हैं जो 6 months के रोटेशन करते हैं, and then third cohort is these FY2s who are basically there for 4 months or so. Then if you don't know the system yourself, it will become really difficult. And then if somebody demotes you at that time that no, you cannot function as registrar, so you become SHO, then I think it's more demeaning rather than you start as SHO. Most of the people, they would say that okay, 3 से 4 महीने काम करो, if you settle down, you are comfortable with that, we will be happy to promote you to registrar. जब मैं यूके गया in 2002, वो उस वक्त ये MTI स्कीम जो अब है उसको उस वक्त कहते थे ओवरसीज डॉक्टर्स फेलोशिप ट्रेनिंग स्कीम, ODTF. Essentially it was similar sort of thing. It was much simpler, I would say, at that time. तो उस वक्त भी यही था कि आपका जब आप स्टार्ट करते हो तो सैलरी आपको वो रजिस्ट्रार की दे देंगे, लेकिन आपको कहेंगे कि फर्स्ट कपल ऑफ मंथ्स एसएचओ पे काम कर लो, देन यू विल प्रमोट, एंड आई थिंक इट्स अ फेयर डील, एक्चुअली इट्स मच बेटर। सैलरी वाइज जो एसएचओ जॉब्स हैं दे स्टार्ट विद अबाउट बेसिक सैलरी 35,000 पाउंड होती है, लेकिन उसके बाद वहाँ पे आपको सप्लीमेंट मिलता है नाइट ऑन कॉल्स वगैरह का। तो उसमें बैंडिंग आती है जब आप जॉब्स करते हो। अगर आप जितने छोटे हॉस्पिटल में काम करेंगे से एक जगह पे साल में 500 डिलीवरीज है और एक दूसरे हॉस्पिटल में 5000 डिलीवरीज है, तो आप इमेजिन कर सकते हैं कि 5000 डिलीवरीज वाले हॉस्पिटल में वर्कलोड विल बी मच हायर। सो वहां पे वो जो बैंडिंग होगी, जो एक्स्ट्रा सप्लीमेंट है, बैंडिंग इज बेसिकली एक्स्ट्रा सप्लीमेंट, it could be 50% of that 35%. So that means you add another almost 17,000-18,000 onto that. And so your salary will go to about almost 47,000-48,000. That would be like your starting salary. This is not your take home salary because then they will take tax on that. So tax at least 40% उस पे tax आपका कट जाता है. So in general it's still not bad, about 3000 के करीब आपको जो आपकी फर्स्ट जॉब होती है उसके अराउंड आ जाता है. तो मोस्ट ऑफ द पीपल दे कैन मैनेज. बड़े शहरों में प्रॉब्लम आता है कि आपको 3000 में या 3500 के करीब अगर आपकी बनती है तो यू हैव टू रेंट योर ओन प्लेस. छोटी जगह पे जाएंगे तो वहाँ पे हॉस्पिटल अकोमोडेशन होगी तो बट इट विल बी वेरी बेसिक. It's not fancy at all, very basic sort of accommodation. But still it is not bad because school education बच्चों की free होगी और आप कितना खा पी लेंगे, कितना आप सैर कर लेंगे, तो most of the people they can survive. I think that's one of the other questions a lot of people they ask कि मेरी salary कितनी होगी, starting salary, तो you can cope on that. फिर उसमें आता है आपकी religious needs. आप जाने को आप वेल्स में चले जाएं, वेल्स जाएं तो वहाँ पे ब्राउन नजर ही कोई नहीं आता. आपका बच्चा हो सकता है स्कूल में अकेला ब्राउन हो, और प्लस ये है कि हो सकता है वहाँ पे आपके पास कोई मस्जिद ना हो. और अगर आपको फिर इन चीज़ों का भी ख्याल है तो देन यू हैव टू थिंक ऑफ मोर कॉस्मोपॉलिटन टाइप सिटी. उसमें लंदन हो गया, बर्मिंघम, मैनचेस्टर. वैसे तो आप अल्लाह का शुक्र है इट्स नॉट दैट बैड. तकरीबन हर जगह पे ही कोई ना कोई मस्जिद वगैरह बनी हुई है और मुसलमान है काफ़ी हर जगह पे, और आपको हलाल खाने को कुछ ना कुछ मिल जाता है. लेकिन छोटे शहरों में इट इज़ रियली डिफिकल्ट बिकॉज मेरी पहली जॉब थी बेलफास्ट में, नॉर्दर्न आयरलैंड, और उस वक्त एक ही मस्जिद होती थी वहाँ पे और हलाल रेस्टोरेंट भी कोई नहीं था. तो वो फिर आप वो अपॉर्चुनिस्टिक वेजिटेरियन बन जाते हैं. कुछ अब मेरे साथ इजिप्शियंस थे तो वो कहते थे हम तो बिस्मिल्लाह पढ़ के सब खा लेते हैं. तो अब उसमें फिर वो प्रॉब्लम ये आ जाता है कि आपके अपने जो कलीग्स होते हैं नॉन मुस्लिम्स, वो फिर देखते हैं, वो कहते हैं अच्छा वो भी मुसलमान है, वो तो खा रहा है और तुम नहीं खा रहे. तो और आदत है ना, अब आप उस जस्टिफिकेशन में जाए कि वो क्यों खा रहा है और मैं क्यों नहीं खा रहा, कहते हैं मैं वेजिटेरियन. तो यू डोंट लूज एनीथिंग बाय दैट, तो यू कैन मैनेज. तो उसमें बाकी ये है कि वो कहते हैं कि यूके में जब आप काम करते हैं किसी भी नॉन मुस्लिम कंट्री में तो ना करते हैं आप आधा खंजीर खाई जाते हैं. और वो होता ही है कि टाइम आपको पता नहीं होता. अब आप देखते भी हैं तो अगर आपको इंग्रेडिएंट्स का नहीं पता फिर आप उसको नहीं करें. मैं शुरू में गया, एक चीज़ होती है इनकी बड़ी ट्रेडिशनल क्रिसमस की मिन्स पाई उसे बोलते हैं. मैंने शुरू में कुछ 5-6 साल मिन्स पाई को हाथ नहीं लगाया. अच्छा, मिन्स मेरे दिमाग में आता था कीमा. तो वो वहां पे ना क्रिसमस के अराउंड आती है, हर जगह वो पड़ी होती थी. तो मैंने देखा लोगों ने कहना मिन्स पाई खाओ, नहीं मैंने नहीं खाना. एक तो मैंने कहा कि नहीं मैं ये हलाल नहीं है. तो मुझे उसने नर्स ने बोला, उसने कहा इसमें हलाल हराम की क्या चीज है. मैंने कहा इसमें मीट है. तो उसने कहा इसमें मीट तो नहीं है. तो मैंने कहा इसमें फिर क्या है. तो मैंने तो कभी खोल के भी उसको नहीं देखा. मैं तुम्हें दिखाती हूँ. तो खोल के दिखाया, उसमें वो ड्राई फ्रूट होता है, मीठी सी वो चटनी सी होती है, उसको वो बना के वो करते हैं. एक जमाने में वो मीट डाला करते थे लेकिन अब नहीं उठाते. तो देन आई केम टू नो कि मिन्स पाई इज नॉट लाइक मिन्स मिस. तो वो है. बाकी है कि ये जैसे आती हैं चीजें आपकी क्या कहते हैं इसको, मार्शमेलोज वगैरह, उनमें जेलेटिन होता है. तो जेलेटिन फिर वो कई वो बीफ जेलेटिन भी आता है, पोर्क भी आता है, वेजिटेरियन सोर्स भी उसका होता है. तो यू कैन लुक फॉर दो सॉर्ट ऑफ थिंग्स. तो सबसे पहले जब आप जाते हैं ना तो आपको एक मोबाइल सिम की जरूरत होती है. अभी हमारा एक एमपी आया नाइजीरिया से. उसको जब हमने इंटरव्यू किया लास्ट ईयर तो उस वक्त बड़ा कॉन्फिडेंट लगा. वो जो कहते हैं ना कि वो सही आके वो गवाची गांव की तरफ फैला था. उसको बिल्कुल वो तो लगे हवाइयाँ उड़ी हुई हैं, उसको समझ ही कुछ नहीं आती थी। तो लोगों को फिक्र पड़ गई कि ये वही बंदा है जिसको हमने इंटरव्यू किया था, कोई और आ गया। तो इट डज हिट यू। और इवन मैं, इफ आई लुक बैक, जब मैं गया था तो फॉर मी इट वाजंट दैट डिफिकल्ट, बिकॉज मैं पार्ट 1 करने यूके गया, आई स्टेड देयर फॉर अबाउट 1.5 year और सो। उसके बाद जब मैं यूके गया, उस वक्त हम मेरी वाइफ कर रही थी रेजिडेंसी अमेरिका में, तो आई वेंट फ्रॉम यूएस, और आई वाज एट लीस्ट कल्चरली वो जो था expecting what to expect basically, but otherwise I've seen people, they are completely lost, खाना पीना उनका खत्म हो जाता है, they don't know। मेरे साथ एक इंडियन था, वो कहता है मैं तो मसाला चाय पीता हूँ, तो वहाँ मसाला चाय कहाँ पे उसको दे, तो वो फिर वो कप लेके उसमें 2 टी बैग डाल के, दूध डाल के, उसके बाद उसमें अपना ये सिनेमन स्टिक्स डाल के उसको करता था माइक्रोवेव में, मतलब उबाल उबाल काट काट के उसके बाद वो पीता था। तो पीपल जस्ट फाइंड अ वे टू डू दैट। लेकिन ये कि जब एटलीस्ट आपके पास आप कनेक्ट हो जाते हैं और आप मोबाइल हो जाते हैं, इट डज हेल्प यू अ लॉट। बिकॉज जब आपके पास ड्राइविंग लाइसेंस नहीं है, आपके पास गाड़ी नहीं है, यू स्ट्रगल, देन यू कांट गो एनीवेयर। एंड देन अभी तो ये है कि बड़े शहरों में आपको पब्लिक ट्रांसपोर्ट सिस्टम इज वेरी गुड, यू डोंट रियली नीड अ कार। लेकिन अगर आप छोटी जगह पे हैं, देन इट इज अ प्रॉब्लम। ऑल्सो छोटे शहरों में ये होता है कि उनके कम्युनिटी हॉस्पिटल्स, सैटेलाइट क्लिनिक्स होते हैं, then you have to rely on somebody else to take you over there, or you have to take a taxi and go for that. तो ये वो issues आ जाते हैं, and then you have to look for a place to rent, और rents का मैंने आपको बता दिया। फिर इसी तरह school admissions का है, and you have to find a place nearer to the good schools as well, and then you need time for acclimatization. Most of the units, they are very considerate. You join and then nobody would expect that you would start working immediately. First week तो आपका honeymoon period होता है, उसमें वो कहते हैं अपना बैंक अकाउंट खोलो, जाओ अपना फोन लो, सॉर्ट आउट करो, you get paid for it, but we are not doing anything. So gradually then people start putting you in the clinic. ये जो हमारा entry आया था, we gave him almost like over a month, 1.5 months, and then we had to put him on the rota gradually. So then once you are thrown in deep water, थोड़े दिन आपको मुश्किल लगता है. Usually somebody will pair you up with somebody else and you settle down with that. And then a stage comes that some people, they don't want to go back and they want to carry on with that. MTI में यही होता है कि once you have done MTI, then options will be you can find a job आपको मिल जाएगी, because by that time you might have done your MRCOG, you have become experienced now in a way that 2 years आपने NHS में काम कर लिया, then a lot of doors they will open for you. Finding a job like that, वो आपको मिल जाएगा, because everybody wants experienced people, and then you decide where you want to go. And then single लोग हैं, they हमारे साथ कुछ थे इसी तरह MTIs आए, now they want to go and work in St. Thomas's in central London, and they are happy to rent a place over there and they can do that. So then you can just get into that system, and then once you get that work permit, then that time gets the clock starts counting towards your permanent residency if you want to stay. If not, you can go back. श्रीलंकन से श्रीलंकन बहुत आते हैं। श्रीलंका का ये है कि उनका जो कॉलेज ऑफ फिजिशियन सर्जन्स है, they have an agreement with General Medical Council. They cannot do their postgrad exam in Ops and Gynae unless they have worked in UK for a year. So they come on that exchange one, they get exemption from plan, and that's what they do. But then they sign a form that they are going to go back, and because they cannot do the Sri Lankan board unless they go back and then go through that exam. So most of them, they come, they spend a year, and then they go back. So it's usually Indians, Pakistanis, Nigerians who tend to stay. और अब ये है कि a lot of people are doing MRCOG, so it's much easier. A lot of them, they are moving from Middle East. They want to come over there. Any questions about this? हाँ बाबा सेटल हो गया बाबा खुश बस
आपने जैसे अपना मिर्च पाई का सुनाया ना तो मेरा चिली कॉर्न करने का तो मुझे आई तो चिली कॉर्न करने में बीफ होता है तो भून भून कर तब मुझे नॉटिंघम में केले खाते हुए और बीज के साथ ब्रेड खाते हुए 3 हफ्ते हो चुके थे मुझे लगता था कि कुछ भी मुझे मिले जो मैं खा जाऊँ तो मुझे ये चिली कॉर्न करने आइडेंटिफाई किया मैंने और जब मैं आपको से बड़े शौक से खाई गई तो समझ टोल्ड मी कि इसमें बीफ होता है
अभी हम क्लास स्पेंसर के ऐसे जो मिक्स मिलते हैं हर कॉन्फ्रेंस में दे आर नॉट अलाउड उसमें जेलेटिन होती है
So let's go for lunch. हमारे साथ दरअसल लंच करना है then I will see you there.
Zoom session.